Good morning, everyone, and welcome to the Board of Registered Nursing Board meeting. It is May 24th, 2024, and we will take roll call to establish a quorum. My name is Dolores Trujillo. I am an RN, and I have been appointed by Governor Newsom to serve in the direct care provider role, and I am the current president of the board. Vice President Mary Fagan.
Good morning, everyone. My name is Mary Fagan. I'm the Vice President. I am serving in the Nursing Services Administration role, and I was appointed by Governor Newsom.
Thank you, Mary. Board Member Jovita Dominguez.
Good morning, Jovita Dominguez. I was elected by Governor Newsom, and I chair the Education and Licensing. Thank you.
Thank you, Jovita. Board Member Patricia Nguyen.
Good morning, everyone. I'm Tricia Nguyen. I was appointed by Governor Newsom into a public member role.
Thank you, Tricia. Board Member David Lawler.
Good morning. My name is David Lawler. I was also appointed by Governor Newsom into the public member role.
Thank you, David. Board Member Vicki Granowitz.
Vicki Granowitz, I was appointed by Senator Tony Atkins as a public member.
Thank you, Vicki. Board Member Neelu Patel.
Neelu Patel, I was appointed by Governor Newsom into the advanced practice role.
Thank you, Neelu. And Board Member Allison Cormack.
Good morning. My name is Allison Cormack. I was appointed as a member of the public by the Speaker of the Assembly.
Thank you. Our quorum has been established for today's meeting. We will move on to item 9.0, where we left off yesterday. This is information only. 9.3. Is this Shannon?
Hi. So this is item 9.3 is a discussion and possible action regarding working as a registered nurse in a position requiring patient care with or without narcotic access prior to a successful completion of the intervention program.
Sorry, Tricia, this is Reza. I think, are we going to start with 9 point, that's
Oh,
9.3.1
I'm
that
very
you read
sorry.
off.
I'm very sorry. Yeah,
9.3 contains a presentation.
I'm very sorry.
That-
You're right.
that's
Thank you. And Shan, okay, so this is presentation of the intervention program, contracted program vendor, general requirements, legislation, regulations, and the uniform standards governing the IP, recovery agreements, IEC member appointment terms, responsibilities and training, and the difference between IP and probation, et cetera. And Shannon Johnson, who heads our enforcement, will be presenting on this. Thank you.
Hang on just one moment. I may have our IT run our video. Can we hold just one moment?
Yes?
And just while we're waiting, the item that Tricia had mentioned regarding working in a position with or without narcotic access will be coming after these presentations and that discussion.
Thank you.
Yeah. Jen has the PowerPoint. Mhm. Sorry about that. A little technical difficulty on my side. There we go. So 9.3 9.3, 9.3.2. So again, hi, I'm Shannon Johnson. I'm the board's enforcement division chief, and I'll be presenting 9.3 through 9.3.2. Just a note going through the slides that the statute, regulation, and uniform standards pertaining to the discussion points today will be notated at the bottom of each of the slides throughout the presentation for your reference. So from the last board meeting, there was some public comment about concerns regarding the intervention program. We were asked by the board to bring the discussion points to this board meeting for further discussion. The board also requested that the current intervention program vendor, Maximus, provide the board with a presentation on Maximus regarding services they provide for the board's intervention program. So we'll first have a presentation from Virginia Matthews, the Maximus Program Director for the board's intervention program, and she'll be providing the board with an overview of Maximus. I'll then be covering statute, regulation, uniform standards that are applicable to each of the discussion points today regarding IEC members, appointments, term limits, responsibilities, and training. The difference, between probation and the intervention program was also a topic brought in public comment from the last board meeting. And so I would like to clarify some of those differences for you today. In 9.3.1, I'll be discussing Uniform Standard 11 and how that plays a role in the program regarding not only returning the nurse to practice, but also the capacity in which they return and what would be required for successful completion of the program. 9.3.2 will be clinical diagnostic evaluation and reassessments, which is defined in Uniform Standard number 2, including the criteria for an assessor. So without further ado, I'll go ahead and introduce Virginia Matthews. She's with me today from Maximus, and she will be presenting her PowerPoint on Maximus and their services. So if we could switch to that PowerPoint, please.
And I'll be a little bit distracted as I watch the screen because I don't have it in front of me. Good morning. Thank you for having me here today. I also am often referred to as Ginny, so please feel free to call me Ginny because I don't respond to Virginia very well. Unless you're mad at me. Go ahead and go to the next slide. Go ahead and advance. Okay, so we're going to talk about a high-level presentation of the program and what we do. We're talking about the mission, the boards, and Maximus overall, and the process of the program, and then just kind of an overview of the program and all of the processes and how we proceed through the program. So go ahead, next slide. The mission of the recovery program from the bigger picture mirrors that of the board, which is protection of the public. And then we do that through returning the healthcare professionals to safe clinical practice through intervention and rehabilitation. And that's through the legislation that created this program back in the mid-'80s. And that's what's stated in the statute that created the program. Go ahead and advance. We work with 8 healthcare licensing boards through a single contract through the Department of Consumer Affairs. And each of the individual licensing boards has one general section of the contract, and then each board has a board-specific section so that the boards are able to specify for themselves what they want related to each of those general sections, what they'd like handled individually for their board. For example, an example that comes immediately to mind is the dental board. When the dentist can't immediately leave practice because it would endanger their patients, they have a brief period of time in their contract before they must cease practice when they come into the program. So that's written into the contract. So those specifics are all, each individual item in the contract is written in for the boards specifically. So we work with these 8 boards that are on the screen. The Board of Registered Nursing is the largest of the boards that we work with. They make up about 75% of the participants that we work with. So right now we have just under 300 participants enrolled in the program. And it's about 290, I think it's 297 today. So it's just under 300. And of that, right around 250 are nurses enrolled in our program. And the other boards make up a much smaller contingent. You can go ahead and proceed. So the monitoring program process is complex and involved, and we have teams of case managers and compliance monitors that work with the assignments for our participants, and they're assigned to work with approximately 80 to 100 participants per team. So a case manager and compliance monitor together are assigned to work with the participants, and they manage different components of the case. We are by contract permitted to work with up to 130 participants per team. But we're not working with that high of a number because our enrollment is as low as it is. So we're responsible for education and outreach. We work with hospitals, networking organizations, other facilities. We'll go out anywhere that we're asked to come and speak. And we'll make efforts to reach out to different organizations, or if we hear from an organization that's having a struggle with what to do with their participants will, or their employees will offer to come and speak to them. And we don't charge for that. We'll coordinate with the board and work on doing an organization. The presentation is about an hour and a half, 2 hours, because we go through not only the disease of addiction, substance use disorder, before we go into more specifics about the program and intervention and probation. So we talk about kind of the whole package. We manage an intake, interview, and case management of the case overall. We provide support to our participants. We provide referral to treatment or suggestions for treatment. We have to be careful not to provide specific referrals. We don't want to get into a conflict of interest, but we work with the SAMHSA list of provided treatment services, and we have a list of some do not use treatment programs that we've run into problems with. But for the most part, if it's SAMHSA approved, we'll work with the list of treatment providers where the participants can afford to go to treatment, what's available to them, and then we provide oversight of those treatment services. We'll schedule the clinical diagnostic evaluation or the clinical assessment. We provide post-treatment monitoring, so when they're released from treatment, we'll then continue monitoring the participants. That is really what becomes the most effective component for their recovery and prevention of relapse. We know that that's through studies that have been done related to the work that we do, is the most effective component of what we do for recovery, because that post-treatment monitoring is what keeps people from relapsing. It helps to support them. Drug testing, we'll go into that in a later slide. Support groups, 12-step community support groups, which are different from the peer support groups that we provide. Worksite monitoring, and we require our participants to check in with their case manager at Maximus at a minimum monthly, and more frequently if the committee or the board decides that it's more important for them to check in more frequently than that. Next slide. So we're going to give you a little bit more specific information on the overview. So the criteria for admission into the program is in the regs. The registered nurse must be licensed and residing in California. The statute says that it can be, that this program is designed for mentally ill or substance abusing, a nurse who abuses alcohol or drugs in a manner which may affect their ability to practice safely. So that's defined for us. It is a voluntary program, so they must voluntarily request admission into the program. They must agree to undergo medical and/or psychiatric exams. So that is one of the requirements for admission and continued participation in the program. They must agree to provide us with medical information, disclosure authorizations, and release of liability. Comply with all elements of the program. So we have a compliance, non-compliance process that we track, and that's what our compliance monitors do for us, is an in-depth process where they monitor compliance. They cannot have had their RN license disciplined for substance abuse, mental health by us or another state. So we monitor for that, and that they've not been terminated from this or any other intervention program. So if they've been closed by our program previously as non-compliant or a public risk, they're not eligible to come back into our program. And that's true if they've been closed in another state as well. Next slide. Next slide. Are we stuck? Oh, there we go. Criteria to deny intake or admission into the program is if they don't meet any of those admission requirements, if they've violated a provision of law regarding the practice of nursing. So That's excluding drug-related violations, which is a separate point. If they've diverted controlled substances for sale, and it's a very specific issue. And if the Intervention Evaluation Committee determines the applicant will not benefit from the program, that the applicant's participation creates too great of a risk to the public health and safety and welfare. So that's a determination that's made by looking at the case history and all of the details surrounding the cases provided to us by the participant and by the investigation. Go ahead and advance. The clinical diagnostic evaluation, sometimes I may refer to it as a clinical assessment. That's the language in the contract, so you may hear me talk about it both ways. That's the process that we use. Once the intake interview is completed by our case manager, which is a telephonic interview that the case manager does when the participant comes into the program, Maximus schedules the clinical diagnostic evaluation, which is by order of the board. That's contractually required. Once the evaluation is completed, it's provided back to the board through our documentation process, so that the board and the Intervention Evaluation Committee has real-time access in live access to all of our documents so that they can look at them as they're entered into the system. If there's a diagnosis of substance use disorder or a mental health condition, the program director, who's myself, and a physician or nurse consultant can make a recommendation of program eligibility. Maximus schedules the committee to review the recommendations for acceptance into the program so that the participant then is scheduled for their first IEC committee meeting as soon as we can get them on the schedule. Typically, they're scheduled for a committee close to a location where they live, because in the past they had been scheduled for committee meetings where they went in person. Right now, they're attending by Zoom. So we have a little bit more flexibility. I'm sorry, by Teams, but we have a little more flexibility for getting them on the schedule quickly. And the IEC makes a recommendation for the recovery agreement to the program manager and makes a recommendation for acceptance into the program. Next slide. So the recovery agreements, each participant is required to sign a recovery agreement, which is recommended by the Intervention Evaluation Committee and reviewed by the board. Those are the specific requirements that the participant must follow. And they must follow them throughout the participation in the program in order to successfully complete the program. The recovery agreement is reviewed by the committee anytime the participant is seen by the committee or their case is reviewed, and the committee will review their progression or whether they're not following or not progressing in the program, and looks at their demonstrated recovery. So changes are made to the recovery agreement depending on how the participant's doing in the program. I don't mean to be ignoring this side of the room. I have to look over here. Sorry. So treatment, Maximus is not a treatment provider, and that's often a mistake that people make, and make that clear that we don't provide the treatment. The case managers provide monitoring of the treatment. So we're case managers and provide oversight and overall coordination of the case, but don't provide treatment itself. That's the reason our case managers are clinicians, is that they need to be familiar with treatment and what's required, and they're able to monitor the progress and understand the process of recovery. Whether it's substance use disorder or mental health, they need to be able to understand what to look for in recovery. Recommended levels of treatment may include, and not limited to, but this is what we see most often, inpatient residential. Most participants coming into our program go into an intensive outpatient program initially. Many of them, when they come into our program, have completed some form of treatment before they get to us, and so we'll have considered that as well. Partial hospitalization, aftercare, now referred to as continuing care in the community or in the healthcare industry. Outpatient therapy at all different levels of individual outpatient, group therapy, and sober living environments. So we have a few participants in our program that have either voluntarily or at the recommendation of the committee gone into a sober living environment for a period of time, which has been very effective for them. Next slide. Group support, there are two different types of groups that our participants engage in. One is the nurse support groups, which are facilitated groups. In the case of the nurses, they're facilitated by other nurses who have, in most cases, graduated from our program or have experience working in recovery or in substance use disorder, or have are in recovery themselves. Many of them have graduated from the program. And then the other type of groups that our participants participate in are the community support groups. Many cases, it's 12-step. We can't require 12-step because there are some regulations that state that laws that went into effect a few years ago that say that if someone has an objection to the religious nature of a 12-step meeting, that they can have an option not to specifically participate in 12 steps. So we can assist participants in finding other types of groups that are not specifically 12-step. And so we'll work with them to look at other things. And when they're mental health participants, we help them find mental health related groups. So there are other types of groups that are specific to depression, thought disorders, anxiety. So there are other mental health related groups as well, NAMI. So back to specifically nurse support groups, the board and the intervention committee have criteria for determining attendance. This comes out of the uniform standards as well. Looking at the history of the case, their length of sobriety since their last substance use, their recommendation of the clinical evaluator and what would be most appropriate for them, their scope and pattern of use, what drugs they've used, what their case history has been, the individual's treatment history, and the nature, duration, and severity of their substance use. And that's all very important in looking at what would be most appropriate for that participant's appropriate group process. Nurse support group facilitators report to us any unexcused absence within 24 hours. And they also have a way to report directly into our documentation system, monthly reports to Maximus. So it's a confidential process, and they're able to submit their reports to us monthly directly into the system. And participants are responsible for submitting their own reports, their evidence of attending their 12-step or community support groups. And so they report that to us themselves, and they also report directly into the system, again, confidentially. Next slide. Random drug testing. We have an extensive drug testing process. We've worked over the years with our drug testing vendor. I think yesterday, Ms. Melber mentioned that we've held the contract for a long time. Maximus has held this contract since 2003. We've worked with this vendor since 2009. So we've, over the years, developed an extensive panel. Much of it came from the DCA over the years, and then has evolved to be most appropriate for the types of drugs that we see. For example, as Kratom became more available and more frequently used in the community, we added it as an available drug to be tested on our panels. So we have a flexible and varied drug testing options. We are able to test with urine, saliva, hair, blood, breath, sweat, and SoberLink, which is a breathalyzer kind of mechanism. The participants required to check in daily with the vendor. They can check in by web or mobile app, and we're notified of a missed check-in. And so we follow up with that immediately. Required testing is on the day that they're selected, and we're including weekends and holidays. That's a uniform standard requirement. And they're, as I mentioned, we have extensive test panels. They actually, in other parts of the country, refer to it as the California panel, and some states have copied it. So the lab has offered it out to other states where they had contracts because it's an extensive and low cutoffs and sensitive test panel. We work closely with the medical review officer, who's a physician, to analyze the test results promptly. So every test that comes back positive is reviewed by the medical review officer. And we maintain our own internal ongoing quality control QA review of test results and processes so that if anything comes back that would trigger, we have a process to review, so that triggers an automatic review of if the test panel isn't the correct panel, or if there's any result that doesn't fit the cutoff, it triggers a quick review for us. And so we go in and relate that back to the vendor and follow up on that. So that's kind of the high overview of the drug testing. The return to work process is before being returned to work, the participants must just show us that they're ready to return to work. And so they have to do a self-report of their progress. We ask them to do an essay that talks about what happened to them before in the workplace and what kinds of triggers did they face, what was their history, what was their support system, and what's changed. So why are they ready now? And to create a relapse prevention plan. So if they face those triggers in the workplace now as they're getting ready to go back to work, how are they prepared to deal with that now going back? And then the board and the intervention committee, evaluation committee evaluate that readiness. So they consider that essay, they consider their compliance overall. They look at drug test results. The uniform standards require at least 30 days of negative tests in one place, but in another place require 60 days of negative tests to return to work. So we take those both into consideration. That's just one of the pieces in the uniform standards. We look at the recommendations from the clinical diagnostic evaluation, and we look at their individual plan for each participant. Might require part-time work before returning to full work privileges. So each case is individual. Go ahead. The participant must identify a worksite monitor and submit that person to Maximus. There are specific requirements for worksite monitors. And they have to, I think Shannon's going to go into more specifics about what's required of a worksite monitor. No?
Not in today's.
Not today's. Oh, that was in a previous
No,
presentation.
that was in a previous presentation, but it's
Okay.
within uniform standards.
Okay, so the requirements for a worksite monitor are spelled out in the uniform standards. But within those requirements, we require a release of information consent form and a signed attestation from the worksite monitor that they understand those requirements and they meet those requirements. We get a release of information from the participant to also speak to the employer. We require an organizational chart from the employer to demonstrate that the worksite monitor is at least one step above the worksite monitor is one step above the participant on the org chart. And we look for a job description to show that the participant will be working within their restrictions that have been set by the IEC. We provide education to the worksite monitor on the monitoring requirements in the workplace and how to submit reports, how to report to us within 24 hours if there's any concern of performance, any signs of relapse, or anything that they ever want to talk to us about or any questions. So that's part of our education to them, and they know how to come back to us. We also have on our website, on our outward-facing website, a video that they can refer to in a page for employers. So they can always go back to that and see how to come back to us and report to us. Next slide. For contact and reporting, we have a toll-free number with 24 hours a day access. So we have a case manager on call 24 hours a day, 7 days a week, including holidays, and the participants know that, and we keep them informed of that, including on the holidays. Typically, the questions we get on those on-call questions are related to drug testing, but we're there for them around the clock. Participants are required to submit monthly self-reports and document their community support group meetings. So they have access to their portal, but they don't have access to read reports or any of the documentation that's in the portal. They have submission-only access. Participants can call regularly for check-ins with their case manager. I mentioned that earlier. Case managers and compliance monitors can review all of the reports that are coming in. They all come in real time. And we provide outgoing reports, statistical data to the boards on a monthly basis. Next slide. And for completion, the length of time in the recovery program varies by individual case. It also depends on the history of substance use, the diagnosis, sustained program compliance. The uniform standards require at least 3 to 5 years of documented continuous sobriety and ability to practice safely through satisfactory program participation and compliance. So the minimum requirement in the uniform standard is 3 to 5 years of documented sobriety. And I think that's my last slide. Yeah.
We could go ahead and go back to, excuse me, we could go ahead and go back to the original presentation. We should be on the slide, intervention evaluation committees. Next. There we go. Okay, so again, Shannon Johnson, the board's enforcement division chief. And so we're going to go ahead and continue on with agenda item 9.3 and discussing next the intervention evaluation committees. I just want to also mention again that if there's any topic that comes up, because I'm specifically touching on or bringing for the board the concerns and questions that came up from the last board meeting. So if there's any specifics that we're not touching on today that you would like to see in a future board meeting, you know, we can, I'm more than happy to come back and touch on those specific items at the next board meeting. Next. Okay, so in the previous public comment during the last board meeting, it was stated that the intervention evaluation committees make decisions independently from the board. So I shared the following slides previously, but I wanted to go over them again with you for just for clarification of that statement. So first, the committee's composition is dictated by Business and Professions Code 2770.2. Each committee consists of 3 RNs, 1 physician, 1 public member. The RNs will need to have demonstrated expertise in the field of chemical dependency or psychiatric nursing. The physicians must hold an active license specializing in the diagnosis and treatment of addictive disease and mental illness. The public member needs to have knowledge in the field of chemical dependency or mental illness. Next. The committee members have the responsibility to evaluate have the responsibility to evaluate the nurses that request participation into the program according to the guidelines that are prescribed by the board. They're also required to review and designate treatment services needed for recovery, including but not limited to the inpatient treatment, intensive outpatient treatment for rehabilitation. They are also to consider in the cases of each nurse whether or not the nurse can resume the practice of nursing. The committee needs to call meetings as necessary to consider the reports of the RNs. They need to make recommendations to the board's program manager regarding the terms and conditions of the intervention agreement for each registered nurse participating in the program. And this includes treatment, supervision, monitoring requirements, et cetera. So based on what Ginny had just previously provided you, when we have the diagnostic evaluations and all of those things, that goes to the committee. And that's the committee's responsibility to make those recommendations based off all that initial information. The role is to ensure the appropriate recovery plan is in place for each individual RN at all stages through their participation in the program. And the committee, they do have the authority to accept a participant into the program without having to make a recommendation to the board. That's the one authority that they do have. Okay, term limits, very similar to the board. They can serve 2 consecutive 4-year term limits. That's in BMP Code Section 131. And also, just like the board, they can have the 1-year period once the term expires for that overlap of appointment. Next. So I want to briefly touch on uniform standards. We covered them in depth at the last board meeting, but I wanted to provide just a brief snapshot over the next 2 slides. And as some of them will be referred to in 9.3.1 and 9.3.2. So first you have 1 through 8. These are the clinical diagnostics, removal from practice, communicating with the participant's employer, et cetera. So we will be touching on 1 and 2, as well as, next slide, as well as we will also be touching on uniform standard number 12, which is the petition to reinstate for a full and unrestricted license. So those will be coming up as well. So historically, there have always been misconceptions about intervention versus probation, the difference in requirements. So in the next 2 slides, it gives you those differences. And again, we did present these slides previously, but there were some questions and statements at the last board meeting, so we wanted to cover them again. So one of the board members had asked a question regarding if a probationer is allowed to enter the intervention program. So pursuant to California Code of Regulation 1447H, if there's a current disciplinary action for substance abuse disorder or mental health, a licensee would not be eligible to enter the program. And they would be referred over to our discipline unit so we could pursue discipline against the license. There are some other boards that do have that dual track. Meaning that they can have someone on probation, and then when they get that diagnostic evaluation and it's determined that there is a substance abuse disorder, they can mandate that RN into the intervention program. So they do have that dual track. We do not at the board. There was also a concern during public comment that we are not applying the same requirements across both intervention and probation. So if a licensee is placed on probation, there's a decision and order that is specific to the terms and conditions of probation, which you guys are very, familiar with seeing those. This is determined in either the stipulated settlement or the proposed decision. And that's all based on the recommended guide for disciplinary orders and conditions of probation in our regulation. Both administrative law judges follow that, as well as our deputy attorney generals when they're doing the STIP settlements. So those are all followed through those disciplinary guidelines. The intervention program is it's not ordered. It's a voluntary program, and it's governed by statute 2770 through 2770.11. It's also regulations in California Code of Regulations 1446 through 1449, and then as well as the uniform standards, which were the previous slides that we just went through. The intervention program, the intervention evaluation committees, they make the recommendation for the requirements of an intervention participant, which was covered in a previous slide. So they make all those recommendations based through those statute regulations, uniform standards. So on this slide, I do want to point out though, drug testing. So a lot of these, you'll notice a lot of these are very similar, but the drug testing, they both, and when it comes to probation versus intervention, they both have to do an evaluation. Probation, it's mental health, physical, the clinical diagnostic for intervention. They both have testing. They both have possible treatment. They both have therapy. So they're very similar. Can you go to the next slide? Here. So those are several standard requirements that are the same. One of the big differences, though, is that intervention is confidential. Probation is not. So meaning that within intervention, there's no public posting. There's no awareness. There's no one of the public that is aware that someone is in our intervention program. With probation, once that decision that the board votes on becomes effective, that is posted to both the board's website and to nurses. And so that is available not only to our residents of California, but to the entire United States through nurses if they would like to view, that and in any other nursing jurisdiction across the United States gets those. Next. So that is 9.3. I'm just ending up 9.3. So if Tricia, if you any board discussion.
Great. Thanks very much, Shannon. And thank you very much for your presentation. Are there questions or comments from board members at this point? Yeah, go ahead, Ms. McCormick.
Thank you. This is Board Member Cormack. It's very helpful to get this level of detail. Because the intervention program is confidential in the almost year I've been on the board, we really get very little information. And so I appreciate learning more. One of the things we talk about a lot is metrics and time. About how long does it take from the slide where there's a phone intake until the first IEC meeting? So what is about how long that takes?
What we've been trying to do, because we do identify that there is an importance of getting them before an IEC. Again, participants are assigned to a specific IEC, but if that IEC is not meeting for 3 months, because they typically meet about every quarter, if that IEC is not meeting, we try to get them at least to the next IEC, regardless if that's going to be their permanent IEC, to at least review the initial documents and make a decision on whether they're going to be accepted into the program, because we want to get them started in their recovery process, not just that pre-entry phase. So it could take anywhere from a few weeks, it could take up to 3 months. It's just how often we haven't called an emergency meeting yet of an IEC, because we do have several. We have 9 IECs and they meet on a quarterly basis. So we have 36 meetings throughout the year, and there's usually at least 1 per month.
And does that seem like an appropriate length of time for someone who is asking for treatment? I mean, speaking as a member of the public, getting help can be hard. This is why we end up sending people to ERs when, that's not really the greatest option for everyone.
Well,
I mean, are we happy with this? Do we think this is the right length of time for someone who is asking for help? And are we tracking the amount of time? Because I'm not hearing an answer that we're tracking it.
We do track, because most of our entries into the intervention program come in through a complaint from the board. They go into the program. We track the date that they actually made contact. We track the date that they had their first initial intake. We track the date of their clinical diagnostic. And for some people, we need to wait on that clinical diagnostic evaluation, because if they have the evaluation and it is determined from that clinician that they do not meet the requirements, maybe they're not substance abusing, it was a single one-time DUI, and they don't feel that they're substance abusing and that they would benefit from the program, or they just don't meet that criteria. There's something else that comes up. We need to make sure from that clinical diagnostic that we are applying the correct rehabilitation for baseline, starting baseline. And that could take, a couple weeks to get them in to see that clinician for that assessment, that full assessment. So, and that's across the board. That's even with our 820, when we compel them to a psych mental eval through our disciplinary process. And that is also with our mental physical evaluations. It takes at least 2 weeks to get them to the clinical diagnostic eval, and then we're really trying to get them in within a few weeks to the IEC. And I think that that is probably the best or appropriate amount of time. I mean, in the real world, it'd be nice if we could get them a clinical diagnostic within 24, 48 hours. It would be nice if we could get them before an IEC, within that amount of time, but it's just not feasibly possible.
Since there are metrics, it seems like that's something that perhaps when the IEC committee meets, that could be a regular part of the review, in the same way we look at, how long it takes for, someone to go through a license process or someone to go through, the formal probation. Just a thought, I'll just raise it as, otherwise we're relying on folks in a confidential program to come forward and say there's a problem. And that seems like a high bar. So I'm sure there's some things I don't understand, but if this is data that you're tracking that is not about who the participants are, but just about how long it takes to get into the program, that seems like something, we could consider looking at.
Absolutely. And as for the last board meeting, if you recall, we did come before you. We have identified some areas that we will be bringing before the board for a reg package, because we feel that we've identified some areas within our regulation that we would like to bring before the board and have changed. And so with all of these meetings and all of these items that are coming before you, you can identify maybe some additional that you would like us to take back and figure out regulation for.
Okay, my next question is about the cost.
Allison, I'm
Sorry.
sorry. I just wanted to throw something in, and if you don't mind the interruption,
No.
it's responsive to your last question. Just wanted to add to what Shannon was saying. I think staff are, as far as the time frame to get folks into the program who need those services and things, that's, I don't think, lost on them, and that shorter is always better. That said, I wanted to draw your attention to Business Professions Code 2770.8. And, staff are doing their best, I think, to be responsive and get services administered as quickly as possible, but also run the program according to statutory requirements. So that section that I mentioned outlines the duties and responsibilities of the intervention evaluation committees. And just briefly, a few of them. The initial subdivision A is to evaluate those registered nurses who request participation in the program according to the guidelines prescribed by the board, and to make recommendations. Subdivision B, to review and designate those treatment services to which registered nurses in an intervention program may be referred. And it goes on. There's a few additional subdivisions, but the point, those first two being that to kind of get the ball rolling with them, they have to get before an IEC, and under Bagley-Keene, which also we have to abide by that as well, and are making great efforts to ensure that the IECs are doing it according to Bagley-Keene. There's limitations on getting participants before an intervention evaluation committee. As Shannon said, those meetings occur so often, and they are taking steps to address that as best they can by, I think she said, getting an applicant in front of maybe another IEC that might be meeting sooner, rather than the one that they'll permanently be assigned to if they're admitted into the program, and things like that. So just wanted to add.
Yeah,
that
well, let's, because I heard a reference in that in public comments yesterday. So how does the Bagley-Keene, I mean, like, it's not like the agenda's published with a person's name, right?
Correct.
So there's no, maybe I'm not seeing the problem with more rapidly getting folks in front of a meeting.
Well, one of the advantages that folks, the applicants and participants' names are not published on the agenda,
Right.
is that we can have a new applicant go to a different IEC and get reviewed more quickly. What I was getting at is that the IECs have to abide by the same Bagley-Keene requirements as this board, as our advisory committees, which means a 10-day agenda. Even if the agenda is not going to identify their names and things like that, it has to be posted in advance. The locations have to be public, even if the majority of what they do is going to occur in closed session without the public. There's all these formalities. So their meetings, it's not like they can meet weekly or as needed. There is technically, we can hold meetings more frequently, but there is a cost, and at the end of the day, there's a practical limitation to how often they can meet. So that's the point about Bagley-Keene. And
That's super helpful, Mr. Pejuhesh, and I'm going to formally request that our IEC committee actually have a meeting and discuss how many IECs there are, how many times they meet, understand, how helpful is it for the same IEC committee to follow a participant from the beginning to the end. Like, I think there's some work here to do, and obviously now is not the time to do it in an informational setting. So hopefully the IEC committee can take some time to delve into this, because we should. Yeah. Okay. Enough on that.
Allison, are you saying the EIIC
Yes,
committee,
sorry.
not the
So,
IEC?
yeah, I know.
Okay.
I never know what the I's are for in the middle. Whatever the committee is that I'm on that hasn't met, that's chaired by board
Tricia.
member Nguyen.
Yes, so we can get that on the agenda for June.
That would be great. Okay. And then costs. So I understand that per test, it's $62.50 plus the fees. How, I can imagine that, and people are randomly selected. Are they randomly selected 2 times a month, 10 times a month? Does it depend on their treatment plan? Because we get a lot of complaints about costs.
That's dictated by Uniform Standard Number 4. That is the drug testing standard. And in the first year of recovery or first year of the program, it's testing anywhere from 52 to 104 times a year is what's been mandated within that standard. Their second
So 1 to
year-
2 times per week.
Their second tier was if they, once they enter that second year, it drops down to 36 times to 104 times. So it still gives you the flexibility. Within that standard, it also lists exceptions. So for instance, if they're not working in any healthcare environment at the time being, we can drop them down to no less than 12 times per year. There's some exceptions written in there. So there's probably 5 or 6 of them that are written in there. But those are the main 2 tiers, the 1 and 2. But then there is a caveat that, and you'll see in one of the upcoming slides, that when they're prior to going through the diagnostic evaluation and when we're waiting on that eval back from the clinician, they are to test at least 2 times per week during that period of time. And that's also mandated within the uniform standards.
Okay, super helpful to have that information. And my last question is, relates to the phrase that the IEC makes recommendations to the program manager.
Yes.
So it is the program manager in this current instance, Maximus, that determines?
Program manager, that's program director. So Jenny's the program director at Maximus. It's the board's program manager that oversees the intervention program. And that has recently been
Oh.
delegated by Lori to Jaspreet Pabla, who's one of our deputy chiefs.
Okay,
Yes.
okay, thank you.
Before I call on another member, I do just have one follow-up question
Mm-hmm.
from Ms. McCormick. Ms. Cormick, I always want to put an MC, I'm very sorry.
It's fine. I've been answering to that my entire life and will continue to do so.
People may still go into treatment. If they're ready for treatment, they may go into a treatment program regardless of intervention or probation, because we get a lot of probation cases where people have already entered residential treatment. And I know the same is true for intervention, right? So we're not really a serious obstacle. If someone's ready for treatment, they may go and get treatment. I do take to heart, Ms. McCormick's concerns, but if someone's ready for treatment, we're not getting in the way.
No, I mean, we don't have any control over someone, an individual wanting to go into treatment. And in fact, if we do have someone that calls the program in their initial contact and they're in distress and they need emergency help, we do direct them to residential or refer them. So Maximus does have a 24-hour line that when someone calls in, if they do need emergency services, they are directed to where they can go. And then the board is notified immediately of those participants. So we can really react in a more, in a quicker response way to those that are in need of immediate help.
Thank you very much. Are there other questions or concerns on this? Go ahead, Mr. Lawler.
I appreciate the presentation, Jenny. I noticed throughout, it said the program was for both drug abuse and mental illness issues. And one of the questions we heard both yesterday and at our last meeting more than once from the nurses was, when the offense has nothing to do with narcotics, why am I in this program? And I assume the reason is therefore because it's a mental illness issue?
I believe the comment yesterday was based on diverting. So the issue wasn't with diverting narcotics from the hospital. So it may have been a use issue or maybe alcohol outside of the workplace. I think that may have been what the comment was referring to yesterday. But again, I'm going to go over in one of the next agenda items, the returning to work in patient, non-patient care with or without access.
Okay.
Yeah.
I have a quick comment, if there's time. Yeah. I've had 35 years of nursing leadership experience.
Thank you.
And lots of experience with the intervention program. And Jenny, you could probably validate this, but in my experience, the vast majority of people I've known, because we get notified when they're coming back to work in the intervention program, they have, the reason that they went into intervention in the first place was because something happened at work. Either the nurse came impaired or there was diversion, and then they're no longer working until this gets resolved. But most of them then, I think, go and start seeking some help immediately before they even get into the program. Is that correct, Jenny?
Um, most often they come in, and I don't have any statistics off the top of my head, but most often they come in for incidents in the workplace. We do have a fair number of DUIs, but many of them are work-related issues. And yes, so most often they seek treatment on their own, or because their employer has referred them into treatment, or their EAP.
Right. And if their
Yes,
employers
you're right.
referred them, they're no longer working, so they're no longer a risk to the public in that position, at least.
Right, right.
Thanks very much, Mary, for that comment. And go
Question.
ahead, President
Yeah.
Trujillo.
Hi, thank you, Jenny, for that presentation. I actually learned a lot from that PowerPoint. My concern, and I have several questions, is that at one point we heard from public members that they had to either leave their job or go into a position where they will have to handle narcotics. And I have a concern, sorry, I have a concern with that, but is that true? I mean, again, I heard it from public members, but I didn't know if truly that was part of the program.
I'll be covering a portion of that in the upcoming agenda item. But there is a perception right now from nurses that they have to. They're being forced to. They're being forced to quit a job. But we can cover that. I want to say it's 9.3.1, which is coming up next. We can talk about that
Okay.
then. But there is a perception out there, and hopefully I can clear that up.
Thank you. I'm looking forward to the next presentation.
Go ahead, Ms. Dominguez. Yeah.
Thank you. I just want to relay that question because I feel like the board has I feel like we're doing two buckets, and maybe that's not the right word or phrase, but we're trying to the board has a responsibility to safeguard the public, and my question just basically is the same as President Trujillo, is that then why are we that maybe I'm not understanding, because I did also learn a lot from this education, is that let's say I'm a case manager, I'm in the program, and now I have to now I've been out of the bedside for multiple years, and now this program's telling me to go to the bedside so I can prove that I can manage transferring from the Omnicell or Pyxis narcotics and giving them to a patient without diverting. So that's just my concern too, because then how are we doing both and truly safeguarding the public if I'm not even competent to take care of patients at the bedside because I've been so removed?
Yeah, and again, we're going to cover that in 9.3.1, and I think that's a much bigger discussion point. So maybe we can hold off for 9.3.1 to talk about the employment and the requirements surrounding employment.
Thank you. Sorry if I
That's
didn't.
okay.
Thank you. So I'm going to jump in just really quick here and just give some additional background. So we, as a Board of Nursing, collaborate nationwide through NCSBN with other boards of nursing. And the other boards of nursing have alternate to discipline programs as well. Maximus does participate in many of those also. And there's studies that have done on the efficacy of the programs, what are good processes, what are evidence-based processes, and they talk about 3 years without a relapse. They talk about daily check-ins, including holidays and weekends, which are all things that we do. They talk about a minimum testing of 2 times a month, random, also within the type of test. They talk about the structured support group being 2 times. a month. They talk about the RN specific mutual support group at least one time a week. And they kind of go into specifics of that. And they have great success rates that are proven with programs that utilize those kind of tactics to assist in the recovery. One of the other things that Shannon mentioned, I believe yesterday in her report out at the end of the day, was that we are also involved in a substance use disorder study that NCSBN is completing. And that study's been ongoing with them since I believe 2022 is when we joined. I believe September, they did a presentation in front of our board. And we, as a board, elected to join the study, and we are part of that study. And that study is actually going to go forward through August of 2027, if I remember that correctly. And we will have additional information that layers on top of that, that talks about the recidivism, talks about relapse, and follows, I believe, I took some notes here really quick, just let me kind of refresh that really quick, 2 years back into practice to see what occurs if there's relapses, and kind of tie that back to the way that the intervention or alternate to discipline programs are administered. And so we will have additional evidence that supports how these programs are run state to state. And I have requested, Richard Smiley is the person that did the initial study, and he's conducting this study, if they would be willing to come and present at a future board meeting. I've asked for either August or November so they can come in and kind of do some evidence-based into these meetings, into these programs, and provide some additional kind of national look. There's also a kind of movement across the nation within the boards of nursing as well. And I believe Dolores was with me on one of the meetings where we went to NCSBN, and they talk about reimagining discipline and really looking at risk-taking behaviors versus reckless behaviors, et cetera, and then really working with that through a lens of just culture. And I think those are going to be really pivotal as the board takes a look at these programs, that takes a look at the way that we administer these programs, and through the regulatory process that will be coming forward as well, so that we can have some guidelines for this. So this is an ongoing process. It's not something that is final today. And as what you've heard just with our strategic plan and everything that's going on, we are doing deep dives into every single one of our programs that we offer throughout the BRN and our processes. We're mapping, we're looking at, are we in line with regulations and statutes? Are we following our uniform standards? And we are discovering areas that need some attention. And this was one of the areas that did need that attention. And Shannon and Jaspreet, with the assistance of our Assistant Executive Officer, Reza, and myself, are really looking into this. And so with this presentation today, it is just to set a baseline, get that information out to everybody. And as we go into the next agenda items, nothing is set in stone today. So with these agenda items that are coming up, more discussion can be had. The board can ask for certain things to be brought forward to a committee meeting as well for additional discussion. And we can work through these processes and see that we are making the right choices, that they are evidence-based, that they are supported in our law, and that we are here to rehabilitate and support. That's the entire purpose of that, both for people that are suffering through addictive issues as well as mental health issues. And medically, we all know that a lot of times there's a dual diagnosis that comes in where you're managing both, and so that's why it's pivotal to have a program that can address all of that. There are within the evidence as well risk factors that show that a person may be more at risk to not successfully complete, and sometimes those areas that are identified that we know in the evidence the participant doesn't. And so when we see those behaviors come out when we're doing the evaluation, and that's one of the additional changes that occurred more recently, is our board staff has taken a much more active participation, not even speaking well, my coffee hasn't even been touched, role in this, where they're reviewing the members that are scheduled to go in front of the committees. And they're making sure those members are, those participants, sorry, are appropriate to go in front of those committees. Because what we were discovering when they opened that up is maybe those, the entire medical history, the behavioral history was not being considered, and they were being brought forth too soon. And so that was something that when we discovered that, when we peeled back the layers of the onion, we were like, oh goodness, now that we know that this is here, we have to jump in and do that. And additional to the nursing facilitator groups, but also with our IEC meetings, we were not having board participation. Our board staff was not attending. And those IECs were being ran kind of on an autopilot. We did trust everything that was going on. We knew that there were a lot of success and that everything was going well, and the reports that we were receiving were good. And then we started receiving things that may not have been in alignment, that they weren't following some of the statutes and some of the regs and some of the uniform standards. And each one, both Yvonne, Shannon, and Jaspreet, have been now traveling throughout the state and attending these meetings in person as well as virtual, and doing on-the-spot training, and identified where we did have to do some IEC onboarding, re-onboarding. We were also looking at term limits. We were also looking at various items that we needed to really address internally as well. And that came with a reassignment of who the board's program manager was, and put that, we believe we leveled that appropriately at this point as well. And so we are learning more as we kind of go through this process in here, and we're grateful for the public comment. We're grateful for people sending emails and reaching out and letting us know that these areas did exist and are currently existing. And we are committed to just working through that process and seeing what we can do to improve on this. And, you know, definitely with a full understanding that we don't want anybody to be caught off guard. That's the biggest thing. But we also need to know that plans change, you know, and what worked for a person yesterday may not work for them today. And as new evidence is brought forward, as new items are considered, there may need to be a change in that treatment plan. It's not static. And so you have to be able to adapt and adjust and change the treatment plan when you see something else. And that's common in medicine, that's common in addiction, and that flexibility is required. And so there might be some, as Maximus, you know, is sharing, that they do kind of an intake and an education. And we might need to do much more focus at that level, where we're notifying the participants that your treatment plan is not the end all be all, that it will be updated. It may change, that we may discover something and that we might have to adjust that. And so that they're not holding on to that treatment plan as this is gospel. This is not going to change. This is how it's going to stand. And I think that might be helpful. Yes.
This is Board Member Cormack. We've heard the treatment plans, which I've now heard called recovery agreements, referred to as contracts. Are they actually, I guess this is a question for Mr. Pejuhesh, are they actually contracts, meaning they're enforceable? Or help us understand, because the terminology matters.
Yeah, that's a good question. I'll give you my opinion. They're not binding contracts in the contract law sense.
Okay.
That, you know, I'm afraid there's been some confusion as a result of the use of the word contract. I think the point that Lori was just making is an extremely important one to understand, that just because there's certain terms written down on a piece of paper and someone signed it, doesn't mean it's a contract that can never change without both sides consenting. If somebody's in the program and there's a set of terms that are required of them, and then all of a sudden circumstances change, for example, they have a really bad relapse or something like that, absolutely, the terms of that can change, and it can change against the will of the participant. It's the program's job to determine that the individual is safe to be, we've been using the term graduated from the program. So, yeah, I
Okay.
don't think it's a contract in the,
So
go ahead.
treatment plan or recovery agreement, or we'll just standardize
Yeah,
that.
better
Thank you for clarifying that, because it certainly has been something we've heard in comments helpful. Thank
Yeah,
you.
one of the common contracts that you might be familiar with hearing is when you have a patient that goes in on what's called a 5150, where they're on a hold if they're gravely disabled, harm to self or harm to others. They may not meet the criteria for inpatient, but they are still at risk. And so in the ED or in any of the emergency screening units or intake units, they will do a safety contract with that patient, and they will sign and they will say, this is what I will do if this occurs. This is what I'm expected to do. When they sign a safety contract, it's not a legally binding contract, but it is a safety contract. And so you will hear the word contract used in medicine around substance use disorder, around mental health, commonly, because it does kind of share the importance of that, the gravity of the situation that you're in, and that you are requesting them to commit to that. And so that is an amazing point to put out, that that's not a legally binding court of law kind of contract, but it is a contract between the person that is needing that assistance at that moment and the professional that is providing that assistance.
And I just wanted to say one additional thing, just to, I think this is kind of understood, but to ensure that my words aren't twisted down the line. It's the recovery plan, if it lays out the terms that the participant has to follow and they don't follow those terms, the program can enforce that. It can terminate them from the program. It can, alter the terms of the agreement. So it's not that I don't want to imply that it's not binding, but it's not a contract that requires both sides to consent to it being changed. Their participation in the program is, at the end of the day, voluntary. And this is not to, sound harsh, but if the terms of what the program thinks are appropriate are not something that the participant is willing or thinks are appropriate, it's their choice. But yeah, don't want to imply that it's totally without any kind of recourse to violate those terms, but yeah,
Can
hopefully
I
that's.
also just add, we have identified that as one of the things we would like to bring up in the reg package is there are some terms that need to be defined, and that will be presented with the reg package as well.
Thank you very much. And I don't want to cut off conversation, but we are going to take public comment on this item, and then we're going to get into the more specific issues. And I think a lot of these questions will be more appropriate for 9.3.1 and 9.3.2. So at this point, I'd like to open it up to public comment, and I'd ask the board moderator to do so.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment.
As you're doing that, board moderator, I just want to check here in headquarters. Is there anybody in the audience here that wants to participate in public comment in person today? Nope. Thank you. Board moderator, there is no public comment here in person today.
Thank you. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Please submit your I would like to make a comment request one time. We will get to you, I promise. And sorry, they're lining up. I'm getting my timer ready. And here we go. Matthew A. would like to make a comment. 1 second, please.
As Matthew A. is getting ready to make a comment, if this is more of an overview of the program, so we would love to have, as we've directed our board members today, to keep the comments and the questions kind of more aligned to the overview of the Maximus program, the overview of the intervention program. And if you do have specific comments towards the following items in 9.3.1 and 9.3.2, we would like you to hold off to those agenda items so that we can, as a board, participate in that discussion with you guys versus being required to wait until that agenda item. And we think that that might be much more helpful.
Thank you. And here comes Matthew A.
Good morning. Good morning. Thank you, Mr. Pujahesh, for explaining Maximus's one-sided agreement and that it's only enforceable from their end. For each participant you will hear from today, there's probably about 10 more that are afraid to speak out. I'll re-ask my question, my unanswered question from yesterday. Does the BRN or ECs provide any written reasoning how they came to the conclusions on extending participants in the program? I'm glad Ms. Matthews painted a rosy picture of Maximus, but that's not the way it actually functions. Ms. Matthews stated the recovery agreements says the criteria for completion or for what's going forward, but that's absolutely false. Currently, participants are being required to do things that are not listed anywhere in their recovery agreements, such as handling narcotics, but they're required to do it anyway. The way it works currently is participants attend these EC meetings. They're praised and told what a great job they're doing. Then they're told they'll get a decision about the EC's decision in 2 weeks. Frankly, it's longer than that. Then at some point, Maximus case manager calls participants and tells them of the EC/the BRN's decision, but they can't tell them why the decision was made, any specifics of some newly added requirement, or how long they'll need to follow these new requirements. All the while, participants, even participants with impeccable compliance for years, are extended indefinitely without any direction, criteria, or light at the end of the tunnel. They continue to jump through new hoops imposed and are indefinitely extended without any reasoning. Since the last board meeting in February, I've been contacted by about 24 other participants who have told me the same story. This is not an isolated incident. The BRN continues to use the general criteria that participants are quote unquote able to practice safely, but that's a red herring for the BRN to continue to fail to provide any objective evidence-based criteria. There's also a real conflict of interest as the BRN enforcement forces participants to obtain clinical evaluations years into the program from a BRN paid psychologist. Not surprisingly, the psychologist, after 15 minutes of speaking with the participants for the first time, tells the BRN what it wants to hear, extends participants in the program, and Maximus and the BRN continue to benefit from the nurses' participation in the program. As Ms. Milley mentioned yesterday, ironically, right before she was cut off, EC members are also being silenced. The desperation and hopelessness I hear from nurses makes me fear something tragic will happen to these nurses. And the last thing I want to do is come here at the next quarterly meeting or after that saying, I told you so. Thank you for your time today, and I appreciate the discussion.
Thank you for your comment. Tony would like to make a comment. 1 second, please.
Thank you for that overview of Maximus. That really shows how tightly we're monitored. I just wanted to round back to a couple of points. Lori, just to agree with Matthew A., the contracts are definitely one-sided. And for some of the participants that have been in the program for years, and have gone before complete IEC boards, meaning that there were, BRN members there, there were board members there, and Maximus representatives there, complete IEC meetings. Praised, doing good, participants that have held a job for more than 3 years, who have had worksite monitor oversight. And when got into transition, which was the way the program was set up, and in that last year, right before to go before their last IEC meeting, to be released because there were no issues raised. As Lori had pointed out, that something has to change and we have to be flexible with the contract. Well, no issues were raised. There's been 100% compliance, and we were told that we can't have the meeting. There are participants that have also physical disabilities that have submitted doctor's notes that have been blatantly disregarded, and we've been just told, find something. So we work full-time jobs, so we're looking for jobs on the weekends. It's already incredibly hard to find a job when you're in this program, incredibly hard. So now to find a job with all the extra restrictions that they put on us, for some of us, our recovery agreement has been the same, and we've completed every single thing on that agreement. And some of us have not even been before our IEC board in over a year. So I can't imagine what has changed, what issue has been brought up that would just keep us extended in this program. With, again, impeccable compliance. No issues have been raised. So I'm so confused by what Lori is saying. I understand the board has every right to make changes. These changes should have been thought out and rolled out in a cohesive manner. And the people that
Thank you for your comment. You have I'm sorry, you have exceeded your allotted time limit. Chris Elsie would like to make a comment. 1 second, please.
Good morning, everyone. Chris Else here. So, I'm the nurse support group facilitator for San Luis Obispo County and the surrounding area. And just to kind of explain what my job is a little bit is, we're there as support group facilitators appointed by the board, and we're there to support the recovery of our nurses, but also to help them navigate their way through the probation and diversion program. So I just had so board member Cormac and Loretta brought up, these treatment plans. Excuse me. So in Maximus, they have a treatment plan, and with probation, like Shannon said, they have a decision and order. So there is and every time they go to an IEC, they have a different, for my understanding, they have a different treatment plan, but their decision order stays final until the end of probation. So every so often when they do it to an IEC, their treatment plan may change from time to time. So my example with how that's not really, we were concerned about how the treatment plans are legal or not legal, but there's things that are just being told to the nurses, but not placed in the treatment plan, which is part of our concern. So my nurse, so I think it was like November of last year, was told by her, just make sure I'm getting that. This is the case manager, Maximus case manager, that she was now going to be required to handle narcotics for about minimum of 3 to 6 months. So she went out and she found another job outside of dialysis, to working in a nursing home. She now has went to another IEC last month. Again, in her treatment plan, there is no mention of her requirement to pass narcotics. So part of her frustration is that we're getting these edicts from Maximus that are not being held up in writing. And there's no email train, there's no, this treatment plan does not, I just read it myself, because we have access to it as group facilitators to read their treatment plan. It still has not been changed that it requires her to pass narcotics. And I am aware, because I speak back and forth with Maximus, that is a requirement for her. So I don't understand why they're not being placed in treatment plans if they have requirements. And there's, like, I think Matthew talked about some new requirement to see a psychiatrist, which is now being added. And there's all these things that are being added, but they're not being placed in these nurses' treatment plans, which if you go over to the probation side, these are set in stone.
Thank you for your comment. You have exceeded your allotted time limit. Julie would like to make a comment. 1 second, please.
Participant in the
Sorry, Julie.
Okay, can you hear me?
Yes, go ahead.
Oh, thank you. Hi, my name's Julie. I'm a participant in the Maximus Recovery Program, and I have some comments I want to make later on 9.3.1, but regarding what was just discussed, I did want to make a personal comment. I know we got a lot of metrics and statistics here, and that the board or excuse me, Maximus has stated that they make every effort to connect us with an IEC as soon as we have voluntarily joined the program. And it sounds like there's going to be some more some discovery that's going to be done as far as the actual statistics behind that. And I just want to echo Ms. McCormick's concerns and let you guys know that from a personal standpoint, they've said that they do everything they can to connect us as soon as they can, but that is not what is happening. When I personally joined, I had done research. I knew that they meet about every 3 months, and I was hopeful that when I joined and inactivated my license, that the next IEC would be soon. And I was elated to find out it would be soon. It would be in about 2 or 3 weeks. But then I was told that that IEC meeting was full and I would have to wait an additional 3 months. I had to fight. Personally, I had to fight and let them know that it was very important to me to be seen quickly. And I did have to kind of fight for that. And it was granted, but it is not something that is routinely offered. And I'd also like to point out, as far as 12-step meetings, Maximus is, although they say they cannot require a 12-step meeting, it is very unspokenly required. Personally, I tried every other type of meeting due to religious trauma, found one that I really liked, but due to the fact that there is no sponsor program and they do require a sponsor, it was very difficult to stay in a non-12-step meeting. It's in the verbiage. It's something that they definitely do require, even if they tell us that they can't require it. And I think that needs to be evaluated. It's something that could be changed and looked into a little bit further. And those are the two things that I found some problem with, but thank you for hearing me.
Thank you for your comment. Anthony would like to make a comment. 1 second, please.
You hear me?
Yes, sir. Go ahead.
All right, thank you for this meeting and thank you for the presentation. But I think that the board members are absolutely correct in their questions and their feelings on this Maximus program. When it comes down to this contractual agreement, it is a contract. It has every verbiage and every standard and every format as a contract. But now we're hearing that it's just a one-sided contract where Maximus can change it whenever they want to. But if the participant doesn't agree, they're out of the program. But they signed this contract, they date it, it has a term limit, it has every legal format and standard as a contract. And also, when it comes time to getting out of the program, I know many applicants who were supposed to be out of this program December, January, February, and they're told that they can't meet with their EIC meeting or their committee because these new requirements have been placed where they have to pass narcotics. They have to have bedside for 3 to 6 months, which is so unfair because a lot of these nurses have physical disabilities that would not allow them to do that. That would be harmful for the applicant. Can you imagine your mother being transferred from one bed to another bed by a nurse who has cages in her back, spinal fusions? You wouldn't want that. That's not helpful. Some of these nurses have nurse case manager jobs where they're at home. They're with their family. But now you're telling them they have to find another job where they have to do these requirements. And even though the BRN says this is not a requirement, these nurses are being held right now, not able to leave the program because of this requirement. When we ask Maximus, what can we do? What is the requirements? There's no understanding. Can it just be the weekend? Can it be 1 day a week? What is the actual, how can we get out of this program? Some people have been in it for 3 years, 4 years, 5 years, and they're still in this program. And then when it talks about the testing, yes, you can get tested sometimes 3 times a week. You can get tested 5, 6 times a month, and it costs differently between blood, hair, the saliva. Imagine getting patches of your hair pulled out once a month. This is completely what the presentation says is nice if it worked.
Thank you for your comment. You have exceeded your time allotted. LH would like to make a comment. 1 second, please.
I'm hoping you can hear me. Thank you for allowing me to speak. This is just in reference to the slide showing some of the cost for the program. This is just informational for the board, a real life example. Another BRN board member mentioned many of nurses come into the program after already being in treatment and recovery. I am one of those nurses. I was not notified about the complaint against my license for 22 months from the time I entered recovery and treatment on my own. So by the time I entered the program, I'd already been treatment, recovery, therapy, meetings, etc. And when I entered the program, I entered with the most basic treatment plan, IOP, 52 weeks of aftercare, obviously the other requirements, testing, etc. My insurance would not cover IOP because they determined I did not need it because of my strong history of sobriety and treatment and recovery. So I paid for all of that out of pocket. So I have been in the program for 15 months and I have spent over $17,000 out of pocket. So just to give you a better understanding of some of the costs, and mine, again, is most basic. There are many nurses who have spent much, much more money in this program. And obviously, I was not working for the first 6 months while in the program. So I was making all of those payments and paying for all of that out of pocket, which I'm now in a mountain of debt because of it. So I just wanted the board to have a better understanding because that slide was very vague with its cost that it was talking about. I also wanted to echo what Julie said about the requirements for 12-step or community group. I was never informed there was any other option besides 12-step from Maximus when I entered. My case manager told me you have to do 12-step, and I also am not comfortable for religious reasons in the 12-step program, but I'm in it because that is the requirement I was told I needed to be in it. Thank you for allowing me to speak.
Thank you for your comment. Mary Molly Shirk would like to make a comment. 1 second, please. Okay.
Can you hear me?
Yes, ma'am. Go ahead.
Oh, okay. Thank you for giving me this opportunity. I'll be brief. A lot of my concerns have already been expressed. Two things. One that came up recently is that folks are going to have to provide quarterly reports from their physicians. And so my question is, when the physician fails to do this, is the participant going to be held as being non-compliant? And then my next one is just an observation. I feel like the intervention program keeps a tighter control over participants than the probation program. And I understand because of the anonymity of it, that you're worried about the safety of the public. But is the public aware? I have participants in the probation program that took them almost 4 years to start. Is the public aware of that? And those people are still working. Thank you.
Thank you for your comment. Jason would like to make a comment. 1 second, please.
Everyone hear me?
Yes, sir. Go ahead.
Okay. In regards to the recovery agreements, what about participants who have continued to complete every single requirement in their recovery agreement, maintained perfect compliance with the program, continued to show growth as evidenced by letters from nurse support group facilitators, psychologists, sponsors, family, and friends? They've also demonstrated an attainable relapse prevention plan and continue to engage in sustainable recovery modalities for well over 3 to 4 years. The only thing that has changed is they have spoken out against all of these changes. What exactly are you looking for from these participants?
Thank you for your comment.
This is Reza.
Oh,
Sorry, real quick.
sorry.
I've said a number of times, nobody who's in the program needs to identify themselves. There's been a number of folks seemingly accusing either myself or staff or the board of retaliating. That's kind of the implication of that last comment. Said again and again, you don't have to identify yourself. There is not this. None of this discussion is driven by retaliation against individuals. We've tried to offer you a way to keep yourself anonymous if that is a concern that you still have nonetheless. But yeah, the rest of that we can take up later. But the implication that this change is only being made because folks are speaking out is not one that I wanted to let stand.
Thank you for your comment. Thank you, sir. NP Watching would like to make a comment. 1 second, please.
You hear me?
Yes, ma'am. Go ahead.
Thank you. I'm a nurse practitioner and I'm not in the intervention program. I did not select it based on my research. And my main concern was the fact that the contract was not really a contract and it could be changed over time. And my concern was that it would be changed and I would always be in a state of flux. And so I am in probation. But I also wanted to say that I feel like the cost that is described is profoundly underestimated. Profoundly. I feel like you cannot describe the cost of this program. Thank you for hearing me out.
Thank you for your comment. Amanda would like to make a comment. 1 second, please.
Can you hear me?
Yes, ma'am. Go ahead.
Hi, yes, thanks for letting me talk. I'm actually a participant in the program. I was supposed to graduate this month, and mine is more of a question. I've been, extended and mandated to pass narcotics, and I can't graduate the program until doing so, is what I've been told. I've been looking for jobs. I've been interviewing. I have not been able to find a job. I've been off the floor for almost 4 years. I've been in case management because I wasn't allowed to go to the floor when I first started working for over 2 years now. I love my job, want to stay there. What do we do if we can't find a job? I've been told by the people I've applied to that they won't accept the Maximus program, that they don't have an on-site monitor, or I've been off the floor for too long. So sorry, bad luck, right? So if something's out of my control and I'm not able to find a job, what's the maximum amount of time that I have to stay in this program? What's my maximum jail sentence, so to speak, to get out if I'm compliant and sober? Thank you for letting me speak. Just a lot of fear, a lot of fear.
Thank you for your comment.
Real quick, this is Reza. I just want to say again, the comments can keep coming in regarding the requirements about jobs and whatnot, but that's the next agenda item. So as far as like the rationale as to why that's being done and all that, that's going to be addressed in the upcoming item by the board and staff. So
Anonymous 25 typed in a comment. It doesn't look like they have the ability to speak. Would you like me to read it?
Yes, please.
Why is Maximus / the board implementing something that hasn't been voted on? Thank you for your comment. Committee Chair Nguyen, there are no other public requests for comments on the WebEx. Are there still no public requests for comments there in BRN HQ?
There are no public comments here. Thank you.
Thank you. Would you like me to close this window?
Yes, please. So if there are no further comments on this item from board members, I'm going to recognize President Trujillo.
I would like to take a break
Yeah. So
for 10 minutes before we go on to the next agenda item.
we'll take a 10-minute break. We'll get started again at 10:50, and we will move to 9.3.1. Thank you.
Thank you.
Go ahead and get started again. Repeat it? Yeah, the hour of 10:50 having arrived, we're going to come back into session, and we're going to start with agenda item 9.3.1. And I'm going to turn it over to Shannon Johnson. Thank you.
Thank you. Hi, this is Shannon Johnson again, the board's enforcement division chief. In previous meetings, there was some concern that the board was changing the requirement for the employment in order for a participant to complete the program. The concern was regarding the requirement for some nurses to work with direct patient care as well as possible narcotic access. The concern was that it wasn't part of their initial contract and was changed during participation, as well as being required when there was no intent on ever returning to bedside or direct patient care nursing, and the nurse was not wanting to have access to narcotics. Some nurses also state that they do not want to return to nursing at all. So that brings us to this agenda item today. Next.
Real quick before we move on any further, this is just informative at this point. Is that correct, Shannon? I'm just worried we're down one board member. We did have a board staff go to retrieve her.
But this is just informative, but this agenda item is a possible action. So
Okay.
I don't know if we want to hold off.
We do have quorums. We don't have to, but it might be of benefit to.
Let's give her a couple minutes. Let's give her a couple minutes.
Yvonne's looking for her. I just sent, yeah. So we would like to take a moment just to see if we can locate board member Cormack and
Mm-hmm. Yvonne, did you locate her? 1 minute? Yes.
so we have located board member Cormack and she's asking for 1 minute. So we will ask the board to hold on this presentation until she's able to rejoin.
Okay, we're ready to get started. Thank you.
Okay. So I added in here, I just wanted to share the legislative intent of this program. It's in 2770 in Business and Professions Code 2770. So it is the intent of the legislature that the Board of Registered Nursing seek ways and means to identify and rehabilitate registered nurses whose competency may be impaired due to abuse of alcohol and other drugs or due to mental illness, so that the registered nurses so afflicted may be rehabilitated and returned to the practice of nursing in a manner that will not endanger the public health and safety. It's also the intent of the legislature that the Board of Registered Nursing shall implement this legislation by establishing an intervention program as a voluntary alternative to traditional disciplinary action. This is taken into consideration by the intervention evaluation committees When discussing the need for nurses to possibly work in direct patient care with or without access prior to completion, in conjunction, we also need to apply Uniform Standard number 12. Next. So in Uniform Standard number 12, it's the criteria that a licensee must meet in order to petition for reinstatement of a full and unrestricted license. And I just want to start by saying we only have one license type. It's an RN license. And once it is unencumbered, they can work in any capacity as a registered nurse. And that would include passing narcotics and direct patient care. So with that being said, Uniform Standard number 12, the licensee has to meet these criteria. They have to demonstrate sustained compliance with the terms of the disciplinary order. That is actually for discipline. These, and I just want to state too, the Uniform Standards was written for both probation and for intervention. And however, when we go over the next slide, the intent of Uniform Standards was for substance abusing RNs. And if they are not diagnosed, typically we won't follow these types of procedures. So that's why the diagnosis in 9.3.2 is very important. 2, they have to demonstrate successful completion of a recovery program if it's required. They have to demonstrate a consistent and sustained participation in activities that promote and support their recovery, including but not limited to their ongoing support meetings, therapy, counseling, relapse prevention plan, and community activities. They have to demonstrate that they're able to practice safely, and they have to have a continuous sobriety for 3 to 5 years. So a positive drug screen in the middle of that would extend that time within the program based on Uniform Standard 12, number 5. Next. So in Business and Professions Code 2770.7 C3, disciplinary action with regard to acts committed before or during participation in the intervention program shall not, means it must not take place unless the registered nurse withdraws or is terminated from the program. So what this means is when successfully completing a nurse from the program pursuant to the statute, any disciplinary action or complaints that were filed against the nurse must not take place unless they've been terminated. So if the nurse successfully completes the program, the board cannot pursue disciplinary action, and this would mean that there is no public awareness of any mental health or substance abuse disorder. Many of our participants claim that they do not intend to return to direct patient care nursing, but once completed, unfortunately, a lot of them do. Me lost my place here. They can also, they can if they choose, and some even find themselves back in the program for a second or third time. So there is nothing within our statute or regulations that if they're successfully completed, they can return. There's nothing that stops them from that. So we do have some that have been in the program 3 times. They've left, found themselves diverting again, back in the program again. I'm sorry.
Can I just seek clarification in terms of program? Are you speaking of Maximus? Or
When I say program, and I just want to make that clear, so Maximus is our vendor. It's not Maximus program, it's the board's program. So the board, it's the board's program, and we contract Maximus to support us in services with the program. The board only has, like I said, the board only has 1 RN license. So when you take into consideration that when they successfully complete, there's no public posting, there's no public awareness. And again, we have to remember we're a regulatory board. At the same time, we want to rehabilitate these nurses back into practice, but we do have, we have to uphold public safety at the same time and through our regulations that we have in place. So unfortunately, we don't have a nurse license that says registered nurse, but with the restriction of narcotic access or with the restriction of direct patient care. When it's unencumbered, it's a complete package. They get to do as they choose with that license. So that's why this is really important. And that's why I wanted to bring up this particular concern from the last board meeting. And And with that, we can go to the next slide and just board discussion. Any questions?
Thank you very much, Shannon. Are there questions or comments? Of course, this is a very, controversial issue right now in that I think maybe there had been some lax enforcement of this issue. And once it came to light, it began being, enforced, and people are kind of caught.
And prior to
crosswise.
discussion,
So-
maybe I should, because it came up in the comments previously, the board does not make that determination. It is the responsibility of the committee to look at the diagnoses, to look at the evaluations, the reassessments done, and make that determination is this person, based on their violations or based on their drug of choice or based on their history, what would be appropriate for us to feel comfortable allowing them to have an unencumbered license? And that's the recommendation of the committee.
Go ahead, Mr. Lawler.
Thank you for showing Uniform Standard 12 as the criteria for, I assume that's graduating out of the program?
Yes.
Is one way to put that. More than once, we've heard in relation to that, the challenge of being extended indefinitely in the program. Can you address, because I don't know what that's referring to.
So in the meetings that I've been in, and when this comes up, that a committee feels that maybe this nurse needs to work in, let's say, for example, they've been in non-direct patient care, and they think, we really need to have them monitored while they're in bedside nursing, direct patient care, or maybe we need to have them monitored with access. I've never sat in a meeting where they've said they have to leave their current job. They've said, let's give them an 8-hour shift per week to try and meet this criteria. They've extended hours, saying, we'll give them a maximum of 50 hours per week or per pay period. So they're trying to accommodate and fit in this requirement that they would like to see. And normally what they will say is, okay, we would like to see them in this capacity. And once they find that position and they're monitored, let's bring them back before us in 3 months, in 6 months to then be reevaluated. They're not saying in 3 months, then they're going to be done, or 6 months, they're going to be done. So it is slightly open-ended because they still need to be reassessed again. And of course, when you return somebody back to work, if you've had an assessment that says they're not safe to practice, you need to have another assessment stating, yes, they are now safe to return to practice. And so we want to make sure that we have those things in place in our protection of the public, to make sure that we are returning a nurse that we can say, and nothing's 100%, it's never 100%, but at least we can say yes, or the committee can say, yes, we're comfortable that this nurse can return to practice in a capacity in any manner as a registered nurse. And they're really trying to fit that in. I've seen nurses be completed without having access to narcotics. And I've seen them, say, no, we need to extend because we need to see that monitored.
Go ahead, President Trujillo.
So thank you for your presentation. My question is, we've heard from public comment. One, they're finding it very difficult to find these jobs where they need to go in and pass narcotics. Two, if I were, let's just say, an advice nurse, and I was going through this program, and now you're telling me that I need to be in an environment where I need to pass narcotics for 3 to 6 months, and I've never done that. I mean, with our license, we can do many things, not necessarily just passing narcotics, right? And I find it difficult to find a job doing that. And from what I'm hearing is that seems to be a common thread in the public comment. Is this part of their initial contract language or agreement? Because, as Reza said, it's not a legally really binding contract. But is this part of their agreement in the beginning so that they know that they're going to need to do this? My second question is, are you individualizing these treatment plans? And if so, how are you individualizing it? And do you have a nurse on board that's helping to assist in this and a physician?
I'm going to try
I
to
have a
answer
million
them.
questions.
I know, I'm going to try
Shannon.
and answer you. There was a few thrown out there, so let me try. They do take into consideration what is the history? Was it diverting from your hospital you were currently, working at? Is that where the incident happened? Was it a DUI? Have you always been in non-direct patient care? Have you been a case manager or a triaging nurse and you're not bedside? A lot of the nurses that come to us, they have been in the environment where they were direct patient care. They did have access to narcotics, and that's where the violation occurred. They start off in the program. A lot of times the IEC will determine, we'll allow you, or we think it's okay for you to go back to work, but maybe in a non-patient care setting, a lot of these participants find, you know what, I really enjoy this work. I want to stay in it. But when they get out of the program, they can go back to that if they choose to, and a lot of them do. So the committee looks at, okay, this is what they currently were in, but previously they worked in this setting and they very well may go back to it. Do we need to see them monitored in this capacity again? So they really have to take all of it into account when they're determining what they think would be appropriate for that nurse. And it is on a case by case now. They look at each individual. Someone in the comments mentioned transition that went away. Transition was what was given to a nurse regardless of where, once you hit a time frame, it was based on time frame, not about the nurse, not about the individual. And so once you got to that point in time, you were given as like a benefits package, you were given, and everybody was given the same thing. You all got to not go to nurse support group anymore. You didn't have to turn in paperwork for 12-step or community-based programs. You got to work in what capacity you wanted to. And if you did that for a year, you got successfully completed. And now we're asking the IECs to look at them as an individual, make a decision on them as an individual, take into account their violation, their mental health, any dual diagnoses. Have they had the appropriate therapy? Have they had the appropriate clinical diagnostic by someone appropriate to give the diagnostic? Have they had an assessment saying they're safe to practice? Those are all the things that we as a board are asking them to look at now when they're making their recommendation.
I'm wondering, is this a nurse or a physician participating in this input for the client or the participant?
I could jump in and answer that one really quick. So our IEC members are defined in law, who they are, and it has 3 RNs, 1 physician, and 1 public member. And that public member must be knowledgeable in the field of chemical dependency and mental illness. And so when the participants go in front of the IEC, there are 3 nurses that take a look at this and evaluate this. So I think one of the things that was helpful to me when this was kind of brought up was discovering what the change was. What is bringing this to attention today versus 6 months ago, a year ago, and what I'm going to try to gently phrase. What had occurred is what I've referred to in management positions as drift, as streamlining, as kind of finding something that works and repeating it over and over and over again, which it's not a one size fits all. But our IECs, Maximus, what was being delivered through our program was a one size fits all. And so it was very heavily reliant upon timeframes. If you do this for 6 months, then you do this for 6 months, you do this for 6 months, you do this for 6 months. And they didn't look at the individual. They didn't look at what was occurring with this individual participant. They didn't look at history. They didn't even take that into consideration. So when that was discovered by our board staff, we met and said, this cannot continue. It's not It's not a conveyor belt, right? It's not something that you meet 6 months, you go to this, you do this for 6 months, because that is not what addiction is. That's not what mental health is. And that's not what treatment is. A treatment, no matter what kind of treatment it is individualized. Even if it's a common diagnosis like congestive heart failure, right? Like you can't treat congestive heart failure the same for every single person. You have to individualize it. And so when that was discovered, that's when they did a deep dive and just started kind of peeling back the layers, going to the meetings, seeing how the meetings were scheduled, seeing how they were set up, seeing how the participants were brought in front of the committees, and what can be done. And so the one thing that did occur was making it individualized. And so what you heard from Maximus today is there's, about 250 participants in that program. We don't have 250 people in public comment, right? So not everybody is being required to complete and pass narcotics. Not everybody is being required to participate in patient care. And yes, 100%, if there's a disability that is taken into consideration by the physician, by the 3 nurses, and by the public member when they're bringing that forward. The other thing that is taken into consideration is the work history. And true, if I've been a case manager all my life, please don't put me back into not even back, but don't put me into direct patient care, because 1, I'm not going to be satisfied in that. But 2, as brought up, is that could be a safety issue, because my competence is not going to be there, right? And you don't want that to occur. But if you do have an ER nurse that's been an ER nurse for 20 years and they're diverting on the job, and yes, they're doing something different while they're in this program, that is understood, but you have a high likelihood of going back to work as an ER nurse. And so at that point, what is the board's role in public protection to ensure that they can meet the requirements for completion of the program? And that's what the IEC committee does. Now, is our board staff now much more involved in that? Yes, they do the review of the participants who are coming in, and they help to schedule them where we weren't doing that previously. So again, you go back to what has changed, right? Because when you start hearing these things come in front of you and you're like, we've never even heard about this, why is this happening? You have to, what's the catalyst, right? And the catalyst is we took the program off autopilot. And we are now very involved in it. We are looking to see how it is ran, what is being done, how can we improve, and really providing the service that we are legislatively mandated to provide, which is an intervention program, a return back to full licensure, and with the public protection really at the focus. And so not to be punitive. That is not the intention. And I just want to kind of take a side. We're hearing the participants that are saying that the goal has been moved. We're hearing that the participants are saying that they are unsure of what to expect. Those are things we can absolutely address. I think very kind of clear communication from the beginning, and that's where I said in the last agenda item, if you're being onboarded and oriented into this program and you're not fully aware of what the possibilities might be, that's something we need to address. When we're changing things and we're communicating that out, we need to be very clear in that communication, not prescriptive, but very clear on these are the steps in the process. And we're going to work with you and communicate with you and bring you through that entire process. As anybody knows, when you're going through the change process, it is a plan, do, check, act, right? And when things are discovered and you start to put the interventions in place to kind of course correct, that communication may not be completely ironed out. And that's absolutely something that we do need to address. We heard that loud and clear in public comment. And we will work diligently to bring that communication forward and have it very clear, working with Maximus, working with our IECs, and to really kind of be clear on what has happened in the last few months. And Shannon, you can elaborate on this more, is they've provided at least 2 nursing support group facilitator trainings that Shannon has presented with Jaspreet, myself, Yvonne, and Reza in getting materials prepped and brought forward. And we hadn't done a nurse support group facilitator training in years. Additionally, we did an IEC member orientation. You know, you guys go to BMont, board member orientation training, and that is hugely helpful. And we now do a lot. We are requiring our advisory committee members to even go to BMont because, again, we realized how important that is. We were not having our IEC members do that. So our IEC members now have an onboarding and an orientation, and we're bringing them up to speed as well. And again, that had not been done in a few years either. So we are finding areas and opportunities that we can address for improvement and really kind of correct that drift and remove that autopilot so that we can make this an individualized program. And I know that some of the board members in discussion were brought up cost. That is not part of our agenda items today, but I can assure you that that will be an agenda item going forward. But Shannon, I know you had informed me previously on cost. We pay as our board, we do supplement some of that cost for some parts of that program. But we do understand that if you're inactivating your license, you go from, you know, and I don't know the salary ranges of everybody there, but say, you know, an RN in California, you can expect a greater than $100,000 a year. And you now do not have access to that income. And if a program is what they're saying, $17,000, that isn't an impact. And we need to take a look at that and see if there's anything that can be done to address that. And we'll have to agendize that for a committee, as well as bringing it to board when the committee work is done. So I just want to let people know that we hear you. We will be making additional adjustments and just working on how we can improve this. So thank you.
Thank
Thanks,
you,
Lori.
Lori. Thanks for kind of setting a little context for us, because I think we were all blindsided, you know, in last meeting. And of course, now we're getting some context, but I think your description really kind of gives us a better kind of starting point.
Can I also say too, on the board side, in identifying areas, you know, the board has also identified where we have possibly fell short as well. And some of the change in direction has been because we identified that our IECs, we were asking them to make these recommendations when they did not have a full picture of this individual's history. We are now making sure that we're providing them the summary of the complaints, you know, the possible evidence that's found within an investigative report. And when doing so and starting to do that, we realized these IECs were making recommendations without having knowledge of these very important historical pieces of this history. And now that they have them, when they were set on one path, now they see it and they say, wow, we had the complete different plan for them. It should have really been this, and maybe they should have had some individual therapy in this area, or, you know, a codependency based on situation. So that has played a part in it too. And so now as a board, we've realized where we needed to step up, and we have done that as well. So there's areas all around that really need improvement. I've been watching this for a couple years now, involved in the meetings for about a year and a half with some of the other managers, and really open to any possibility. And that's why we wanted the reg package as well. We do identify there is need for change.
You know, I understand taking a nurse, and if they came from that environment of where, let's just say they passed narcotics, like the example of an ER nurse, well then, yes, they can be monitored in that environment, right? Because that's probably what they're going to go back into after completing the program. But someone who's like an advice nurse has never done inpatient care. And it's not even just passing narcotics in inpatient care, right? There's competencies that they need to complete. And they may have been out of nursing school for like 20 years. And so this is like taking a new graduate into this environment just for the purpose of, passing these narcotics and seeing that they don't divert again. I mean, to use the analogy of an alcoholic, you would not tell the alcoholic to go sit in a bar and all you can do is order Diet Pepsi. Okay. You would tell him,
Be a bartender, yeah.
telling the bartender, yeah. So you would say that's a very stressful situation. That's a situation where you most likely would go back and start drinking. Why would you want to do that with a nurse who has never been in that environment? I think that alone is a stressor, not to mention also having to complete whatever competencies they would need to do that for the purposes of satisfying this program.
I
don't know if I'm making any.
Yeah, you absolutely are clear.
Yeah.
And I personally have not seen that where someone has never worked in bedside nursing without narcotics and has been, as they say, forced to go work with narcotics and direct patient care. It's been that their history has always been direct patient care. They diverted, and more than likely, and our nurses do when they successfully complete, they end up going back to what they know, back to where they started from. And unfortunately, some of them end up back in the program.
Okay, because what I'm hearing in public comments is some of them feel that they have to complete this or have been told to complete this. And that concerns me.
Well, what is recommended by the committee, and I've heard some people say that we found this was the new requirement, but they haven't been before their IEC yet for the IEC to have made that recommendation. So therefore, if you haven't been before your IEC yet and that recommendation has not been made, then it is not a requirement of you. A lot of times in nurse support group too, there's conversation that happens and then there's a perception that, oh, all of us have to do this now. We're all being required to do this, where one person gets told. And so I just want to end that perception. It's not a one size applies to all. It's not a one size fits all. If you go before your IEC, they will look at your case only, and make that determination or make the recommendation to the board. It's not now everybody needs to do this.
Well, I appreciate your reassurance. The other question I had was the comment regarding the individual who had to see an IEC, go in front of the committee, the IEC committee, and the committee was full. So do we have enough staff to handle the intake?
As far as I know, that was a past possible issue. That is not an issue now. We move people around. We try to get them before another IEC. That is not the case now. That is that may have been an issue previously. But we are trying diligently, and we do work with Maximus over that schedule. When we have an overload, like there's some next month, they're, up till 8 p.m. at night. Well, we're trying to find space in other IECs for them to be seen. We don't want them to go without being seen if they need to. But then on the other hand, we don't want someone going before the IEC where there is not going to be any change in their recovery plan. They're still in recovery. They're not ready to go back to work yet. They don't have any request of the committee. There's no reason to have them go before the committee to just say, hey, how are you doing? Okay, you're good. Okay, we'll see you in 3 months. Because then that takes up a space for someone who really does need a change to their recovery plan. So we're trying to look at that as well.
I think one other thing to give history to as well is the way that the prior IECs were ran prior to COVID. Prior to COVID, we had 14 IECs. Is that correct?
That was years ago.
And they met 4 times a year, each one of them in specific locations and required in-person participation. So our IEC, the people that had to go in front of IEC had to travel.
had to go in person, had to participate that way. That is not a requirement now. There is no in-person requirement for the participant to attend. And that allows our board to allow for people to attend alternate IECs that are not specifically in their region or their specific geographical location, where that used to occur previously. So when the person in public comment did make a mention that they were full and they did have to wait, that did occur. It absolutely was something that used to occur within our board, and that has now changed. And so we are working to look at, do we have enough IEC committees? Are they accessible to everybody, whether it be in person or virtual? And we are limited, though, in some incidences in whether or not we can get the 3 RNs, the physician, the public member, in that location. So we have had to shutter some IEC locations, and other IEC areas have had to pick up those caseloads. So just to put that out there, that is something that has occurred. But the other thing on top of that is, again, we're down to 250 participants being shared by what Maximus was, and we were much, much higher in years previous. And so we've had a drastic decline in intervention participation. So we do have to manage that as well, and work through that.
Board Member Granowitz has a question, and then Ms. Patel. Yeah.
It's probably irrelevant, but I was just thinking as we're going through this, is there something this onerous for physicians who get in trouble with chemical dependency?
Well, it's funny you mentioned that, because today they're actually in a board meeting discussing their plan for physicians. There are a couple of the other under medical that are under this umbrella. They do have, and that's osteopathic, as well as physician's assistants. They're both currently under, they have Maximus as their vendor as well, and they also have a program. But again, they have just about 295 participants. We take up 200, almost 250 of those. So the other boards have very few.
Thank you very much. Ms. Patel, and then Ms. Fagan. Thank you.
Board Member Patel here. I don't know who can answer this question, but is there sort of a formulaic situation where you increase the number of IECs based on the number of licensees in the state? So as the number of licensees grow, do we have a formula to say, okay, we need more IECs, just as a statistic of how many we expect might be in the program at some point?
Yeah, so as Lori mentioned, we had 14 at one time. So about 7 or 8 years ago, we shuttered 3 of them down to 11. During COVID at the beginning, we shuttered them down to 9. We still have them. I mean, they're still there because the board had approved them, and then you approved us to shutter them. So if we want to reopen them, we absolutely can. So we have up to the 14, and we can always increase them as needed. But previously, if you want to look back about 7 years ago, I think we had over 600 participants.
And just to second what Board Member Granowitz brought up, is maybe anecdotal, but it seems as though our other colleagues, our physician colleagues, for instance, don't have to go through the same rigor as nurses do. And granted, yes, our job is to protect the public, but you know, their job is also to protect the public as well. So just looking through that lens.
Yeah.
Thank you. Go ahead, Mary. You're next.
Mute myself. First, just a point of clarification, Shannon. Are you saying that the only people whose treatment plans were changed so that there's a requirement now that they must pass narcotics are people who were previously diverting narcotics?
No, not at all. I'm saying that their plans have changed for individuals who have come before the committee, and the committee is now looking at the whole picture, every puzzle piece, not just a piece of it. So for instance, previously, someone could go before the committee and they'll come with a request. Maybe their request is, I just want to request additional shift of overtime. The committee was only looking at that request at that time. So they weren't reviewing everything else Okay, have they had another reassessment? Should they have overtime? Have they been going to therapy? What's the result of that? They weren't looking at the bigger picture. So we've been asking them, regardless of what the request is, what the issue was, whether it was diverting, whether it was a DUI, some are battery cases, things like that. We're asking them to look at everything. So their plan may change now based on all of the evidence taken into consideration, not just a piece of it.
Can you provide an example of a situation in which a nurse would be required to, because what we're hearing in public comment is consistently that now I'm being required to pass narcotics and I have no intent to pass narcotics. Can you give us an example of a situation in which someone who did not divert narcotics is now being required to pass them before they can be released from the program? And what were the individual circumstances that led to that decision?
I don't have an example because I can't think of one. They've either, the ones that I've seen that have been, the recommendation has been made for that has been that they either were diverting, they were impaired at work, something under that type of situation. I haven't, I'm sorry.
Based?
I'm sorry, what was that?
All narcotic based as opposed to, because so many are related to alcohol.
Some are related to alcohol, but they take that into consideration. Some are, come to work impaired. Some are, getting impaired while they're at work based on either alcohol consumption while at work or based on coming to work impaired on narcotics versus, pulling narcotics, stealing the wastage or taking the wastage and not accounting for it, filling vials up with saline and taking the narcotic out. So there's all different reasoning for them, but the IECs are definitely taking that into consideration when they are making their recommendation. And I have not personally seen an IEC or been involved in one of the meetings that I can think of where someone had never ever had access to medications while as an RN that they've required to go back into bedside or direct patient care and had narcotic access.
Do we know the number of participants whose treatment plans were changed as a result of this, increased oversight?
That would be a hard number to get. I would say everyone's has, because every time they go before an IEC, they get a new recovery plan. Even if it's for the slightest, 1 8-hour overtime shift, they get a new recovery plan that is sent out to them. So what happens is the recommendation goes to the board, we review all the notes, and we send it over to Maximus to incorporate that into that individual's portal so they can go on and see what their new recovery plan is.
But I think the question that we're looking at, I think this agenda item is specifically related to the requirement to pass narcotics. So what I want to understand is who are the participants who are being required to pass narcotics?
So
make some sort of a recommendation to start some ledge package, we're going to want to, I think, be more clear on that.
So at the next board meeting, what I could provide in general, of course, because it's confidential, but I could possibly provide you with a number of, we're going to have to use a starting date from a specific date till now, how many nurses in the program have been required to find a job with access. And then I might be able to give you a generalization of what, of course, again, it has to be general because we can't be specific here because of confidentiality, but maybe the reasoning or a partial rationale as to why the committee came to that determination.
Shannon, maybe instead of that, maybe the committee will meet, Enforcement Intervention Committee
Right,
can
I'm
meet.
sorry, yes.
And we
before the
can
committee.
discuss that and come forward with some kind of recommendation.
Yes.
Which will be a reg package at some point, but definitely more work needs to be done on this. But I do have to say how much I appreciate us having this conversation, because we can't make changes until we have a very public airing of what's going on. And I think for years we drifted, as Lori said, and we've kind of got ourselves into a tough spot. So now we're doing the hard work. We'll go into committee and come forward with a package. Mary, did you have one more comment?
One more, and I promise. So we've just talked about this drift. Do we have examples of participants in the program who were released and then something untoward happened? Do we know that something bad happened as a result of this
Yeah,
drift?
well, I can definitely provide a report of anyone who has been into the intervention program, because we do track that in our system. And if there was a subsequent complaint that came in on them, I could provide that. And I could also provide a report on recidivism, participants that have returned to the program.
My question real quick, just for timing, Shannon, is we can schedule EIIC to meet in June. Is that some data that can be collected and ready for the June committee meeting? Okay, thank you.
And I'm thinking, I just would need to know, so going back maybe 4 years, 5 years?
Any other comments from committee or board members before we go to public comment? Go ahead, Ms. Cormack.
Thank you, Chair Wynn. I second Vice President Hagan's questions along the lines of really understanding the problem we're trying to solve. I think, you know, being more clear about that up front would probably save time in these situations. It took a long time to get to the point where it seems that some people have been released and were not able to function as nurses in a similar environment. So then we get back to all these other things. Some basic questions about the IECs. Are the members compensated?
IEC members, yes, they are. Just as the board per diem and then for travel, yes.
So they're paid $100 for every 8 hours they work. Okay.
Yeah, that's outlined in Business Professions 2770.3. Each member of the committee shall receive per diem and expenses as provided in section 103.
So these people are providing a public service with some recompense, but they're not being paid even minimum wage.
No, it's
Okay.
it's the
Okay. And who chairs the IECs? Who actually calls them?
The chair is voted on upon the members. So once the IEC is formed, then they vote on a chair and a vice chair.
Okay. And this will be a question that I think we should delve into at the committee meeting when it happens, but, and this isn't exactly how I want to phrase it, but is it good or bad that fewer nurses are in this program? And we will need some information to assess that, meaning how many people, you know, were there offenses the 4 years ago? How many went to probation? How many chose this program? Are those numbers about the same going forward? Or is the declining participation evidence of one of the public comments, which is the person had researched the program and felt, you know, be too restrictive or wouldn't meet their particular needs. So I'm not making a judgment that fewer participants is a bad thing. It's possible that's a good thing, right? But we need to understand why this has changed. And yeah, and
I would just like to say, based on our licensee population, we've never had the numbers that I think that we should have had. Across the United States, everyone is down almost 30% in their programs. I was just in a conference or a webinar the other day where they had spoke to that.
it's probably going to be hard for people to hear you, Ms. Johnson,
Sorry,
because you've
we've
turned
been-
towards me instead of the microphone.
Yeah,
There we
we've
go.
been declining probably the last 7 years.
But
In numbers, and no one's really sure why. I can try to pull together some information
Yeah.
statistic wise if you'd like
just
after the
so
next
we have a
meeting.
sense of, is this abnormal in our state? Is this a reflection of our probation program or whatever? Just context to help us know whether, you know, how we should be feeling about the decline in that. And then the other thing, so I'm trying to follow how the treatment plans, recovery agreements, whatever it is, the terminology we choose, how those are amended. And it sounds like the IEC makes a recommendation to amend that. A board staffer agrees or disagrees or implements it by telling Maximus. Maximus then informs the participant. Are those the 4 steps?
Yes.
Okay. And that takes 2 days, 2 months?
Once we get all of the notes, so The board receives all of the notes from Maximus, from the clinical case manager that attends the meeting. So when we get that, within probably 3 to 4 days, we try to get that back. Then they have to write up the care plans and put them in the portal. And I believe by contract, it states 10 days from the time received from the board.
Okay, so a 2-week-ish timeframe.
Yes.
Okay.
Do the
And
participants, are they at the
Are they
IEC
notified?
meeting?
The participants are notified that within 10 business days, they would probably be receiving and they are notified by their CCM, their clinical case manager at Maximus.
Are
Okay.
the participants though part of the IEC meeting
Yes.
when this discussion is occurring?
Yes.
Okay.
So they are aware of it as it is happening.
Yes. Well,
No, I
they,
see
they,
yes
don't-
and no.
they are notified at the end of the meeting that they will have, if there's any changes to their plan, it will be in their portal and they'll be contacted by their clinical case manager.
Okay, that's helpful.
And then the other issue that was brought up during public comment, I think would be good to also address in the EIIC meeting. I think I got it right that time, but don't ask me. Enforcement, intervention, investigation. There we go. Got it. Is the opportunity for folks who are not comfortable with a religious environment to participate in a support group that is not a 12-step. So not looking for an answer here today necessarily. It looks like you might have one to offer. But I think that is something we could understand better in committee. Because it might factor into what we put in the RFP for the vendor that performs these services for DCA going forward. Would you like to say something, Ms. Johnson?
We are very open to any community-based program or meeting that they would like to attend in order for them to recover.
So I guess the data we would need to know is a sponsor required? Because what I heard was the issue with the community programs is they don't always have a sponsor. So that would be an example of, EO Melby referred to evidence about what helps people in treatment and recovery. If a sponsor, there's data that it's sponsor, which is not necessarily related to religion, that's helpful. If the data is it's the group itself and it doesn't particularly matter if there's a direct sponsor, that would also inform our understanding.
For the board, if they are required to have a sponsor, that should come from as a recommendation from the committee and shouldn't be a given that they have to have that. And I don't know
So
if
that-
I've necessarily heard someone in a non-12-step community-based program be told that they have to have a sponsor. So
Well, we just
I-
heard that earlier.
yeah,
Yeah. So that's just, again, something to look
Right.
into to ensure that, we are not insisting that folks participate in something that conflicts with their religious beliefs
Correct.
or lack thereof. Okay, thank you.
Thank you for those questions. And Mr. Lawler has a question.
You basically took the words right out of my mouth, but the only thing I would add since that was said is I wonder, and this is not the time to solve the problem, but I wonder if there's a way to remove that criteria. Because some community-based programs that don't require sponsors are equally effective as those that do. And public members or nurses who have experienced religious trauma should never be required to go to any program that has a religious connection.
thank you. We will definitely look into that.
Thank you very much. Ms. Dominguez has a question.
I just wanted to mention that my concerns were stated by President Trujillo. Thank you.
Thank you very much. If there are no further board member comments, I'd like to,
I think Reza and I have a couple really quick. I just have one really quick. I had made a comment about the makeup of the committee, being 3 RNs, 1 physician, 1 public member. I wanted to also make sure that everybody was aware that it's quorum based. And with 5 members, only 3 need to be present. And so there is a potential that maybe only 1 nurse is involved because you would have 1 physician, 1 nurse, and 1 public member. You may not have all 3 nurses present when the committee meets and makes a decision. Reza?
Thank you for that clarification, Mr. Pejuhesh.
Thank you. I just wanted to kind of take an attempt at somewhat summing up a little bit at a very high level, and maybe kind of frame, what the task really is. So as you know very well, the agenda item is about this potential requirement in intervention for participants to either work in direct patient care or work in direct patient care with access to narcotics. So one thing I wanted to just reiterate is summing up kind of the pros and cons. That's a policy decision that you'll all, be weighing in on. That's really the ask, is for you to speak to whether this seems to make good sense. And this is potentially, possibly likely going to be an ongoing discussion, and not necessarily resolved today, but so you're being asked to kind of speak to the policy here. One thing you could decide is that this seems to have some logic to it, maybe as applied to some nurses in the program on an individualized case-by-case basis. And that's really kind of how it's being done right now. If you wanted to implement more specific criteria, for example, only implementing that requirement when A, B, and C are met, or something like that, something prescriptive like that would come in the form of regulations that you'd pass that would, of course, go through the whole Administrative Procedures Act process. If you think there's no merit whatsoever to it, and you're convinced that despite the rationale, but unquestionably no merit, then you can probably direct staff not to be doing that. And then, like I said, if you want to prescribe any criteria, even that it be, applied more broadly, to, take a more extreme example, that's also via regulation. But recapping the kind of both sides so far, and this is not an attempt, well, it's an attempt, but it probably won't be exhaustive, so I'll rely on our members of the public to kind of fill in the gaps. But as far as the rationale, from what I've heard from Shannon's presentation, keep in mind that I think where this is coming from, for one thing, the legal justification for it is the requirement in Uniform Standard 12 that in order for a participant to, quote, graduate from the program, they have to meet 5 criteria that are listed in Uniform Standard 12. I'm not going to read them all, but one of them is that they demonstrate that he or she is able to practice safely. That's obviously a little bit subjective and open-ended, but the rationale behind this specific narcotics passing or direct patient care requirement is, as Shannon said, that once a person graduates from that program, even if they never worked in bedside care or with access to narcotics before, or maybe they told us that they hadn't or don't have an intention to, that's all well and good. But the fact is, once they've graduated and got an unrestricted license back, there's no public notice that they went through the program, apart from, of course, the people who know that we're, working with them, et cetera. But really the big thing is that they can go back to any capacity in nursing, and we can't restrict them once they're outside the program. So there's a risk there. Now that risk also might be, there's other offsetting factors that you're going to consider, whether that risk is acceptable or too big. But that, I think, is the point behind the policy, that once they graduate from the intervention program, even if they said that they were never going to go back into direct care or work in a position where they had access to narcotics, they can, and we can't really do anything about it unless and until the time that they've gotten a complaint filed against them, and then we have to go through the discipline process anew. So that's kind of the pro of it. The cons that we've heard from public commenters, one thing is, naturally, this requires, some have called it job hopping, or at the very least, even if they don't have to leave their current job, it's certainly pressure to find another job. maybe in a capacity where they didn't have experience before or haven't worked in for a long time or whatever. That's certainly a legitimate issue that kind of offsets the pro is the pressure, the burden to find an additional job in a suitable capacity. An additional thing that was, I think, brought up was, I guess, the idea of taking someone who knowingly has some susceptibility to, drug use, drug abuse, and putting them in a environment where there might be some temptation there, and whether that's a good idea for them to prove that they won't be tempted, or a bad idea because the risks of putting them in that situation outweigh what is to be gained. And then we also heard about some folks who either have a disability or maybe they're a little higher in age and have difficulty working at the bedside or in some of these capacities. So, we'd hope that those types of things would be considered on a case-by-case basis, but certainly there are concerns that participants have had and expressed. So, wanted to kind of recap as best I could what we've heard and frame what is really your kind of to-do with this.
Thank you. Thanks very much. And I do think at this point we need to open up to public comment. So would the board moderator please open us up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Again, please only submit your request for a comment one time. Tony would like to make a comment. 1 second, please.
Hi, can you hear me?
Yes, ma'am, go ahead.
Perfect, thank you. I'm listening to the dialogue and there's a part of me that's very happy that, there are very substantial questions being asked. And then there's another part of me that is so extremely frustrated because I hear a lot of talking from Lori and Shannon, and they're throwing out a lot of things that are just simply not true. So I'm taking from what they're saying is that we weren't on an individualized plan. I can assure you that every person in this program has had a different track. We have had different requirements. We have had different experiences. I can assure you that I haven't been before a DEC in over a year. Before I was supposed to go to my last DEC, I was told no. I submitted documentations from my doctor, my medical records that my Maximus case manager told me. The board said, basically, still, you have to find a job. So the fact that they keep saying that it's not true, that we are told that we have these restrictions, is absolutely absurd to me. It's beyond frustrating. And it's just a lie at this point. We are being told constantly. I will have 4 years of sobriety next month. I've been in this program since the beginning, and I did not even divert narcotics. So again, the fact that we're being told that we weren't on individualized plans and all of this stuff, it's just simply not true. And it just shows that they don't have an understanding of like what's actually happening in real life. And now the harm that they're causing to us, because I have done everything humanly possible asked of me, and yet still I'm in this program. I just realized that now I have a DEC scheduled in November. That will be over a year and a half, maybe longer, that I will not go before a DEC. My medical records that were submitted were sidebarred, and I don't even have a transcript of what was said. this is information that my Maximus case manager had told me. So the fact that when I hear you guys saying that it's being, because it's not true. It's just simply not true. So again, yet I say I am indefinitely in this program, just here, paying, doing what's asked of me, trying to find a second job, even though I already work 40 hours, which takes away from my recovery. I don't want to work extra. I don't. It's not physically conducive for me. It's not conducive to my recovery. It's going to take away from.
Thank you for your comment. Your allotted time has expired. Matthew A. would like to make a comment. 1 second, please.
Good morning once again, at least for a few more minutes it is. Thank you, board members, for your excellent questions, particularly Ms. Fagan and Ms. Cormack. I really appreciate your questions. It's extremely hard to address the issues here today since board members obviously have unlimited time to speak and defend the BRN against issues raised today, but the public have 2 minutes to do so, but I'll do my best. Unfortunately, Ms. Johnson is speaking out of both sides of her mouth when she's talking about the program. In support of saying the ECs are not independent earlier, she specifically said ECs only recommend the treatment plan and whether participants are safe to practice or successfully complete the program. Then later on, during this most recent thing, she said that it's the ECs who are making these decisions and they're recommending that the participants work or the participants do this. But again, as we reviewed earlier, the EC can only recommend to the program manager. The program manager we clarified is Jaspreet Pabla, BRN staff. So it's the BRN staff that ultimately have the decision on whether a participant completes. This goes back to something that Mr. Puja has mentioned earlier and one of the participants mentioned about retaliation. It's not that the board members sitting there today, the 9-member board, is retaliating. It's the BRN staff, because I've heard from many participants that they've written letters to BRN staff to get clarification, questioning what's happening, a lot of the stuff you've heard today. And what happens is they appear in front of their IEC meetings. BRN staff that they specifically wrote to are there. Again, the ECs praise them, say you're doing a great job, and then the EC makes the recommendation, unknown recommendation to BRN staff. Then BRN staff comes back and says, well, now you have these added requirements. And it's particularly the people that have spoken out is the ones that are particularly this is happening to. Ms. Melby's comment as well about just because all 250 people are not here present, that this is not an endemic issue is extremely dismissive as well. While the board corrects their quote unquote drift, participants are collateral damage here. And also we've been discussing the quote unquote potential narcotic access requirement, but let me make clear, it's already here and has been implemented for at least the last 6 months. This is not something that you guys are discussing whether the board should do that or the BRN staff should do this. It is here. It has been asked of participants. Thank you so much again for your time.
Thank you for your comment. Dan would like to make a comment. 1 second, please.
Hello, hello.
Dan, go ahead.
Can you hear me?
Yes, sir.
Hi, yeah, I'm Dan. I'm a participant in the Maximus Recovery Program. Thank you for having this meeting. It's been pretty eye-opening in the specific sense that it is just so stunning how blatantly ignorant these people are about their own program. Ms. Johnson, you are completely falsifying everything that's going on. You have no idea what's going on with your own program. I think that if someone from the DCA is here, this program needs to be investigated thoroughly. It's been mentioned by myself and other participants that we think that they're stringing participants along in order to get an easy paycheck, and there's no end in sight. We're set on these vague rules. They're changing the goalpost as the game is being played, and we're just like Tony and Matthew, everyone else is voicing our concerns. There's no communication. You guys are bringing in like, oh, we're going to train the facilitators, we're going to train the IEC members. That's great. Train them. but then you just change the rules again, and then the communication goes out the window once again. So I plead with the DCA, investigate this program. It's a scam, it's a shamble. It needs to be completely redone. Thank you.
Thank you for your comment. Julie would like to make a comment. 1 second, please.
Hi, my name's Julie. I'm a participant in the Maximus Intervention Program, and I'm grateful for the time to speak today and for the comments from the BRN, especially from VP Fagan, President Trujillo, and the rest of the board. I can tell that you're considering the real implications of this mandate, and I appreciate the educated questions you're asking. It has been difficult to listen to Maximus as they explain their process, since there are so many discrepancies with the reality of how we as participants are treated. I encourage the BRN to do their own research into Maximus's claims and to seek out robust understanding before allowing Maximus to require 9.3.1. The most important question that we need to ask ourselves before voting or deciding on this mandate is, has a pattern been identified where RNs recidivate into addiction and diversion after completing the program as a direct result of the intervention program failing to monitor them before completion? I tried to answer this question on my own, but I didn't find any data to suggest any need for a change of this magnitude. In fact, on Maximus's website, they tout that 87% of participants establish long-term recovery through their current methods, which we know that they are improving. And this is a marked improvement to the 50 to 70% relapse rate with traditional treatment. A 13% relapse rate is groundbreaking. But would it be lower if we monitored nurses passing narcotics before they complete the program? The answer is most likely no. We don't know how many of those 13% relapse with alcohol, making monitoring narcotic access a moot point, or how many were already monitored passing narcotics before relapsing. We need a comprehensive breakdown of the data with rates and predictors for relapse and a look into what other less aggressive measures could be taken in lieu of a massive sweeping mandate indiscriminate of circumstance, compliance in the program, or nature of initial complaint. We are being told that in no uncertain terms, we must pass narcotics in order to complete. This is being mandated before the BRN has been able to opine. Please don't force us to make major life changes before this has been fully investigated by the BRN. This is unethical and cruel. Thank you for listening.
Thank you for your comment. Anthony would like to make a comment. 1 second, please.
Can you guys hear me?
Yes, sir. Go ahead.
All right. Hello again. I just want to paint a vivid, true picture. Imagine being in this program for the past 4 years, and at every EIIC meeting, you've been told that you're doing good, you're well on your way, you're on track, you're completing everything that's required. You have your last EIC meeting in October, where they tell you exactly the same thing, and they're telling you our next meeting is in February, and at that time you should graduate from the program. Then you get a call in January, maybe a week before your last meeting, saying, hey, we can't meet with you right now because the BRN is making new requirements for you to have to pass narcotics and have bedside for 3 to 6 months. And you don't know what to do. You're in limbo. And then all of a sudden they're telling you, hey, we're going to schedule your next EIIC meeting in December. So this is what's truly going on in real life. And during that time, when you're asking Maximus, what is this requirement? They're saying, well, we're not sure. It hasn't fully been implemented yet, but you're having us on hold just in case it does get implemented or some type of guidelines for it. It's confusing. It's stressful. That's more trauma. That's more driving someone more towards back to an addiction than helping them. If I had the chance, probably would have taken probation instead of going through this program. It seems to be much easier because this is not helping in recovery. This isn't helping the public. This isn't helping no one but the company, the drug test companies. They're getting rich off of this, but it's hurting our pockets. It's hurting everybody and everything else. And 17,000 is very low compared to what some people have paid. So they're the only ones getting rich off of this, and they're the only ones doing something off of this. It's not helping with the recovery. It's not helping with the process. It's more traumatizing than anything. And when you're in recovery, one of the steps is to stay away from what you got addicted to. Stay away from the drugs. Stay away from the alcohol. And like the vice president said.
Thank you for your comment. You have exceeded your time allotted. Jason would like to make a comment. 1 second, please.
There, can you hear me?
Yes, sir. Go ahead.
Okay, so imagine entering into a recovery program at arguably the lowest and the most vulnerable time of your life. You're told by BRN staff that you'll never regret this decision. So now that BRN staff member sits silently along with many other BRN and Maximus staff while you're filled with nothing but regret as this program continues to make change after change, resulting in participants being endlessly extended and this program feeling punitive and incredibly unsafe. I am one of a number of participants feeling completely hopeless as we just continue to ask for clarity, stability, and transparency. Instead, things continue to just get foggier and increasingly unattainable goals are set. And what's worse is that people who can objectively advocate for us are silenced. So as you heard yesterday, nurse support group facilitators and EC members have been advised that they may not advocate for us as it is, quote, against regulations. Maximus staff continue to encourage participants to speak up for themselves, but then sit idly by as we are intimidated into silence. This is not an environment that promotes any element of recovery, and make no mistake, it is creating trauma. As you can see from those speaking up, we are all suffering. There are no voices supporting the actions of this program, and there's never been such a substantial uproar. Please stop dismissing us. We are not a few disgruntled participants. We're human beings, and we are being subjected to endless abuse at the hands of Maximus and BRN's Enforcement Division. I am respectfully requesting to specify exactly what is required to complete this program. We need objective criteria to be able to meet, and having everything open to interpretation and continually changing has to stop. As it stands today, endlessly moving the goals for completion is extremely detrimental. So ask yourselves, how many times can you hear you're still not good enough before you lose all hope? No one thrives when they feel hopeless. Thank you.
Thank you for your comment. B would like to make a comment. 1 second, please.
Diversion/intervention program. I'm 2+ years into this program. I never diverted drugs. I actually had just completed my RN when I was referred to this program and was pursuing a master's degree. I was in a master's entry kind of program on my way to becoming a nurse practitioner. So I took a year off from school, and Maximus granted me graciously the ability to go back. So I've been back in school. I took out probably $70,000 in student loans, and at my last IEC in November, I was told you will not be able to work as an NP. You actually have to go work as an RN with narcotics access. So, I'm just one of the 250 participants who, can speak out and say that despite my success in this program, despite my adherence, I'm still being asked to comply with these sort of cookie cutter standards that are being applied across the board. I have no RN experience, for one, and I have to also divulge that I'm in this program in every interview that I attend. So, that, as you can imagine, it's probably pretty hard to secure a job that way. So I just wanted to speak on behalf of my own experience and share that with the board, that there are a lot of us who are being asked to do the same thing, and despite the goal of this becoming a bit more individualized. So I thank you for your time.
Thank you for your comment. Aaron would like to make a comment. 1 second, please.
and I'm in the Maximus Diversion Program. I have to apologize. I'm at work and I was kind of half listening to Shannon Johnson and the other woman who spoke. And while they were speaking, I had to ask myself, are they talking about this program? Because there were so many things they were saying that was just blatantly false. And I wish I would have had the time to physically write it down. I don't know if she just doesn't know or if she's purposely falsifying things, but I will give you my own experience. I've been in the program since December of 2020 with a one-time DUI, alcohol related. I was supposed to get out in April of this year. In January of this year, I was told you're gonna have to pass narcotics and your time out is indefinite. We don't know anything. And so I loved my dialysis job, and I was forced to go get a job at a skilled nursing facility to meet this requirement. So when she said something to the effect of everyone is individualized, I have no history of narcotic abuse. So I don't know why me specifically would have to go past narcotics when I was supposed to be done in April. My case manager at Maximus told me they are making every single person pass narcotics, no matter what the offense. So I don't know if that's true or not, but that's what I've been told. If you want to know about the cost of this program, it may say each drug test is $62. After the testing fee, it's actually $100. So each place is a little different, but you can guesstimate $100. I get approximately 4 to 5 tests a month, even though I've been in this program almost 4 years now with complete 100% compliance. And so my tests run me $400 to $500 a month. I know I made a mistake with that DUI. I'm not asking, I'm not the victim here, but what you guys are doing to us is wrong. And please look at the human side of this. What they're doing is not right. I also want to address the AA thing. When I told my case manager I wasn't comfortable with 12 steps, she patronized me and she said,
Thank you for your comment. You have exceeded your time allotted. Esteban would like to make a comment. 1 second, please. Esteban, go ahead. Oh, did I lose you? I will come back to Esteban. Rashad would like to make a comment. 1 second, please.
I'm the mother of a participant, and I noticed there's a lot of reiteration of the requirements of the program, but there's no change. Can a nurse request to graduate from the program without passing narcotics? My daughter has been in the program for years and has remained sobriety since. Her DEC was scheduled and canceled twice. Now she's in the program even longer, and like other nurses have been saying, there's no light at the end of the tunnel. This program is not individualized. Everyone has this requirement to pass narcotics. And this is absolutely ridiculous. And for these nurses that have not worked in years, it's hard to get a job if you have not worked in bedside care for a long time. It took her 18 months to find a job. And so now she's in the program even longer, and they keep canceling her deck. So, she's going to approach 5 years. What happens to these nurses? Like, is there ever going to be any change, or are we just going through the motions with these meetings and like, okay, this is how it's going to be? There's never any change when we have these meetings at all. These nurses are suffering from depression. They're frustrated. They're out of the workforce for years, and we need to see a change. This is not helping the situation at all. There needs to be a change. Narcotics are everywhere, okay? If a nurse wants to use narcotics or drink, it does not have to be on the job. It doesn't. It doesn't. So all I ask is that there is a change. Let these nurses go back to work and graduate from this program. Thank you.
Thank you for your comment. Esteban would like to make a comment. 1 second, please.
Yes. Yes. Hi. Thank you. I am actually a participant in this program, and this program, Maximus, needs to be thoroughly investigated. This program is non-conductive to any recovery to anyone. It's just a money maker. None of the case managers there know what's going on. I haven't had a meeting in over a year because they keep getting canceled. And all they say is that we don't know because we're waiting for the board. They throw the bucket at the board, and then the board says something different. This program I've already spent almost $40,000 in this program. And now they have all these new requirements. There's so much retaliation with this program. If you complain or disagree with anything, they automatically send you to drug test the next day. And if it's a hair or blood, it's even better because, of course, those are between $400 and $500 a piece. The case managers, there's so much inconsistency. One says one thing, the next one says a different thing. There is no connection with anything. Now, as far as the medical issues, I have turned in 2 letters from my neurologist with statements saying of why I have restrictions. And they still told me, you still have to volunteer. I have already exacerbated my injury twice. And this is really sickening what they're doing to us. That's really all I have to say about this.
Thank you for your comment. Mark would like to make a comment. 1 second, please.
Hello?
Yes, sir. Go ahead.
Okay, I'll keep this brief. Mr. Lawler, we are in fact required to have a sponsor. It's in our contracts. This program has seriously deviated from a recovery-focused program to one that feels very punitive and more difficult to complete than probation. Ms. Fagan, several colleagues come in for DUIs and they are being forced to work with narcotics despite having never had any previous history of narcotics access or passing. Ms. Trujillo, as you spoke out earlier, you would never request an alcoholic to go into a bar and be a bartender. So I'm not sure why it is in the same logic to force a nurse who had a problem with narcotics to return to bedside and to be forced to do something that they are not wanting to do, that is against their will, and that lacks clinically validated evidence that would suggest this nurse would have a longer, meaningful recovery than a nurse who did not meet this requirement. Recovery cannot be guaranteed by any regulation or any statute. It is a day-by-day process, and there is no requirement that can be placed that would increase the safety of that nurse long-term. It is something that is a day-by-day basis. As a CCRN, I had to interview 30 times before finding a position an hour away from my house that would allow me to fulfill the requirements. I went 1 year between decks, and in that 1 year between decks, the program requirements flipped on their head, and I was told I have to pass narcotics in order to meet the requirements of the program. And I now must commute 1 hour each way for a 12-hour shift, 3 times a week to meet my requirement. The program is not more individualized. It is less individualized, and these statutes are being blanketedly applied to all participants in the program. Transition was not something that was granted at a time frame. It was a personalized thing that was amended based on your progress through the program. The goalposts are continually moved. We have no idea what to expect. So it is with these statements that I urge you to look further into this program and really evaluate the sentiment that Ms. Melby and Ms. Johnson are conveying.
Thank you for your comment. NP Watching would like to make a comment. 1 second, please.
Thank you for the opportunity to speak. And I want to thank the members of the board who asked so many good questions, facilitated such a good discussion. And with all due respect, I just find Ms. Melby's comments quite dismissive. And I disagree with many of the things that were stated participating in the probation program and being in the nurse support group. But also, I just wonder, it seems like there should be some evidence like presented or some literature, being that we're nurses and we're into evidence-based practice. And I don't see much of that. And I'm just wondering if there could be further investigation if we're trying to make a decision today. It doesn't seem like we're trying to meet a specific regulation or statute, and there's not a lot of evidence. I'm just confused. It seems like we hear a lot of different things at different meetings. Thank you.
Thank you for your comment. B would like to make a comment. 1 second, please.
Hello?
Yes, go ahead, ma'am.
Hi. Thank you for giving me the opportunity to speak. My main concern to voice today is in terms of work stipulations for newer participants, as many of those who have spoken have been in the program for a long time. I'm being told that I and other participants may or may not be approved to work only part-time, which is a new mandate, while those that have been in the program were able to return full-time to practice immediately. Stipulations which I can make no plans for further employment and therefore income. All of my experience is in patient care, and I have a job waiting for me that I voluntarily took leave from, that is in patient care, with no history of narcotic diversion, abuse, nor impairment, as I was brought in on a DUI. It will be extremely difficult to find a new part-time job with no patient care when I have no experience in that sector, and will most likely not provide health insurance, and in the meantime be expected to pay all costs associated with Maximus. Therefore, I'll have to cover all the costs. Testing has been $500 a month, plus psychiatry, therapy, aftercare, and any other costs mandated, without health insurance to leave my current job, which has full benefits. This totals to thousands of dollars, which I don't have. I'm also being told that the board must approve any outside job of the nursing industry, which is severely limiting a person's ability to procure income in a job market that should in no way be overseen by the BRN or have association in utilizing my nursing license. Thank you so much.
Thank you for your comment. Tara would like to make a comment. 1 second, please.
Hi, my name is Tara O'Flaherty. I'm the Director of Nursing at Lifelong Medical. I've hired a number of nurses that are both on probation and diversion. I've had exceptional experiences with them. It has been incredibly rewarding, actually. The only issue that I've had is the challenges that have come up with navigating these programs. I currently have 3 nurses, and oddly enough, I was interviewing a nurse in diversion while this meeting has been taking place, who joined to watch it with me instead of me interviewing him, because I thought that it was valuable information that he should hear. I have also promoted 3 of these nurses. One is now an MP within our organization, into positions of leadership once they've completed their programs. The 3 nurses that I have currently in diversion, and any nurses that I would like to hire, I will not be able to maintain them and keep them full-time, which I need, and I depend upon them for our multiple programs and for our patients. I have been trying to jump through hoops that have been thrown in my way, but only verbally. I've seen nothing in writing about how to accommodate this new requirement that they have availability to pass narcotics. Initially, we were told that it could be controlled medication. I organized a transgender care clinic so that we could pass and have these nurses provide hormone replacement therapy. I was then told that that was not sufficient and that it needed to be narcotics. Nothing, again, in writing. I have tried to accommodate the requests of the BRN, I suppose, or Maximus, to ensure that we can continue employing these nurses who we depend upon. And it has been an absolute nightmare. And from my perspective, it is much easier than what the nurses, many of whom have spoken about their experiences. I've watched these nurses, they have panic attacks. They've called me. Luckily, they trust me enough to speak to me about their experience because I've left a very open door policy around this with no judgment. And it is shocking what they have been subjected to. I have actually hired a nurse who had her license completely taken away in a support role, not.
Thank you for your comment. You have exceeded your time allotted. Sandra Benrostro would like to make a comment. 1 second, please. Sandra? Yeah, we'll come back to Sandra. Amanda would like to make a comment. 1 second, please.
You hear me?
Yes, ma'am. Go ahead.
Hi, thank you so much. I wanted to speak quickly on one of the questions that the board members asked regarding if the participants were informed when we started this program about what the contract was and what the requirements were. When I first entered this program, I was told to watch a video, which is actually on the Maximus website. In order to complete the program, there was nothing in that video about having to do patient care at all. It was just to maintain sobriety with a minimum of 3 to 5 year program. Maybe it had said safely practice as an RN, which could or could not have been in non-patient care. So I don't agree with the fact that we were told and informed adequately. I feel like it was very misleading, and now it is completely changed. Our contract has completely changed. We were kind of pigeonholed into that contract. It was kind of a lose-lose situation. Like either you sign this contract and voluntarily enter this program, or you may have to get a lawyer and we might be coming after you. It was kind of like, all right, well, I guess I have to sign it, even though it might be modified. What am I going to do? And secondly, the individualized care. Every single one of us, by numerous case managers, regardless of alcohol, narcotics, whatever it is that brought you into this program, has been told that these new requirements to do patient care and pass narcotics is mandated. So I don't know how it was an individualized thing. I had my IEC recently, and I stated my individualized case, which I have very good reasons to be exempt from this new requirement, and they did not exempt me. I still have to meet this requirement, and it is not an individualized program, in my opinion. I just feel like we're trapped and there's no way out, and we're all very scared about what's to happen. Please take that into consideration. I feel like this new requirement should be for the new people coming on, not for the people that have already had contracts, but for new participants. That I understand, but not for the people that have already signed a contract that said otherwise. It's completely misleading and false. Thank you.
Thank you for your comment. Mary Haggerty would like to make a comment. 1 second, please. Mary Haggerty. I will come back to Mary. I have anonymous CA, but they are not in the list, and they've been in there many times, so I'm just going to go that. David would like to make a comment. 1 second, please.
Hello?
David, go ahead.
Yes. First, I've been in this program as a participant for a few years now. And, listen, this program is great initially. It brought me to recovery, and I'm so grateful for it. I'm grateful to be back to work. I think the program itself initially set up masterfully. The issues have surfaced in the last few months or 6 months or so. One of the biggest problems that I'm seeing is participants, if they forget to check in one day, or they have a dilute urine for maybe they worked out, or who knows what the reason is, they're now taking these participants out of work for 30 days minimum. And they're also restricting their hours once they go back to work, back to part-time, rather than simply testing that individual the next day and maybe waiting for a result. This has catastrophic results for not only the participant, who's most likely going to lose their employment, and it's already hard to get another job, but also for the employer. The employer is not going to want to employ participants who, if they have urine one time, despite having a clean record for years, this just has catastrophic results. And I don't know why or who came up with this plan, but this needs to be reevaluated. Another point is I belong to a recovery online group of participants in multiple states. And it is well known that California has the most punitive program there is. And lastly, I understand the heavy hand that needs to be taking place when a participant first starts the program, but there needs to be a track that allows participant to graduate, and decreasing maybe the amount of times they're testing, maybe the meeting requirements, maybe these other requirements. So it allows them to transition back to their normal life in a transitionary state, rather than just going full head, full steam the entire time. And that's not happening either. And that's recently changed as well. Thank you.
Thank you for your comment. Kathy would like to make a comment. 1 second, please. Okay. Sherry Gillies would like to make a comment. 1 second, please. Yes, ma'am. Go ahead.
Okay. Wow, lots of things have been said. I am a co-facilitator with Molly Shirk in Oakland, and I was in that training that happened, and my experience in that training was not the experience that was described. It was very much an overview of the program. There was no clarity given to us about what was going on and being said from our participants in our support group. And like the participants in our support group are very, very much sound like the people that are speaking here today. Just, people who have had a DUI that are now told that they have to go give narcotics, change jobs, find other jobs. So yeah, just echoing that. I don't want to get into too much that's already been said. The last thing I'm going to say is that I was a participant in this program, and I was devastated at the thought I would not be able to go back to my job at Kaiser. And I, wow, emotional, but I found a home at Lifelong. I work with Tara, and it's been such an amazing experience to be able to find a home there and grow into management positions, and be at an organization that hires nurses that are going through this process, and the fact that this could discourage people from hiring nurses, it hurts not only the nurses, but it hurts the communities that these organizations serve. So, yeah, really, that's about all I have to say. Thank you.
Thank you for your comment. Sarah would like to make a comment. 1 second, please.
My name's Sarah. I'm also a participant in the program. There has been a lot said. Thank you so much for your comment. I just want to clear up a few things. Number one, I'd like to point out that there is no communication with the board. Dan expressed this earlier. He's correct. One thing that maybe needs to be clarified is when we meet with the IEC, we have a very simple discussion. How is your 12 steps? How are your meetings with your sponsor, etc. And then we ask for some kind of maybe change in the program. Maybe we want to go back to bedside. Maybe we want to go back to work. And then they say, we'll consider the change and we'll let you know. But there's no open forum. There's no room for open discussion. Any discussion is through the case manager, which means we're playing telephone. There's also no written discussion. So we don't have, other than the contract or the agreement, we don't have any paper trail with emails. So that's also that they can say one thing and then say, we never said that. Also, we're not considering, it's been expressed that people who have been working a case management job and have no bedside experience, it will be hard for them to find bedside experience. But what about those of us who we have bedside experience, but it's quite expired? We've been working in, case management positions for some time because that was what was required of us. On the application, we're weeded out immediately. It will say, do you have 1 year of experience in this field in the last 3 years? The answer is no, and then we're not a candidate. Combine that with the fact that we're going to ask for that job with no NARC access, meaning we can't fulfill the basic requirements of the job, and then it has to magically turn into a NARC access job. It also has to be day shift. We know no one starts out on days. We have so many restrictions. I would plead for you to make this a definitive no, and that nurses won't have to quit their jobs, because they will have to quit. If you work 40 hours and they let you work 48, you're not going to be able to accomplish this. You'll have to quit your job. So please, please make it clear to us that we don't have to quit our jobs. Please. Thank you.
Thank you for your comment. I'm going to go back to Sandra. 1 second, please. Sandra, there's a, there you go. Good job.
Everyone, good afternoon.
Go ahead.
Thank you. I just had a couple of questions in regards to the financial aspects. What is the financial gain that Maximus has for each RN in their program? And is it a business model to keep or prolong the RNs within the program for their financial gain? And also, is it feasible to have an independent review of Maximus and or survey the RN participants so that we could have a better picture of what is going on? Thank you so much.
Thank you for your comment. Ashley would like to make a comment. 1 second, please.
Hi, can you hear me?
Yes, ma'am. Go ahead.
I just want to make it very clear that there has been zero transparency as to what is required to graduate. It has been so unclear that even Maximus case managers prep participants for completion just to come back and blindside the participants with additional requirements added, and that the participant is further extended to meet the new requirements. There is zero communication provided, neither from the EC nor Maximus. It should be noted that this program is no longer voluntary when you have committed well over 3 years and thousands of dollars. At this point, none of us are free to leave. We deserve to be spoken to like human beings. Thank you for your time.
Thank you for your comment. Sophia would like to make a comment. 1 second, please.
In the Maximus Diversion Program since
2016. I had a relapse and therefore my time was extended. I currently have 4 years of recovery. I work with foster children as a public health nurse doing medical case management. My experience has changed drastically over the years, obviously. However, currently in the program, I'm also being told I have to do bedside care with narcotic access when I've never had a patient care job. I've always worked in a different type of nursing. Was due to complete the program early this month and was again told, nope, you cannot complete yet. We have to return in August. I think this is ridiculous. I don't understand as to the logic. It's obviously a non-clinical person making these decisions. However, the fact that my current position, I'm told either I don't have to leave my job, we're not telling you that. So do you want me to get a second job? We're not telling you that either. So what exactly are we being told? Because Maximus doesn't even know themselves. They don't understand what's happening. So how can we therefore understand what's happening? This is ridiculous. It's not clinical decision making and there is no logic behind it. Thank you very much.
Thank you for your comment. Anna would like to make a comment. 1 second, please. Anna, go ahead. Yes,
Hi.
go ahead.
Oh, wonderful. Thank you. So it's very easy for somebody who's not actively looking for a job to say how easy it is to jump from one job to another. Getting a job for most of the participants takes a month to 3 months, 6 months to over a year. So the fact that anybody thinks it's very easy to graduate this program at some point and just say, oh, I can go back and then easily go back to your previous job of advice nursing hasn't had to find a job or deal with that. For 5+ years, participants have been told that their certain requirements are individualized and that's why it doesn't match other participants in the program. And now we're being told that they've never been individualized, that it was just a standard for everybody. Transition, you get transition for some participants if you violated your contract in any way, and you would get at least 3 to 6 months, if not a year more, to before you could even ask for transition again. This so-called not requirement is being enforced, and nobody's being transparent about what the participants are being told on Maximus Diversion's end. It would be very, very in the best interest of the participants, the board, and the public safety for the board to actually look at some of these contracts, review all of these contracts, and look at the differences, the dates, the changes. Some people have gone for a full year or more without an evaluation committee meeting, and they're being told on something that hasn't been voted in yet to get their narcotics job. Some of these nurses are senior, older, and need a retirement job. They should have no business going into acute patient care or narcotics jobs or anything else if they're not wanting to do that. 50-year-olds, I don't know too many 50-year-old nurses who want to go back to, this chaotic patient care that's already in the hospital, or any other organization with narcotic access. There's a lot more to say. It's a very short amount of time. I'm thankful for the board and that they're asking these questions.
For your comment, you have exceeded your time allotted. Mary Molly Shirk would like to make a comment. 1 second, please.
Thank you again. I'll be very brief. I've been a group facilitator for over 20 years. And my overall impression that what a lot of these participants are experiencing is not so much directed from Maximus, but it's coming from changes from the board. Thank you.
For your comment, Chris Elf would like to make a comment. 1 second, please.
Commented.
facilitator for San Luis Obispo and the surrounding areas. Just again, thank the board for putting this on that topic agenda for today. And this was possible present you with a hypothetical scenario, basically that will answer kind of the question about this. Nurse A, we're going to say this, she has a history of serving severe chemical dependency and diverting of meds. She has gone through rehabilitation but still has trouble thoughts of thinking about narcotics, and she does not want to be around narcotics in her practice. So she's already stressed out that her license is under is under intervention, and she's most likely having problems at home with financial needs, other problems, and she asks Maximus or the board that she doesn't want to take a job that's involving in narcotics. Well, to get her job back, she's required to now pass narcotics in a nursing home now that she has to find a second job, and working in this nursing home, she comes in contact with your grandmother. Your grandmother is now under cancer treatment with severe pain, and she's on lots of narcotics. Now, this nurse who's already on thin ice is now taking care of your grandmother. And what is going to happen? I think it's just inevitability if we're using this metric to prove whether nurses are safe to practice. There's eventually going to be a nurse that is going to do some harm because they're being forced to do something when they know they should not be doing it, just to placate the program. Eventually, there's going to be an outcome like this, and they're going to look back at this committee meeting and say, why was this metric used? Is this a metric that is, all of us in recovery would like to have a metric to prove that we will not relapse again, or they will not relapse again. I don't know if handling of narcotics is any proof of that. I think it will just end in disaster. I don't think that's safe for the public, which the board and nursing is all here for. I think we're looking at this in a different way. I agree there needs to be a good metric that will show if nurses can successfully handle narcotics again, but I don't know what that is. I don't know if that's more testing, more intervention by social work or psychology. But I don't think this is the right metric to be used in this manner at this time. And thank you.
Thank you for your comment. Mary Haggerty, I'm coming back around to you. I see you on here twice, so I'm going to try the one with the headset. Okay, I'm going to try this cell phone. So on your computer, there you go. Are you there, Mary?
Yes, I am.
There you go.
I first
Mute,
want to say
mute your cell phone, you're echoing.
let me shut this off. I first want to say thank you for having this meeting. And I have been involved, oh gosh, that thing is talking. I have been involved with the Board of Nursing diversion and probation programs since 1997. The first issue I would like to address is that the agenda item presented by Shannon Johnson, the Enforcement Diversion Chief, is about Uniform Standard number 12, which is she's asking for that nurses return. They are required to return to patient care with or without access to narcotics in order to successfully complete the program. We don't need that. It is not relevant to the intervention program. Nurses are monitored very closely on a lot of frontiers to substantiate not only their sobriety, but their stage of recovery. So I really see this as not necessary change in legislation. The other concern I have is that this has been implemented across the diversion program without having legislative changes. One more quick comment. Since Shannon took over as the Enforcement Division Chief and her appointment of the Intervention Program Manager, they both are coming from a probation background and appear to have very little knowledge of substance abuse recovery and treatment. Our prior manager of the intervention program representing the Board of Nursing attended all IECs so that they could do their input at the meeting, and the nurses didn't have to wait up to 2 weeks to get the report. Thank you, and I hope you, the board, are hearing the serious issues that are facing all the nurses in the intervention program. Thank you so much.
Thank you for your comment. Kathy would like to make a comment. 1 second, please. Kathy, if you're on your computer, a box will have popped up that says you've been unmuted, and you have to click that box to be able to speak. And it might be behind something that you have open. Okay. I tried. Bob would like to make a comment. 1 second, please. I'm going with lowercase Bob.
As a lot of participants are talking right now, I just hope that people understand like how much this is changing everyone's lives. I don't think that the board really thought through any of these things. Recovery, if the board is gonna, force recovery and we all get into recovery, you work with your sponsors, you get very, you're supposed to protect your recovery at all costs. And then to force a participant to go back into, get a different job, what have you, working with narcotics, it just doesn't really make any sense. Yes, if you want to go back to bedside, yes, handle narcotics. But for us to handle them, it's going to be like in a sniff where we don't exactly maybe want to work. Or if like that gentleman that talked about the grandmother, like in my case, I've had all this pain issues. You're going to put someone back that has like maybe a higher chance of relapsing into that scenario. Like that just doesn't make sense. And then for my case, I was supposed to graduate on the 7th, and they're not letting me graduate until I can go back to work. I have not been able to walk for a year and have been in and out of the hospital all over the place. So I'm just kind of stuck in the program. I have no idea when I'm going to be healthy enough to go back to work. I've never had a major noncompliance. I've never relapsed. And then the case manager tells me that they could dismiss me from the program, even though I've never messed up. I obviously can't change what's happening to my body, and I don't know when I can go back to work. So I guess I'm just going to be spending, like going to get a loan to pay for my bills because I can't financially afford anything. I don't know, but I just think the board needs to really think about all of these changes and what they really actually mean for us. Thank you.
Thank you for your comment. Jody would like to make a comment. 1 second, please. Jody, go ahead.
You hear me?
Yes, now we can. Thank you.
Okay. I just want to start with, if playing devil's advocate, I can understand what was mentioned earlier about, only having one RN license and the ability to pass narcotics with that. I get it on a case-to-case basis. But to change, for example, a nurse's recovery program that's been in the program for 3 years with 100% compliance, and tell them all of a sudden that they need a new job or, a new approved BRN therapist after 3 years, it just seems very cruel. If this was to be implemented and to new applicants for the program and they are aware, I believe, that would be a different story. But to like uproot these people's lives it may seem easy on paper, but like I can assure you it's not. But these nurses will do it. This group of nurses that you have are some of the most amazing people I've met. They will do it. And then, so they will go out and try to find these jobs for narcotics. But then there's a stipulation of, oh, it's only 8 hours. I don't know who made up that 8-hour rule, but it is nearly impossible to find a job where you're only passing narcotics for 8 hours. I want you to really think about how feasible that is for these willing nurses. It feels very much like being set up for failure. So lives are being disrupted. And as you can hear from the previous speakers, but these nurses will do it. They have worked so hard and their willingness to succeed is highly commendable. So they'll continue to do what they need to do, unfairly, unjust or not, but they need your help. So I highly encourage both the legal and moral investigation into this program. Thank you.
Thank you for your comment. Committee Chair Nguyen, there are no other public requests for comments on the WebEx. Do we have any public requests for comments there in BRNHQ?
No, we do not.
Thank you. Would you like me to close this window?
Yes, please. And I would like to recognize President Trujillo.
Just a quick question, Shannon. Is there a process by which we survey and receive feedback from the participants during this time that they're doing their program? Is there a survey process?
Not during, but I do believe that Maximus does put out a survey at the end of the program. But we could look into if the
Yeah, you
board
might want to
would
think
like
of one during, at some point
Mhm.
in their program, maybe 6 months in, a year in, something to receive feedback so that we're hearing it through the feedback and not public comment.
Yes.
Thank you.
If I could just maybe make a statement, which is, this has been a very difficult conversation. And, the participants of our program are clearly frustrated, and they're actually in a program we'd like them to be in because we'd like them to get well. I think, and then we've heard some stories through public comment that confirm our worst fears. That someone who got one DUI 3 years ago, who was ready to graduate, gets sent to a narcotics, which, Shannon, I know you don't think is the right approach. At least I think I understood that from what you said, that if there's diversion, that's one thing, but if it's a single DUI, from a long time ago. So what I do think is clear from this conversation is that we don't know enough to make a good decision today. And I would like to send this item to committee, and we'll meet in a couple of months, and
In 1 month.
in 1 month, and we'll discuss this and try to come up with an approach that is fair and respectful to our participants and also meets the needs of the treatment program. Go ahead, please.
Thank you, Board Member Patel here. May I make a request in addition to what Board Member Nguyen just stated? Is it possible, and this might not be able to happen in the month, but is it possible to survey the other 7 boards that Maximus is part of to see if they're experiencing similar situations with their members?
Yes, we meet with them on a regular basis, about every 2 weeks right now. Yeah, we can poll them.
Go ahead, Board Member Cormack.
Thank you, Chair Nguyen. I think this is an appropriate course of action. It has been a difficult day and it's not over. We have 9.3.2 to come, and I don't feel that we have enough data to make our decision today, even to decide, what changes need to occur. As I've been listening to this, I've been reflecting on, and hopefully this is something we can cover in committee, Not a comparison to probation in terms of the general part we went over earlier, but specifically, often on probation, there's a 6-month work requirement in a board-approved nursing position. I have no insight into what the board, because that's board staff, approves as a position. So one thing that would be helpful as we make this decision is if a nurse is in probation for narcotics diversion, is it the board's practice to require that the supervised work be done in a setting with narcotics? That's a yes or no question, and that will help me when deciding how do we know if a nurse is safe to return to work. So I think I'm not asking for a big presentation, but on these very crucial issues where we have a whole different program with people with similar, so for example, a DUI, right? If someone is on probation for a DUI, do we require them, is their board approved nursing position have to include passing, I don't know, I know you guys call it that, but it sounds like you're passing notes, administering narcotics. So I agree that today is not the time to make a decision because we are lacking crucial information, but we as a board have some access to a parallel program, and that really will get to a variation on the question that Vice President Hagan asked earlier, which is, have we seen this problem occur? Have nurses completed this program, the intervention program, gone back to direct patient bedside care, and had problems? So I know this has been a really rough day, and I want to acknowledge that everyone has First Amendment right for freedom of speech. I want to acknowledge this has probably also been a hard day for members of our board staff who are figuring out what needs to be done and what needs to change. So both of those things can be true at the same time.
I'd like to make a comment if I don't know who's in the room.
Yes, please, Mary.
I have never been moved by public comment the way I've been moved by public comment from these members that are participating in the intervention program. And it's clear to me that they are traumatized. And that is absolutely the last thing we want to do for someone who's in rehab or in recovery, is to add this trauma. It appears to me that there was some change that was made without board intervention in the past 6 months or something, that even though Shannon, you said it's not been blanket, we've heard from many people who said they had a DUI and now they're being required. I think whatever change was implemented 6 months ago, I think we need to make a change now, because not only are we traumatizing these participants, I do think, as one of the public commenters have said, we're probably putting the public at risk by forcing these people to go out and get a job where they shouldn't be doing it for a multitude of reasons. So I'm hoping that today, even though taking it to committee, I think is definitely the right thing to do going forward, but I feel like there's a mandate to act today, and whatever was implemented 6 months ago or whatever needs to be reviewed, and in many, many, many cases, I think, reversed.
Reza, I do have a question. Are we able to hold a special board meeting in like 10 days or so that we can get the statistics of how many people have been affected by this change, and
You
have
could
their
have
information
another,
reviewed?
you could have another board meeting at any time as long as you notice it 10 days in advance.
Okay.
If you're talking about I don't think you're talking about doing it on shorter than 10 days notice. As long as you're giving a 10 days notice and posting the agenda, that you can plan a meeting for any time.
Okay.
Mhm.
Yeah, what I'm concerned with, and I don't have all the details here at all, is hearing a lot of these things today definitely was moving, definitely was eye-opening. If this was made by a committee of 3 nurses, a physician, and a public member, by reviewing individualized cases and they determined that this was a requirement for this person to safely return to work, I would hate to see that removed based on public comment here. I would love to be able to ask the board for some time for our staff to get the data to find out how many people were affected by this change. What is the reasoning that is around that change, and weigh the risk to both the participant as well as the public, and bring that in front of our board for a discussion, of course, continuing to keep confidentiality here. Because although I do hear what they are saying, I do know that there are sometimes mitigating factors that are maybe not shared or presented or available for us to take that into consideration. And by reverting to the prior plan effective immediately today, I would ask that to be reconsidered. And we don't have to wait a month for committee. We don't have to wait until August for the next board meeting to make that. We do, as Reza clarified here for us today, we can notice and have a board meeting within 10 days if that's what needs to occur. But I do need to check in with Shannon first to see how long do you think that it would take to get that information so that we can have a board meeting to have a discussion on what those changes,
Well,
what is the number of the changes there?
it would just depend on to what extent you want information. Would you like me to go back to every IEC over an extended period of time? I don't know how far back you want me to go and pull up each individual case that was seen, what the outcome was, what their case was prior, and then post outcome of the IEC. And then it also brings up, there are, like Lori said, mitigating factors sometimes in that IEC discussion in closed session that would need to be shared with you in order for you to understand that. And in open session, we can't share that because of the confidentiality of the program. A lot of things are not shared here today. So I would need some direction on exactly what you're looking for. And then I could provide you, I would work very diligently to have that as soon as possible if you wanted to meet in 10 days from now.
I appreciate that. I know that any materials that would be put public would go through legal review, and we would not obviously share anything that could jeopardize that. But I agree, Mary, that we need to act sooner than later. One of the common things that, again, I heard that I want to reiterate again is the communication aspect. Communication to the participants. And Shannon, can you tell me how do our board staff, including Jaspreet, myself, you, or anybody, have the ability currently to be in communication with the participants, or has that been delegated to Maximus solely?
No, we do not have communication with participants. Their point of contact is their Maximus clinical case manager.
So what I'm understanding then are these changes that are occurring are being communicated to them by the CCM that is employed by Maximus. Are we aware of what is being communicated, how it's being communicated? Are we aware of any kind of materials or training that went out to them to convey the changes? Because again, if we have these changes in the recovery plan being taken care of and Maximus is communicating it, is it being a blanket statement that's going out there that says, hey, now the BRN is requiring this, and that's not inaccurate? Is it fear-based where they're saying, oh, we're hearing BRN is requiring this, and so then everybody thinks that that's going to be their requirement? And I think my follow-up question to that is do we have an ability to take action on, not take action, I don't want, that sounds really negative, to address any of the communication issues that may have occurred through this change process that could recenter that not everybody is being required to, and that in our understanding through your presentation today, that if it is a DUI, you should not be having to be required narcotics passing, if that is solely the issue, and really kind of put out some of those kind of statements so that we can provide that clarification so that people that are going through this have some kind of sense of understanding of what they're signing up for.
Okay, so first, you do realize you just asked me about 10 questions.
Probably.
So I'll try to address this. Yes, we have a means to address possible communication. We do meet with Maximus and their executive staff, I believe on a monthly basis right now, monthly, yes. And then we do meet with the clinical case managers and the Maximus staff about once a week right now to try and address any of the issues that are coming up. Do we know? I mean, I wouldn't know what's being said. Apparently today, some communication is definitely not what I had anticipated to hear or wanted to hear. Fortunately, because of the confidentiality, I would love to know the specifics of some of these cases so I could actually do research and look into them. Because I too am a little surprised and taken aback by public comment. I can see and I feel the stress and the impatience and the hurt and the place that they're in. So I want to address them, and I can't remember the other 8 questions you asked me.
That's okay. I don't think I can either. It's a very
But
emotionally driven
I
kind of
do.
response.
And so I'll say anyone listening right now, if you want to send me your case, I mean, we're willing to look at them and to, you know, maybe have you go back before the IEC to have your case looked at. I wouldn't want anyone feeling like they've been displaced or they're out in limbo floating around with not knowing what's going on.
Yeah.
They do have, and I want to say they do have monthly calls with their case manager every month. So if there are concerns, I would just hope that those concerns are brought to the board.
And I think just for clarification real quick, the monthly call with their case managers is a Maximus employee, not a board staff employee. So we may still not be aware of what is being communicated in those monthly meetings. And so again, the people that are choosing to participate in our intervention program, if you are hearing these things, if you're running into these things, if you're experiencing these things and you're not getting the responsiveness from your case manager at Maximus, we need you to reach out to us. We need you to contact Jaspreet, Shannon, myself, Yvonne, anybody at this point, and we will do a look into what is occurring. Because I know that you guys did hear me state that of the 250 participants that we have not been hearing that, and that's an accurate statement until today. Today is where I am hearing this, as along with our board members as well, that we are hearing this. And I can tell you that the understanding that we had going into this is completely different than the understanding that we're having coming out of this. And we do want to address this, and I will give you my word that we will be addressing this, and we will try to do it in a very expedited manner, and we will move this along as quick as possible, so
Thank
because
you.
you guys do matter.
Thanks very much, Ms. Melby. Board Member Cormack has a question.
Thank you, Chair Wynn. We've evolved from let's send it to committee to we have to do something to today to we have to do something in 10 days. So I just want to catch up in here and say, I think it's a lot to ask of individual participants to have to reach out to do this. I would prefer if what the BRN staff takes away from today is we need to do, I'm going to use informal audit just as a construct, meaning, you know, not on a request basis, but on a sort of like systematic basis, go in and I'm currently at this moment less concerned about what happened 4 years ago unless it affects a participant here today. But what are the participants, the 250 that are, you know, the nurses, what stage are they at? You know, do they understand, you know, what is left on their plan? And, you know, obviously there are a few other things we've talked about. And And I'm guessing, thinking out loud, that the IEC at some point is going to have to be involved for each of these people if they want to come back and petition for changes or modifications or whatever. So I'm thinking out loud, there's got to be some work done on understanding the scope of the problem, which we have a lot of information about today, but not complete information. And secondarily, a short-term plan to do those modifications. So again, it is not a responsibility of a board member to manage operations, but hypothetically, it'd be great to get the IECs ready to, to review things, because obviously some work needs to be done, and communication is a whole separate point. But as we've evolved around, I don't think this means the committee shouldn't be reviewing, the individual committee, sorry, the EIIC board committee, goodness me, shouldn't continue to meet in June. I'm sorry, Shannon, you're going to have Ms. Jones, Johnson, you're going to have a very busy time here, because there is data we need to manage going forward to see, how this works. But separately, I think Vice President Fagan has really hit the nail on the head by saying we need to do something more urgently. But I just want to be clear that I don't think it should be the responsibility of the individual participant to ask for an update. I think we should be doing, and staff should consider doing. That's a lot of shoulds. I'm going to modify that. I think staff might. You understand what I'm saying.
We hear you, I promise.
Can I ask one follow-up question?
Yes, Mary.
It's hard for me to believe that these decisions to change the terms came out of IEC meetings, because we heard from so many of the people in public comment that they haven't had an IEC meeting in so long. So I'm wondering if maybe the misunderstanding came in the communication to the case managers, and they are perhaps issuing a mandate outside of an IEC meeting. Is there any chance that that could be the case? And then that could easily be reversed.
I think at this point, anything is possible. And I think that we just need to continue to look into that and find out what occurred. And that will start by polling some data to find out who was immediately affected by it right now. And kind of working through, like, is there a common case manager? Is there a common IEC? Is it a common time frame? That kind of thing. And so I think honestly what we're hearing is November, I think, was probably the earliest public comment that said I was supposed to come in front November, and I got moved. And so I think we're looking at 6 months. So maybe if you pulled like a year, that would narrow it down a little bit for us.
Yeah, I think we will definitely be doing an audit of all participants and when their last IEC was, so we can ensure, because it really, that's a long time.
Yeah.
Board Member Lawler has a question, and then Ms. Granowitz. Yeah.
Process question. Due to the confidentiality of some of these issues, could that main part of the discussion be agendized in a closed session? And then we could say what we need to say out here presenting in an open?
The Reza question on that one.
So I'd have to look into that. In order to do anything in closed session, it has to be specifically, not just that it be confidential, it has to be specifically identified in Bagley-Keene that we can discuss that particular type of thing in closed session. So if you're talking about individual applicants, obviously that's something you wouldn't want to do in open session, but I'd have to take a look at whether that's permitted in Bagley-Keene.
Ms. Granowitz?
First, I wanted to apologize to the board and to the public if people saw me grimacing and walking around. It wasn't directed at you. I have multiple sclerosis and my body has gone into spasm. And so that's why I'm grimacing, because I'm actually in pain. But that being said, and I was out of the room, but correct me if I'm wrong, what I remember hearing at a previous meeting is that the changes were made because of some specific mandate that had to be put into effect. So was that true? Because if that was true, it's less important who the messenger was than figuring out if there was a reason why this change occurred. And I'm confused about that, but I'm less interested in sort of a witch hunt, but there's clearly a disconnect and something is wrong, and I don't care that much. But I'd like to know what real is, because right now I have no idea what real is, but what was real was the pain
Yes.
and the lack of a certainty for any of these people, and that's certainly not what we're about.
Yeah, I think what needs to occur to find out what real is to start with the data poll, to find out that, because as our board staff is involved, again, that communication does happen through Maximus. And we need to find out who was affected, how many were affected, what that effect was, and then find out if it is a board staff issue, is it a process issue, is it a communication issue, and then move through that process. But we don't have answers at this point other than knowing affirmatively that this is something that must be assessed and addressed.
I have a follow-up then. So this was 9.3.1.
Two.
We did get through 1 and 2.
We're wrapping up 9.3.1 and we will be entering into 9.3.2 next.
Which I'm pretty sure we're going to end up hearing the same.
I would hope not. I would hope that that is a separate agenda item. It does have a separate topic that is not as charged as the narcotic access one. And so
the only reason why I would disagree with you is that we heard a lot of this during the last item.
Yes.
And we heard it. I'm sort of surprised you guys are surprised, because we got plenty of warning that this was coming during our last board meeting. And so I think what happened is the public who's been impacted got put on notice at the last board meeting. And it's certainly what I would have done is I would have talked to my friends and said, I don't think they're hearing us. So we need to show up en masse. So all that being said, I'm sort of wondering, it's 1:20.
Yes.
We're not going to get through the agenda, all of it. And I guess you guys are going to need to regroup and let us know, because there are also the disciplinary items.
In
And
closed
I
session.
don't really want to keep those people having to wait another 3 months either.
Correct. So we will need to take a lunch break, probably until 2:00. And that'll give me time to work with legal as well as other board staff to find out how we will proceed with the rest of this meeting. And when our next board meeting will be scheduled, probably within the next 10 days. Because we do have legislative positions that do need to be heard and taken. And we do have disciplinary cases in closed session that do need to be heard and taken, as they are legally defined under some specific time limits. So we will have to have a to-follow board meeting relatively soon.
Will you be finding out if we can do that on Zoom?
We will not be able to do that on Zoom. Bagley Keene does not change.
Okay, because that's probably going to be a problem for a lot of us.
Yes, and so we'll see about what the noticing requirements are to notice several locations, so that we don't all have to be present in Sacramento, but we can have some noticed throughout the state to accommodate the board members as well as get the board business completed.
So we will go ahead and break until 2:00.
2:00, we will return. 9 point, we will.
9
oh,
point.
And so before we break, sorry, there is no motion right now, or is the board members assuming that we will keep this as information and defer making any motion, or are we wanting to make a motion?
Yeah, I'm comfortable.
No motion? Do we want to take a vote on that? Do we have to vote on that to do a motion, or
We don't
a
have
motion
to
to not do a
vote.
motion?
We don't have to vote. If anyone wants to make a motion, they can individually throw it out there. But if nobody is inclined to make a motion, there's no motion needed to not make a motion. I think there's an awareness that there's some information and data to be gathered, specific things to be looked into. And then with regard to next steps on this particular item. I'm not sure if we left off on definitively scheduling another board meeting, or if that's or kicking it over to the EIIC committee, or is it going to be kind of determined as based on what board members' ability and availability is to hold a meeting soon?
I think it's gonna be board members' ability as well as stats availability. But we do want to try to get that done as quickly as possible. And we'll additionally add the EIIC meeting to the June meeting that will definitely occur.
Okay, so to recap kind of where we're leaving off with this, staff are going to work on gathering information in response to some of the things that were asked for. We're going to look into the ability to schedule another board meeting with the full board on 10 days notice so that it'd be a public agenda posted with the item described. That, of course, just for the public to know, that's going to be contingent on us being able to convene a majority of the board and comply with the Bagley-Keene requirements, which we can't overlook, and to do all that on fairly short notice. Again, keeping in mind that these folks all have lives outside of this as well, jobs and things. If I'm assuming if that can't be done, well, I understood that regardless of whether the special board meeting takes place, the EIIC will further discuss these issues. So
Yeah, and then during the break, we'll discuss how we'll manage the remaining agenda items here today and make a plan for that as well. Thank you.
thank you. So what time? 2 o'clock back here?
Okay, real quick before we start the board meeting, we did confer with legal counsel and our board president, as well as chief of ledge, not chief of ledge, sorry, ledge chair, as well as enforcement chair. And we do have a proposal to put out to our board members here on how to navigate through the next few hours of our board meeting, taking into consideration the agenda that is items that are remaining. It was suggested that maybe 9.3.2 be deferred to a subsequent board meeting and that we go into ledge. And then there are 3 bills within ledge that directly affect our Nurse Practice Act. And so we would love to prioritize those and get those heard. And then if the board does have additional bills that they would like to bring forward and discuss at that time, we could. And then at that moment, we would then recess into closed session and allow the STIPs and the decisions and stuff to go forward. The evaluation that was scheduled will be deferred to the next board meeting as well. And we will go forward with that. So if the board is okay with that, we will make those adjustments. Thank you. And I will turn this over now to Board President Trujillo for reestablishing quorum and then make those items occur. Thank you.
Okay. Okay, we'll do a quick roll call for quorum. Dolores Trujillo present. Vice President Mary Fagan.
Mary Fagan present.
Board Member Jovita Dominguez.
Jovita Dominguez present.
Board Member Tricia Nguyen. Board Member David Lawler.
Lawler present.
Board Member Vicky Granowitz.
Granowitz present.
Board Member Leela Patel.
Neelu Patel present.
And Board Member Allison Cormack.
Cormac present.
Okay, we have a quorum. We're ready to begin.
Good afternoon, everyone. I'm Marissa Clark, Chief of Legislative Affairs at the board. So I will start.
1 second, I'm sorry. You need to make the motion to defer, not motion, but say that we're going to defer 9.3.2 to the next board meeting so that we can address that agenda item and then move into ledge.
Okay. So at this time, before we go into ledge, I would like to make a motion to defer item number on the agenda 9.3.2 to our next meeting.
Next board meeting. Next regularly scheduled.
Next regularly scheduled meeting. Do I have a second?
Second, Granowitz.
Great. We'll take it to
No, just,
a vote.
you don't even have to do a motion. You had to make the statement
Okay,
that you were going to reorder or realign the agenda.
so I'm going to reorder, realign the agenda. We're going to take 9.3.2 to another meeting, and we will start with opening with 10.0, and this is legislation.
Good afternoon. So the first bill that impacts our Nursing Practice Act is AB 2015 by Assemblymember Schiavo. This is the board-sponsored bill that we did discuss at our February board meeting where the board took a support position. Just as a quick refresher, the bill would establish a new process for prospective nursing program faculty, assistant directors, or directors to obtain their approval directly from the board and then have that approval displayed on their RN license through the DCA license lookup tool, which would provide them somewhat of a portable credential. And so the main change that has happened to this bill since we last discussed it, and I believe Lori touched on this a little bit yesterday, was that we wanted to clarify that this new process would not override an existing exemption. So it would not apply to faculty, assistant directors, or directors that work at approved schools of nursing that are actively accredited by an accreditor recognized by the U.S. Department of Education, unless unrelated to the scope of their accreditation. And so this exemption was included in our sunset bill from 2022. And there was some stakeholder concern that this new process would conflict with or override it. So we wanted to make it very clear in the language that that would still stand. And then for everyone else, this would be the proposed new process. So that was really the main change. All the other criteria remains the same. But since it was a significant language change, we wanted to bring it back before you all.
Thank you. Does this in any way change that, with the changes that were done, does it change the process of how the bill is going to be carried out?
Not yet.
Okay.
Yeah, so as long as the language that is currently in print stays in print, then it is in alignment with our regulations, our statutes. And I worked with the committee to do that rewrite. And together we ensured that it went very smooth and it hit all of the areas that needed to be included to allow for the portability and to not interfere with that other provision that was put forth in a Sunrise.
This is Board Member Cormack. So the description on page 5 says the process would not apply to schools that are not accredited, but I'm not sure that's what I just heard from you.
Sorry, correct. So the accreditation right now, we have schools that are accredited through NLN, CNEA, ASIN, and CCNE. And those are nursing program specific accreditations that are recognized by the Department of Education, NCSBN, et cetera. And they specifically address in those accrediting standards, the approval of nursing program faculty. And so because that is addressed in those 3 accrediting bodies to date, we will defer to them for that faculty approval and will not hold them to our minimum standards. They'll be held to their minimum standards.
It's a typo.
Oh, thank you. That's what I thought.
Yeah, I
Okay.
apologize.
So one
Thank
of
you.
the knots needs to not be there.
Correct. Yeah. So I
That's
will.
confusing.
Thank you very
Okay,
much
great.
for catching
So-
that. On page 5, just so I can, in the amendments, and this was my typo, so I apologize. I put the bill as amended to clarify that the proposed faculty approval process would not apply to schools of nursing that are not actively accredited. That second not should not be there.
Yes.
No pun intended. Yeah, I apologize. So thank you for catching that.
Is the chair looking for motions?
Yes,
I would move that we support AB 2015.
and I will second it.
Public comment.
Yeah. Bureau moderator, can you please open this up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box. I would like to make a comment. Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Chris Elsey would like to make a comment. 1 second, please.
Again, it's Chris Elsigan. Oh, sorry, go ahead.
Chris, is this going to be public comment for the faculty approval bill?
I wanted to make one more public comment, not on that subject. It's just
Let me confer with our legal counsel. Since we are in an active agenda item, how do you suggest we manage that?
It's up to discretion of the board.
Do you want to hear him or give him? Chris, is it related to the prior agenda item 9.3.1 or the moving of our 9.3.2 or?
It's kind of the moving of the 9.3.2 because I was trying to get in on a little bit there, but.
Okay, can we ask that, do you have time to sit in public comment for just a few minutes longer so we can get through the public comment for this item?
Of course. I just thought this would be the.
And we'll leave this open so that once we're done with the roll call vote that we can take into consideration here.
I will be brief anyway, but thank you.
Thank you.
Kathy Hughes would like to make a comment. 1 second, please.
Registered nurse and the executive director of the Nurse Alliance of SEIU California. SEIU California is proud to support this bill. We lobbied on it at our lobby day a couple of weeks ago and would continue to support the bill with the amendments. Thanks so much.
Thank you for your comment. Sorry, we have no more comments. Were we going to, do we have any comments there in HQ?
No, there are no comments here in HQ.
Okay, were we going to continue? What were we going to do?
Yeah, hold this open really quick, Mark. Sorry, board moderator. I just gave away your super secret identity.
That's okay.
And we will go ahead and do a roll call vote and then we'll return it back to you real quick to hear from Chris.
All right, we have a first and a second on the floor, and we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Dominguez, yes.
Board Member Patricia Nguyen.
Nguyen, yes.
Board Member David Lawler.
Lawler, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Lilu Patel.
Patel, yes.
And Board Member Allison Cormack.
Cormack, yes.
Right, thank you.
Thank you. So board moderator, if you can have Chris give his brief statement.
Thank you. So I just want to thank everyone for listening to all our public comments and how you responded to them all. We sure appreciate them all. I just wanted to, well, it's in the board's thoughts. We talked yesterday about Maximus's contract ending at the end of this year. And I just kind of, with all these comments and everything, I just want to, again, I want to say how well I think the Maximus program has done in the past. And I just want to, I think Board Member Cormack talked about an audit, a little bit of an informal audit. And I just want to make sure that if we were to renew Maximus's contract for another term, that we're not using this as possibly against them, because I think the changes are coming from the board side with Shannon, Jaspreet, and that. And then I think Maximus is kind of getting the brunt of all of this. So I just want to congratulate Maximus for doing such a great job, over 90% success rate. They're the easiest to get a hold of. I just love working with Maximus. So I believe it is, I could be wrong. Maximus could be not representing their side as well, but I do believe a lot of this confusion is coming from the board side, and Maximus has gotten the brunt of a lot of this. So when they go for contract negotiations, I hope you would not hold that against them.
I can assure you that that will not occur. The contracting process with the state is a very neutral process, and that's not a process that we even have a lot of control over. So that will be managed appropriately. Additionally, an audit would be a neutral audit, and it's not an audit of Maximus, it's an audit of the intervention program, so that we can see what we are doing well and what we need to do improvements on, that start with board staff, including myself. And then bringing that forward and then looking at it kind of downstream as well. And that would be looking at our vendor, looking at communication, looking at participants, and so forth. So it would be a very neutral but very thorough audit. Thank you.
Thank you very much.
Thank you for your
Thank you.
comment.
We
Board
can
Person
close, we
Jalili.
can close the.
Oh, I'm sorry, we can't
public
close it.
comment.
Okay, perfect, thank
Yes.
you.
Thank you.
So the next one is AB 2578 by Assemblymember Flora. This bill was on our February board meeting agenda, but it was still in spot bill format at that meeting, so we weren't able to have like a substantive discussion. It has since been amended pretty significantly, so again, bringing it back before you all today. Under current law, a nursing student can only provide nursing services if those services are related to the course of study of one of the following: a student enrolled in a board-approved pre-licensure program or school of nursing, and a nurse licensed in another state or country taking a board-approved continuing education course or a post-licensure course. This bill would propose to add the following provision to that section. Nursing services can also be provided by a student who is a resident of the state and enrolled in a pre-licensure distance education nursing program based at an out-of-state private post-secondary educational institution for the purpose of gaining clinical experience in a clinical setting that meets all of the following criteria. The program is accredited by a programmatic accreditation entity recognized by the U.S. Department of Education. The board does not otherwise approve the program. The student placement does not impact any students already assigned to the agency or facility. The program does not make payments to any clinical agency or facility in exchange for clinical experience placements for students enrolled in nursing program offered by or affiliated with the institution or private post-secondary school of nursing. The program qualifies graduates for licensure in California. The program maintains minimum faculty to student ratios required of board-approved programs for in-person clinical experiences. The program pays a one-time fee of $100 to the board for each student who participates in clinical experience placements. And then the bill states that a student shall be supervised in person by a registered nurse licensed by the board while rendering nursing services. And then lastly, the bill also states that a clinical agency or facility shall not schedule a clinical experience placement with an out-of-state private post-secondary educational institution if the placement is needed to fulfill the clinical experience requirements of an in-state student enrolled in a board-approved nursing program. So as indicated in the analysis, this is somewhat of an updated version of a bill that the board took an oppose on last year, AB 1292. And some of the additional criteria and provisions have been added into this version around who would be eligible for this exemption. It looks like it's trying to narrow the scope a little bit. So they may have addressed some of the concerns that were raised last year around that kind of upfront oversight, but we still weren't sure if it was clear enough on if there would be any type of clinical displacement and how we would enforce that. Just some things to consider for your discussion.
So for clarification, this is a school that is primarily out of state.
Or
For
is out of state. It
is
that's
out
the
of state.
right.
And they are looking to have their California enrollees do their clinicals here versus out of state where they are located.
So this is primarily like distance learning based. So yeah, so I'm sure they have like a physical location somewhere, but I think the business model is that the students are everywhere. So it wouldn't be that all the students are normally in one state and then there's some, it's the students are in various states, but you're correct. This is a non-California based program whose students live in California and are enrolled because it is distance education setup.
My concern would be the lack of clinical space right off. My other concern is that I don't know why they're offering to pay $100 to the board for each student. Sounds like a bribe to me. But my largest concern is that we're having impaction from clinical space here in California for our pre-licensure schools that are here in California. But I'm willing to listen to the board and Board Member Vicky Granowitz.
Thank you. I also think it's a slippery slope. I think it'll be hard to document what's happening, and I am not in favor of supporting this bill. I think it has lots of room for manipulation. So I would vote against it.
Board Member Tricia Nguyen.
Thank you very much. I also agree with the comments previously made. It would be very hard for us to kind of count how many students are coming in, except by just following the $100 bills. We don't know where they would be landing. Would they be landing in Los Angeles that's highly, impacted, or would they be in Reading? It would be very hard for us to watch that. So for that reason, I would oppose this bill.
Just to add some just additional clarification onto that, because we don't approve these schools and they're out-of-state schools, they're not our approved schools, we don't know their enrollment. We don't know the number of students that are from California, and we would have to rely on them self-reporting as well. So it would be that self-reporting, and it would also, there is not a requirement in the bill in the current language that says we would then know where they're doing the clinicals at. So it is self-reporting on a number of students essentially based on the fee that would be submitted, and no additional information. So from an implementation standpoint, this bill is not even in a state that can be appropriately implemented as written.
Any other questions or comments from the board?
Just a question.
Sorry, go for it, Mary, and then I have one.
Yeah, is this for pre-licensure programs or is it graduate? We already do it for graduate programs, right?
This one is pre-licensure programs. Yes, right now, the only way that our pre-licensure nursing program students are able to go into clinicals is under the provisions of Business Professions Code 2729, where it specifically says that in order to provide the nursing services, they have to be enrolled in a board-approved program. And that is why that section was chosen to be amended to allow for this. Our out-of-state post-licensure programs are allowed to do clinicals in-state because the student that is here in state is already a licensed RN. And the way that that is managed is through a different regulatory process that we have underneath the nurse practitioners, and there's a specific regulatory process that talks about nurse practitioner out-of-state programs. And we do know that that is impacted as well, and we know that that is an issue that needed to be managed and addressed, but that's a whole separate process outside of pre-licensure.
Yeah, for pre-licensure, I totally agree to oppose.
Yeah. One thing I did want to point out is that we do have a provision in our law under Business Professions 2786 3 that 3A, and it says the board shall annually collect, analyze, and report information related to the number of clinical placement slots that are available and the location of those clinical placement slots within the state, including but not limited to information concerning the total number of placement slots a clinical facility can accommodate and how many slots that the programs that use the facility will need. It then talks about utilizing that data, putting it in a database, and then placing that report on the internet website. That section of our statute would be impossible to carry out if this bill were to pass and become in law. So again, the overall process here, and I understand that you guys just on the intent and such of the bill are in opposition, but I need to stress how many issues it is to implement this if it were to go through. And right now, Marissa, it has passed out of the first house as well as appropriations. And so there is just one house that it does have to clear. And there's been no documentation of opposition at this point from anybody. And that is quite concerning.
Any other questions or comments from board members? I would like to make a motion that the board oppose this piece of legislation?
I'll second that, Mary.
Thank you, Mary. BRN moderator, can we open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. We'll pause for a moment for members of the public to type in, "I would like to make a comment." Carmen Comsty would like to make a comment. 1 second, please.
Regulatory policy specialist with the California Nurses Association. Like the board last year, CNA opposed the previous version of this bill, and we continue to have concerns about the bill, despite the amendments that were made by the bill's sponsors. And I just want to reiterate and underscore and agree with the concerns that the board members have just raised about this bill, and the ongoing concerns about out-of-state distance learning programs exacerbating the problems of clinical impaction in California, and the inability of the board to be able to reach and address some of the issues despite the amendments that were made to the previous versions of the bill. And we're looking forward to discussing more and working with the board with whatever position you may take today. Thanks.
Thank you for your comment. Blake Holiday would like to make a comment. 1 second, please. Blake, there you go.
Yes, hi. My name is Blake Halliday. I'm the Director of Regulatory and Legislative Strategy for Nightingale Education Group. We're the sponsors behind this bill, and wanted to thank the board for discussing the bill today. We do hear your concerns. Many of the amendments we put into the bill were to address some of the concerns last year. So I just want to remind folks of those amendments that we put into the bill. Specifically regarding the fee, I know there was a concern about that fee. That fee was put in to help mitigate the costs for the fiscal note that was presented by the board. There might be some budgetary concerns there, so the fee was put in to help mediate any of those costs. These are California residents who are leaving the state every semester, who have to do their clinical resident or clinical rotations somewhere else in the country. That presents lots of problems for California. These folks are educated in non-California healthcare institutions. That's against what we want for Californians. We want Californians to be comfortable with the California healthcare system, and there are thousands of these students who have to leave the state in order to complete their clinical rotations. The bill does have prohibitions built in to take care of the concerns about clinical placement space. We understand that concern. We operate in many, many states across the country, and everybody is impacted on a clinical side. So just a reminder that this bill does have language built in that the student placement does not impact any students already assigned to the agency or the facility. A clinical agency or facility shall not offer clinical experience placements to an out-of-state private post-secondary educational institution if the placements are needed to fulfill the clinical experience requirements of an in-state student enrolled in a board-approved nursing program. So basically what that means is, at the end of the day, if there is no space in a California facility, then it's business as usual, and these learners will continue to travel out of state. So we do understand the impacted nature of clinical placements across the country. This is an attempt for these California folks to stay home in California that are enrolling in not just our program, but in other distance education programs across the country, because those distance education programs meet their lifestyle needs. This is an opportunity for them to be educated in the communities where they are going to eventually work. Thank you very much for your time.
Thank you.
To provide some clarification for board members on that, they are in-state California residents. They are students that I'm sure would like to do clinicals in our state, and we definitely hear that. And that is a priority to kind of take that into concern. What I do want to share is that there is a federal regulation. It's 34 CFR 668.43. And that's a law that the federal government under the DOE put into place that requires these schools to have the upfront conversation with the students before they enroll, to let them know what travel cost would be, what housing costs would be, whether or not their schools would meet the criteria for licensure in their home state. And so there should be, at the entry into the program, a very robust discussion with the academic advisors or admission representatives, so that the student enrolling in an out-of-state program clearly understands at enrollment what is going to be required of them to complete their education, including out-of-state clinicals, because at this point, it is not allowable within our law that an out-of-state nursing program could do clinicals here. The other thing that would really is key to address, outside of really understanding that the student has some real desire to have their clinicals here, is I'm trying to find my words for this. I apologize for that, is jurisdiction, right? So we as a board do not have any jurisdiction over our healthcare agencies, healthcare facilities, anything. So if a healthcare facility were to give a clinical placement to one person that maybe is their employee or something that is enrolled in out-of-state school, we have no way of addressing that to either the out-of-state program, because it's not under our approval, or even to the healthcare facility if that were to occur. Additionally, as I'm sure you guys are aware, in our prior ELC communications, where we do have healthcare facilities that have signed saying we're not going to displace. And then we do hear from our academic partners that they have been displaced. So those are all things that I think need to be ironed out and addressed first before a bill like this could be considered. So I understand the desire of the student and the desire of the academic institution to allow for them to do clinicals in our state and allow for those students to be able to participate in clinical experiences here in our state where they want to work and live. I don't know that as a board that we've addressed all the issues here that are affecting our in-state schools in a manner that is sufficient enough to allow for that additional layer to be added on. And so that is definitely something I wanted to bring forward, so that you guys had that kind of upfront knowledge. And my very last point that was pointed out through the UCSF survey that we put out is we have many programs that have a board-approved enrollment number higher than what they're taking in. And they're choosing to decrease their number of students being enrolled because they cannot support them resource-wise. And that includes faculty, as well as clinical placements. And Joanne Spetz did a presentation in front of our board, I believe a year ago, sharing out that information. And she said that through the next report that they are collecting data on, they want to ask more on that to find out why and how much exactly our programs are choosing to decrease their enrollment, because they can't get our own in-state programs at the capacity that they're approved to by the board to be able to enroll and complete.
Thank you, Lori.
There might be more public comment.
Is there anyone else?
Yes.
Okay, thank you.
Kathy Hughes would like to make a comment. 1 second, please.
Hi, this is Kathy Hughes again, the Executive Director of the Nurse Alliance of SEIU California. We represent about 30,000 registered nurses across the state. SEIU has not taken an official position on this bill, but we have historically opposed bills of this nature for the reasons that have been stated. The BRN doesn't have authority to approve the curriculum. We have no idea what the clinical impaction will be. We know that clinical impaction by private schools. They're bumping our public schools. It has happened. It continues to happen. It is a problem for our state and our state schools, our public schools. So I will be taking it to State Council, to SEIU California, with the recommendation that the Nurse Alliance recommends an opposed to this bill. Thank you.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Do we have any public requests for comments there in BRNHQ?
No public requests for comments here in HQ.
Thank you. Would you like me to close this window?
Yes, please. Thank you. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Dominguez, yes.
Board Member Tricia Nguyen.
Nguyen, yes.
Board Member David Lawler.
Lawler, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Neela Patel.
Patel, yes.
Board Member Allison Cormack.
Cormac, yes.
Thank you.
Thank you. So the third bill that impacts our NPA, and I did want to quickly note, there is one other bill on the agenda that had some proposed changes to the NPA, AB 2526. That was actually held in the Appropriations Committee last week. So it's no longer moving forward. So we weren't going to discuss it today anyways, but I did just want to flag because that was another bill that had some language that directly impacted our code. Okay, so the last one that impacts the Nurse Practice Act is SB 1451 by Senator Ashby. And this is a bit of a omnibus kind of policy bill. It was put forward by the Senate Business and Professions Economic Development Committee. So it proposes changes to a variety of boards and bureaus under kind of the DCA umbrella. But obviously today I'll be focusing on the changes that would impact the Board of Registered Nursing or our licensees. The changes are kind of technical and they address, most of them address implementation of AB 890 that I know some of the members were here for, but not all the members were here for it. So I do want to make sure that everyone has the information they need. So rather than go through the entire bill at once, I'm going to go kind of section by section, if that's okay, just to make sure that everyone is kind of on track and able to ask questions because it is kind of lengthy and technical. So just some quick background, AB 890 was signed into law in 2020, and it essentially established two new categories of nurse practitioners that can practice without standardized procedures. These new categories of NPs have been given somewhat informal nicknames, and they're based on the Business and Profession Code sections that establish them. So it's BPC 2837.103 and then .104, which is why you have the 103 NP and then the 104 NP as just kind of colloquial, kind of quick reference in case anyone was curious. So the 103 NP can work without standardized procedures in a group setting with at least one physician and surgeon within the population focus of their national certification. So that means that they don't have to have that direct supervision, but within that group setting they're working in, there has to be at least one physician and surgeon also involved in that setting. And then the second is a 104 NP, and they can work without standardized procedures outside of a group setting, also within the population focus of their national certification. So they can really work anywhere that they would like to work. That's more in line with independent practice. So to become a 103 NP, an applicant must have been certified by the board as a nurse practitioner, hold a national certification as a nurse practitioner, and have completed a 3-year or 4,600-hour transition to practice. Then after practicing as a 103 NP for 3 years in good standing, they would be eligible to apply for a 104 NP certification, which would allow them to practice outside of that group setting. So the first area the bill is proposing to make some changes to is the transition to practice section. AB 890 established an initial definition of transition to practice, and then also within the bill, it tasked the board with establishing standards for it. So this task was spearheaded by the board's Nurse Practitioner Advisory Committee, or NPAC, which was also actually established by that same bill. So the explanation of current law that I'm about to provide is a bit of a mixture of what was in statute along with what was developed by NPAC and the board and put together as what is in our regulations. So current regulations state a transition to practice is defined as 4,600 hours or 3 full-time equivalent years of clinical practice experience and mentorship that were completed in California, completed within 5 years prior to the date the applicant applies for certification as a 103 NP, completed after being certified by the board as a nurse practitioner, and then completed in direct patient care in the nurse practitioner category or specialty area, the applicant is seeking certification as a 103 NP. And just to clarify, when I reference a category or specialty area, I'm referencing the categories established under 16 CCR 1481. And there's 6 categories of nurse practitioners there. You have family individual across the lifespan, adult gerontology, neonatal, pediatrics, women's health and gender related, and then psychiatric mental health across the lifespan. So the regulations also require that the healthcare provider who attests that an NP has completed their 4,600 hours, that transition to practice period, that they would have to specialize in the same category or specialty area than the applicant, same specialty area as the applicant who is seeking certification as a 103 NP. So for this bill would establish some changes to that. It would propose that the transition to practice hours could occur in any state, so not just California. It would establish that the transition to practice hours cannot be limited to experience in a single category or specialty, so not necessarily limited to those 6 categories I mentioned. The bill would also establish that any clinical experience obtained before January 1, 2020 would count towards a transition to practice, so long as it was after the board was certified as an NP by the board. And then lastly, lastly on this topic, the bill would further establish that an NP has completed their transition to practice if they have been practicing for at least 3 years or 4,600 hours within the last 5 years as of January 1st, 2023. So the bill also proposes some changes to the attestation to the transition to practice. So under the current process is when an NP has completed their 4,600 or 3 years, there's an application they fill out where they kind of put in the hours they completed, the area they completed them, and then they have a healthcare provider attest to that completion. And so this portion, these changes are referring to that healthcare provider who's providing that attestation. So the bill states that a healthcare provider who attests to the completion of an NP's transition to practice hours is not required to specialize in the same category as the applicant. The bill states that a healthcare provider who tests to the completion of an NP's transition to practice hours is not required to verify the competence, clinical expertise, or any other standards related to the practice of the applicant and is only required to attest to the completion of the transition to practice hours. And lastly, the bill states that a healthcare provider who attests to an NP's transition to practice hours is not liable for any civil damages and is not subject to an administrative action, sanction, or penalty for attesting only to the completion of the transition to practice. So I'll stop there just with that portion on transition to practice to see if there's any questions or anything that I can provide clarity on.
Is there any amendments to that part?
I have a question. Is the transition to practice only from standard NP to a 103? Or are we talking about 103 to 104 as well?
The transition to practice, that term, the 4,600 hours, is to go from a standard to a 103. And then to go from a 103 to a 104, there's another 3-year 4,600 hour period. But the law states that it's not inclusive of that transition to practice.
Okay, because the piece of what you said that concerned me the most was that someone could do their clinical hours, say, for instance, in pediatrics, and then apply to be a 103 in adult gerontology population. But this would mean that a group would need to hire that person into that. Is that correct? Because they need to be practicing in a group setting, right?
No, I'll provide some additional clarification. The NP that graduates or is first initially licensed in California today does so, they practice under standardized procedures. Those standardized procedures are facility specific. In order to move into not utilizing standardized procedures and work in a group setting without those standardized procedures, which is the role of the 103 NP, you have to complete a transition to practice that is 4,600 hours or 3 years. And there were some specifics that were put into that transitional practice by the writing and passing of AB 890, as well as some recommendations from listening to our NPAC, as well as stakeholder meetings. That is the part that's being addressed here. It's that while they're working under standardized procedures, that is when that transition to practice is completed. So they could, in the new language, complete a transition to practice in peds, have a national certification in adult geri, and then be utilized in a group setting without standardized procedures, irrespective of their national certification and their specific specialty area of education.
They couldn't get a national certification in adult geri without any adult geri experience.
Yes, but they can now, if this bill goes through, they can have a national certification in adult gero, have education in adult gero, but they can then practice without standardized procedures in pediatrics.
Okay, but they would need to be hired into a group setting. So somebody would need to be willing to bring them into their group with that knowledge.
Correct.
Okay, that worries me a little less because they know what they're taking on and they need to train them.
Correct.
Okay, thanks.
And Alice, Board Member Cormack.
So I guess that answers my question, which was on page 34 about the attestation of the completion not required to specialize in the same category, that's linked to the same situation. Okay, thank you.
Thank you. So just kind of some background as you guys are considering this section where you're looking at kind of formulating your opinion. The transition to practice, when this was first brought to us in AB 890, was for the board to put into regulation what that transition to practice was. And we were giving some guidelines in AB 890 that basically was not to make it overly burdensome and to just kind of define that. And I truly believe our NPAC did an amazing job with that. They took that feedback. The NPAC, just for public to be aware, is made up of 2 physicians, 4 NPs, and a public member. And so they worked on this in subcommittees, came back to the practice committee, the nurse practitioner advisory committee, and then it went to practice committee and the board, and everybody kind of heard this regulatory package, went out to public comment, et cetera, and was approved all the way through. I think what's in front of us right now is kind of more towards what our board has always been striving for. And our board has been really, if you go back and listen to as AB 890 was being moved through the legislative session, was nurse practitioners should have an independent practice. And that should be something that is granted to them on licensure, and that independent practice, as long as it's within their scope of education, their scope of clinical practice, et cetera, that should be the golden standard. And through the 103 and then ultimately into the 104, that nurse practitioner now has a pathway to get there. The 103 transition to practice, the intention of that throughout that entire process, working with the nurse practitioner advisory committee, working with our board and stuff, was to really follow the letter of the law as much as we can. And there was some language in there that made that kind of difficult. Further discussion was whether or not the legacy or retired national certification could be used. That was something our board was in support of. But there was language that was prohibitive of that said we had to evaluate a current exam and then evaluate that ongoing. We cannot do that with a retired or legacy certification because that exam doesn't exist. Now, this bill addresses that, pulls that out. So all legacy and retired national certification holders would be able to transition to the 103 status. And that's definitely in line with what our board has wanted. The requirement when they're pulling that, saying that this can now be completed out of California. That's fantastic because in the law, it said the transition practice must be completed in California when AB 890 was passed. And so we were limited by requiring you to, even if you were 20 years licensed in another state practicing independent, in order to get to that independent practice here, you had to come back into California and redo a transition practice. So I think this bill definitely addresses some of those areas that we found as the board when we were looking at implementing this and creating the transition to practice were noticed to be directly kind of a barrier for that. The one thing that I do want to kind of bring to the board's attention is when I'm looking at this now for implementation. The way that it's written right now, I can't see right now, and obviously this is early in and we don't have final language or anything, how we can implement this going into a 103 certification. And when I remember going back and I was reviewing some of the language and some of the presentations that were put on by the advanced practice advisory committee that we had at our board when this was first passed. And they talked about this being kind of an automatic thing that occurred at 3 years in, and that it wasn't a certification process that came in through the board. And in fact, there was no fee assigned to the 103. And that we've created as a 103, sorry. There was no fee assigned to completing the transition to practice. There was nothing that was turned into the board that needed to be done to vet that. And so I think this kind of more closely aligns that, but the issue that it now comes in front of me is like, if this passes, how do I implement this? And that might be something that the board considers, is that maybe at this point that we don't kind of shoulder that responsibility of vetting or verifying that these transition to practice is completed, but put that more on, as Mary had mentioned, that it's up to the person that's hiring, right? Because if I don't have, and I say I as the EO, not me particular, but as the BRN, if we don't have the ability to hold somebody accountable on an attestation, then why have an attestation? If we don't have to have the transition to practice be completed in California and it could be completed elsewhere, how am I to vet that? Employment records, W-2s, a letter from somebody that we don't know and can't verify that this was actually from a legit person that was there. So those are some of the questions that come to my mind. And I don't have those answers. That's why I'm saying, you know, how do we do this? And then if you're looking at accepting hours that are not necessarily within your specialty that you were educated on and that you hold your national certification, then what are we verifying hours for? And that was some of the conversation that happened in NPAC, where when they were developing this, is that if your practice is in alignment with your education, your clinical experience, and your national certification, then we should vet that those hours all line up. And that's what we did based on their recommendations. And so it may be of benefit to retire a 103 and not have a 103 as an option for our RNs, for our nurse practitioners, and have them have an independent practice, either on licensure or sorry, I'll correct that, because this law does require national certification. We do not require national certification for licensure. So it would be on hire of a group setting that they verify that they've been practicing 3 years and have a national certification, and then they can employ them without standardized procedures and have them practice with a physician or surgeon. That to me really kind of opens that up. And I can't say that I know how that would work out, but I mean, I know that our ultimate goal that our board has put out previously is independent practice for our nurse practitioners. And if we're looking at this from our standpoint of public protection, there's not something that we're vetting or managing that is now public protection at this point. At this point is, did you complete 4,600 hours? Yes, no. And they move forward. And I understand that. And I'm not saying that that's something that's incorrect, but I'm looking at how can this be utilized in our current role. And I don't see that we serve a role or a purpose in here at this point, if those sections are removed and adjusted. And I think it ultimately comes more in alignment to that independent practice that we all want for our nurse practitioners.
So Lori, would you say that probably if we support and have amendments, rather than us as a board or as the Board of Nursing, put the implementation onto the employer? I'm trying to understand this a little more.
So as Mary put out there, which really just kind of sparked this kind of thought process in my head right now, is it's up to the employer to hire them, right? And so if they're doing their transition to practice in an area that they're not educated and trained in, and we do know that this occurs, I can tell you as a practice manager of an office with a physician and nurse practitioners and PAs in my prior life, I had a nurse practitioner that was a pediatric nurse practitioner. She did not practice as a pediatric nurse practitioner. And what she did was practice in this facility that I worked in, which was adult GI. And so she was educated and licensed as a pediatric nurse practitioner, but was very competent and working and employed as an adult GI nurse practitioner. And so it does happen out there, and people do get hired in those and utilize them, and they're very competent in all these various ways. And so that, as Mary put, is an employment aspect, and we do not get involved in employment. We also do not get involved in specific competencies. That's done at the employers with policies and procedures and onboarding and sign-off sheets, et cetera. And we don't. We establish safe entry into practice. And that may be where we need to kind of have some amends where we support this, we understand what you're trying to do, we need that access to care, we want the nurse practitioners in the rural settings, we want them to practice to their full scope of practice. And it might be at that point that the 103 part is, if you put BRN into that's a barrier. And maybe we just need to remove BRN out of that so that they can manage that outside of us. And then we look at it from the original language, which is the board comes in at the 104. That is where the fee was established. That's where the certification was mentioned in AB 890. And that's where we live, is kind of just rolling it back to that initial kind of interpretation that was presented to our board by the APRN committee and I believe it was at that point, the president of California Nurse Practitioner Association. And that was how they had interpreted it. And that might be where we need to land.
Thank you, Lori. So I just want to clarify, if we were to support, excuse me, with amendment, would part of that amendment be facilitating, with the goal of facilitating independent practice for our NPs, doing away with the 103, hiring, the employer would hire without standardized procedures?
That's what currently happens
Yeah.
right now. So if that person has a 103, the employer of these specific group settings that are already outlined in law that are not being adjusted can employ that person and work them without standardized procedures. And just for the public to understand what standardized procedures are, there's a separate regulation that outlines 11 specific areas that are needed to make up a standardized procedure. And that is kind of a contractual or policy procedure kind of document that is utilized by a licensed healthcare facility, a physician, as well as the nurse practitioner. And the three entities come together and make this up, and they describe competency. They describe entry into that. They describe exactly what can be done. They describe what the review process is, what the oversight process is, et cetera. And it's very detailed. When the person right now, as a 103 does, is they can work in a group setting without that specific kind of contract policy procedure known as standardized procedures that we have in our regs. And so they're able to do all of that with whatever that facility has on policy and procedure, and they follow that. And so that would maintain, that doesn't change. That's what it is. What they would not have is a 103 certification through us, because removing all of those it really kind of begs to have that conversation about what are we vetting and how are we vetting it? And what could we do to even vet that would be of service? Because getting an attestation from an out-of-state provider that we can't verify license, we don't know anything about signatures, we don't have any authority over their license or anything, and then removing any ability to address that here really guys kind of says, okay, what is our public protection? And if we're not requiring them to be in their same specialty that they were educated, trained, and nationally certified in, then they can truly get that experience through many different means, including continuing education, including coursework, et cetera.
Thank you, Lori. Any questions or comments from the board? No?
And before a motion's made, there's more to this bill. Yeah, I just want to make sure that that's
I
not
just wanted
missed,
to ask
but just
if
so we
there
can-
was questions right now where we're at. Okay, thanks.
No problem. Okay, so just a couple more sections, but the next is legacy certifications. So current law, and Lori touched on this a little bit, current law requires a 103 NP applicant to have passed a National Nurse Practitioner Board certification examination and, if applicable, any supplemental examination developed by the Department of Consumer Affairs Office of Professional Examination, so OPES as we refer to it. Current law also requires OPES to perform an occupational analysis of nurse practitioners performing the functions of a 103 NP as is outlined in AB 890. And then current law also requires the board and OPES to assess the alignment of the competencies tested in the National Nurse Practitioner Certification Examination with the occupational analysis referenced above. The law goes on to state that if the assessment identifies there are additional competencies needed to perform the functions of a 103 NP as outlined in AB 890, and those competencies are not sufficiently validated by the National Nurse Practitioner Board certification examinations, then the board must develop a supplemental exam that properly validates identified competencies. So as she was kind of mentioned, the problem arose with the national certifications that have been retired since those no longer have an active national certification exam. And so at the time OPS did its occupational analysis, they were not able to compare the occupational analysis with the competencies tested in the certification exam for those retired legacies because they no longer were active. And so, like she said, this led to a significant number of NPs who may have been practicing for a very long time, still are practicing because those certifications allow you to continue practicing. You can continue to renew them. You just can't newly obtain them, which is why there's not an active examination. So they've been practicing for a significant period of time, but were ineligible to apply for a 103 NP because the exam they took that would have been that comparison for the occupational analysis didn't exist. So a bit of a technical kind of hiccup there. And so this bill is attempting to address that. It would add language exempting National Nurse Practitioner certification examinations that were discontinued before January 1, 2017 from the requirement to assess the alignment of the competencies tested by the national certification and the results of the occupational analysis. Any questions on that section?
This is Board Member Cormack. Does the Office of Professional Examination Services already exist, or is it created in this bill? Okay, I couldn't really find it on the website. Okay, thank you.
It's a sub-office of the Department of Consumer
Under
Affairs.
Department of Consumer Affairs. Yes.
No, there. Good stuff. Okay. Next, we have notice to consumers. So current law requires nurse practitioners to verbally inform all new patients in a language understandable to the patient that a nurse practitioner is not a physician and surgeon. And for the purposes of Spanish language speakers, the nurse practitioner shall use the standardized phrases enfermera especializada or enfermero especializado. Regulations also require NPs to advise patients that they have the right to see a physician and surgeon on request and the circumstances under which they must be referred to see a physician and surgeon. So this bill would also make some changes to that section. It would strike the verbal portion of the requirement for NPs to advise their patients that a nurse practitioner is not a physician and surgeon, and that is in statute. And the bill would also strike the provision requiring the use of a standardized phrase for Spanish speakers. This did come from a lot of input from communities saying that the translation in there may or may not be an accurate one when applied in all circumstances. So it could lead to more confusion than clarity in some instances. So having that standardized phrase may not be ideal. And then lastly, the bill would establish that an NP shall not be required to tell a patient that the patient has a right to see a physician and surgeon. And that is something that was added by the board through the regulations based on some input we received through the regulatory development process as well. So happy to answer any questions on that.
Yeah, so that was a very lively discussion in multiple different formats on specific stakeholder groups mentioning that in Hispanic culture, there's not a nurse practitioner, that doesn't exist. And so it would be very confusing to patients to seek service from a nurse practitioner when they only really knew what a physician was. And so that language that was put in there specifying the translated term was something that was in law, and we weren't able to address that. So that had to be carried over. We did do the male female version of that to kind of address that and make it a little more broad. But the specific terminology where they had to state verbally that they could see a physician and surgeon, and these are the criteria why, that is outside of what was written in AB 890. That was something that was supported through the Nurse Practitioner Advisory Committee as well as our board because of the extensive stakeholder feedback on that. But we do also understand when meeting with the nurse practitioner organizations afterwards, they were like, you know, what happens if I'm right here right now and I'm taking care of the patient and they need to be seen? And I'm like, well, you have a right to see a physician. And they go, okay, I want that. And then there's not a physician available. Then do I not treat anymore? And so we can definitely see that kind of consequence. And I'm glad that it's being addressed this way.
Thank you, Lori. Any questions or comments from the board? No? Okay,
There's a final section.
yeah.
Alrighty, so this is the last section, and this actually is impacting the Medical Practice Act. So this is the authorizing law for the medical board. The reason we're mentioning it is because it does potentially have some impact to our licensees as well. So current law says the Medical Practice Act currently prohibits any person from practicing or advertising as practicing medicine without a license. Statute specifically makes it a misdemeanor for any unlicensed person to use the words doctor or physician, the letters or prefix doctor or the initials MD, or any other terms or letters indicating or implying that the person is a licensed physician and surgeon on any sign, business card, or letterhead, or in an advertisement. So what this bill would further prohibit a non-physician and surgeon from using the words doctor or physician, the letters or prefix DR and the initials MD or DO, or any other terms or letters indicating or implying that the person is a physician and surgeon, physician, surgeon, or practitioner in a healthcare setting that would lead a responsible patient to determine that person is a licensed MD or DO. And the reason we mentioned it could potentially have some impact on our licensees, because we do have some nurse practitioners or other, not just nurse, advanced practice registered nurses, excuse me, who have doctorate education. And so sometimes they will use the term doctor as part of recognizing the education. So potentially within a healthcare setting, if this were to pass, that could add some prohibitions there. Happy to answer any questions.
One thing I do want to make sure that's very clear is it doesn't prohibit the RN from putting down their degree. So you could still be Jane Doe RN PhD, Jane Doe RN DNP. So it doesn't prohibit the recognition of that academic accomplishment.
Board Member
Patel.
Neelu Patel.
Thank you. I have a bit of an issue here. It seems like this is an overlap of AB 765 that was not passed and about using the term doctor. I myself have a doctoral degree, and sometimes I do identify myself, or my students identify me as Dr. Patel in the clinical setting. I always correct them and say I'm Neelu because I don't like to use that term in the clinical setting. But when I'm teaching, that's what they know me as. And then I would really like to see language here saying that as long as they specify their specialty, so like as long as, for instance, I indicate Dr. Patel, certified registered nurse anesthetist, or a nurse practitioner, that would be beneficial, because to not recognize somebody's education, going the extra mile. I just feel as though this is a blanket statement, right? And also there's many other doctors out there, doctor of osteopathic medicine, doctor of naturopathic medicine, podiatry, optometrists, they all refer to themselves as doctor. So I think this would be really limiting and just really pointing out to nurses only this particular issue, so.
Board Member Tricia Nguyen.
I completely agree with Dr. Patel. I mean, that it's, I think we really need to recognize if it's a terminal degree and you've earned a doctorate, I don't think you should be precluded from using it. I also don't think there should be misrepresentation in the workplace, but this seems overly broad.
I think it was also mostly a cultural issue. We spoke of Hispanic, in the Hispanic culture. If you mention doctor, they're going to think you're a doctor. And so that explanation would have to be made.
Yeah, this was a very controversial subject last year as well. And there was some legal action and stuff within our board against us, and us, of course, taking action on other individuals that did not appropriately identify themselves and such. So it is a heated discussion, but looking at it from the public perspective, there was several podcasts, there was several comments and stuff that if you're in a healthcare setting and you do refer to yourself as doctor, that people may not understand the difference of that. And when we were kind of going around and having conversations around that, I pointed out to our business professions code for midwives as well as for nurse practitioners that require you to identify yourself as an advanced practice RN and specific to your role. Midwives actually include a statement in their chart where they sign a consent saying, I know that you're a nurse midwife underneath the BRN board, and that, and that becomes a permanent part of the record. When we were meeting with various healthcare employers, when we were looking at the 103 and the 104, and that statement and acknowledgement, stuff where you had to put out that you were a nurse practitioner, came out, and they were like, and how do we implement that? And they were saying, can we add that to the chart? Can we do that? And absolutely, you can do that. It's making sure that your patients are very aware that you are a nurse practitioner and not a medical doctor. And there was a lot of discussion around thinking that that was sufficient for the nurse midwife and the nurse practitioner. What we don't have, again, is regulation for clinical nurse specialists as well as our certified registered nurse anesthetist. And that regulation doesn't address identifying yourself as your specialty, et cetera, and because there is not regulation, it doesn't address it to the extent that the midwife and the nurse practitioner has. And so I do want to recognize that they did clarify more from last year to this year and limit it to the healthcare specific arena. But Neil, you're absolutely correct. We have many, many nurses in academia, pre-licensure as well as post-licensure academia, who would be allowed to utilize that doctor in their title as their teaching theory. And then they move to a clinical setting, and now that is confusing because their students would be calling them Dr. Patel, and then you're now in a clinical setting and you're doing hands-on care, and now they can't call you Dr. Patel because that is confusing, and there could be an issue that comes up at that point where then if you were to continue to utilize that in a clinical setting, which is now in a healthcare setting, that you could be penalized. And that would definitely be something that should be looked at.
Thank you. That is my big concern because I'll be getting misdemeanors left and right if that's the case. The other issue I wanted to bring up, since you brought it up with the other advanced practice specialties, I feel like this is going to be a slippery slope, and it's going to, go towards all the other three advanced practice specialties too, if we allow this here.
It will, and as we kind of talked yesterday in nurse anesthetist scope, that a terminal or doctoral degree is going to be required for entry into practice. That's additionally what's going to be happening with nurse practitioners, where the NOMF put out by 2025 they plan to have the doctoral level as the entry into practice for nurse practitioners. So we're going to have a lot of APRNs with terminal degrees, and that needs to be looked at. And I do know that there is some thought out there as well. So I just want to be devil's advocate and be very neutral here, that if you're acknowledging your degree as part of your title and your name, that you can do that without utilizing the term doctor. So it could be, and I don't know your credentials right off the top of my head, sorry, but it could be Neelu Patel, RN, CRNA, PhD, DNP, EDD, whatever you end up having, and you would still have recognition for that. So I know that that's also part of the conversation as well.
This is Reza. Just on that point of using the term doctor, something I thought I'd throw in there. A couple things actually. One, we hear, when this topic comes up, we hear from members of the public who comment that they, scrupulously ensure that their patients are well advised about their actual role and that, being clear that they're not a physician. And that's great. But we can say with 100% certainty that there are folks out there who abuse that confusion and the possibility of confusion and deliberately seek to portray themselves as a doctor when they're not. And so that's one thing. That's not to say that that's a cut and dried issue. It's, your point is well taken, Neelu, about allowing people the recognition that they've earned. The main thing I wanted to just throw in there, I find it interesting, is that there's a court case working its way through federal district court right now that keys in on that specific issue. It pits the medical board's ability to restrict use of that term doctor versus the practitioner's First Amendment right to identify themselves as such. That case is still pending. It's not going to go to trial for another year, but that is the issue in that case of whether the First Amendment plays into that restriction that the medical board currently has and all that. So, until that court case is resolved, it's not going to actually directly impact the legislation or our rules in any kind of binding way. But it's just interesting that that's at the very heart of a very big piece of litigation that's currently pending.
I have a
Thank you,
couple.
Rez.
Mary?
Is it? Yeah, I have serious concerns about this. And I know there's already a requirement that nurse practitioners introduce themselves and say, I am a nurse practitioner, especially if the degree that they earned, a doctoral degree, for any legislation to tell people they can't use the degree they earned, I think is very inappropriate. And another thing, I think one of the things, Lori, I think you mentioned this in that, and we were in the admin committee, that this would only be in the clinical setting, so in the educational setting or other settings, that people could still say, I'm doctor. I just realized, because when I saw the language, it's in the healthcare setting. So say in my instance, now, yeah, I have my PhD, so I wasn't working clinically, but if I'm, being introduced at a board meeting or whatever, I wouldn't be able to be called Dr. Fagan. And that has nothing to do with confusing me with a physician. So
Correct.
I think that's some serious issues that this really is a very slippery slope.
Go ahead, Neela.
And and to me, it seems a bit redundant because it's already in the Medical Practice Act that we can't identify or try to act as though we're a physician or surgeon. So I don't see the need for this to even exist.
Any other questions or comments? I would like to put a motion on the floor to support if amended. My amendments would be to retire the 103 designation. The second amendment, and I might need help with this one, is the exact wording where you can use your degree and be referred to as doctor as long as you explain, if questioned, what that doctorate is. I don't, Neela, would you suggest better wording than that? I'm sure you would.
Yes, something to the, along the lines of that person that has earned their terminal degree can express themselves with their title, but must specify their specialty. So
Yes.
Right.
Use their
nurse.
earned title, but must specify their specialty.
Can I ask one
Perfect.
thing to be clear on that? The way you originally phrased it was if the patient asks that they have to then provide clarification.
Mm-mm.
You're
No,
saying that it's
I'm-
in the first place, the responsibility of the nurse.
It would be the responsibility of the nurse. Yeah.
You know,
I think being forthcoming. Yeah. Yeah, we'll keep it that way. I think it's, it needs to be forthcoming from the nurse.
And Mary, did you have more to add?
just if we're gonna recommend that we don't have a 103, I think, and I don't know if it's the part of this legislation, but I think we should recommend changing the name of the 104 to NP/independent or something to make it more clear what it really is.
Correct. We actually do not have a specific name for an NP that practices as a 103 or 104. That's not in law, and that we don't uphold that. We actually designate the NP as an independent practitioner when they're at the 104 level. The community has adopted the 103 and the 104. And I think that if we remove the application for what is referred to as a 103, that will help to make that much more clear.
Great.
So we have a motion on the floor. Is there any other questions or comments? I could use a second.
Real quick, this is Reza. So I just want to, so removing the 103 designation is it's a big change relative to the structure that was kind of set out originally. I mean, you can leave it kind of at that, or you can specify more specifically how they go about backing that out. Because currently to get to a 104, you got to go through transition to practice, then become a 103, and then get to 104. So if you take out 103, that leaves the question of the pathway to 104, which again, you can in your motion be specific as to how you propose the legislator ought to do that, or you can just kind of leave it at a general level that your recommendation is it be amended, and just pull out the 103 and let them kind of sort out the particulars.
So just for some clarification real quick on the path to a 104, in our regs currently right now, it does say that you have to be certified as, and what we're calling it is a 103 NP. That's not the real language. And work as that for 3 years without any kind of incidents, anything coming negatively against your license. They could still work in that role as the 103, as what we now call 103, and they could still be required to not have an incidence. What they would not have is a certification from our board that acknowledges that they've obtained that initial 103. So again, that would be something that would be done through employment. But what we did get as the 104 with the original entry and the CANP's interpretation of AB 890 when it was first coming out was that we would do that certification for that independent so that we would have the standardized procedure NP or the NP that it's working kind of under standardized procedures, as well as those that could work without standardized procedures in a group setting. But that after they've been in a group setting for 3 years, then they would apply to us to get that independent practice. That still stands. So what we would have to address in regs is the removal of that certification by the BRN prior to entering into that.
Dolores, I'm very happy to second your motion, but I would love to hear your thoughts on, what Lori said. Should we kind of leave it general or should we be a little bit more specific?
General.
Okay. I second.
Thank you. Questions or comments from the board before we go out to public comment? No? BRN moderator, can you please take us out to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Scott Suko would like to make a comment. 1 second, please.
Scott Suko. I'm the executive director of the Liver Coalition based in San Diego, and I'm calling in support of SB 1451. The Liver Coalition was formed by medical specialists, transplant surgeons, patients, and caregivers to promote liver health and meet the needs of those affected by liver disease. We have NPs that serve on our Associate Medical Advisory Committee and further supported by Medical Advisory Committee. These professionals are vital to the delivery of care of those living with one or more of the 100 different liver diseases. We support SB 1451 because it will strengthen our state's primary care system and ensure patients with the most need can see a provider. NPs play an important role in the early detection of asymptomatic, life-threatening diseases such as non-alcoholic fatty liver disease. Early detection is a key aspect of primary care delivery, and we can improve lives and save lives. If more NPs are granted independent practice to the full extent of their abilities, as intended by AB 890. Thank you very much.
Thank you for your comment. Janina Tioko would like to make a comment. 1 second, please.
Comment. Thank
Go
you
ahead.
for being. Yeah, sorry, got distracted.
Sorry.
My question is pretty general. What role does current best evidence play in the legislative development? And my follow-up question is, how are new policies evaluated for effectiveness and safety? Thank you.
Thank you for your comment. Dr. Diane Nugent would like to make a comment. 1 second, please.
And thank you for your really robust discussion on this issue. My name is Diane Nugent. I'm the founder and president of the Center for Inherited Blood Disorders and co-founder of the Networking California for Adult Sickle Cell Care. I'm calling in for support of SB 1451. And particularly in the realm of sickle cell care, nurse practitioners play a critical role for us. They improve access to high quality, knowledgeable, and compassionate care, which hasn't always been the case for many of our Californians living with this disorder, particularly as we have an extreme shortage of hematologists in our state. Nurse practitioners, by my way of thinking, are essential in expanding access to comprehensive team-based multidisciplinary care, which is really game-changing for our patients living with sickle cell disease. So as a physician, I strongly support SB 1451, which will help close out our state's provider gap. And thank you again. It's been a very interesting 2 days. I've enjoyed the dialogue.
Thank you for your comment. Nancy Trego would like to make a comment. 1 second, please.
As you're continuing with public comment, I just want to make sure that it's on record that board member Vicki Granowitz has had to leave. So no longer part of the board members' discussion and voting.
Hello, good afternoon. Can you hear me?
Yes, ma'am.
I'm Nancy Trigo. I'm a geriatric nurse practitioner and one of the many legacy NPs here in California. I want to thank you for the opportunity to speak out on an important quality of care concern. and I'm asking for the board's support for SB 1450. But I'd like to thank EO Melby for her understanding and insight into the bill, and an amendment to vet the requirements for transition to practice for the 103 and putting that burden onto the shoulders of the employer makes total sense. But I'm asking for support for SB 1451 because it fixes the shortfalls of the OPES review of AB 890, for which I served as a clinical expert in the workshops, but subsequently was not eligible to be recognized as a 103 MP because of the literal analysis of the law regarding retired national certification exams, which unfortunately diminished the benefit and the scope of AB 890 by disallowing the legacy NPs to achieve 103 status. And this diminished the impact of the law, which was intended to increase access to care for our patients. And my patients are frail older adults in nursing homes, and they deserve nurse practitioners working in teams and practicing at their highest level of clinical expertise, delivering high quality and timely care. And thank you so much for your support on SB 1451.
Thank you for your comment. Ron Ordona would like to make a comment. 1 second, please.
And everyone, can you hear me?
Yes, sir.
My name is Ron Ordona. I'm a nurse practitioner. I do house call visits for homebound elderly patients in the Sacramento and surrounding counties. So I'm one of those who provide access to care for those who are not able to get out of the house and go to a regular medical office. I'm also a co-chair of the Health Policy and Practice Committee of the California Association for Nurse Practitioners, CANP, and we advocate for 35,000 more or less NPs in the state of California. We are in strong support of SB 1451 by Senator Ashby. This crucial bill is instrumental in facilitating the full and effective implementation of AB 890. SB 1451 is a beacon of hope for many of our NP colleagues who, like Nancy, has years of experience, but were not able to be recognized because of the legacy certifications being retired in 2017. SB 1451 clarifies also the experience requirements for transition to practice, including those NPs who have either had a break in their experience or practiced outside of California. There are about 28 states, as you know, that has full practice authority for nurse practitioners. And lastly, I would like to thank EO Melby for completely explaining what the legacy certification is about, as well as I shared Dr. Patel's dilemma. Like her, I also teach, and when my students go with me in clinical setting, it will be a dilemma for me as well. I have a DNP, and in the classroom, my students call me Dr. Ordona, and then of course they will potentially call me that in the health setting, which is a dilemma for some of us. Thank you very much and have a good day, everyone.
Thank you for your comment. Kathy Hughes would like to make a comment. 1 second, please.
Hi, this is Kathy Hughes, the Executive Director of the Nurse Alliance of SEIU California. We are very proud that we had a huge part and were very involved with AB 890 to ensure that our nurse practitioners that we represent were able to practice to the full scope of their licensure. And we are again proud to support SB 1451 as written. We believe that removing the requirement for the nurse practitioner to use the title Enfermera Especializada instead of a more culturally and grammatically correct title was the way to go. And we also want to recognize that we're providing clarifying guidance surrounding legacy certifications, and that this will help streamline the application process and enable California's nurse practitioners to expand access to quality, affordable care. And as a personal note, I live in Chico, California. It is considered a rural area. My primary care provider is a nurse practitioner, as many of my neighbors do the same, because we do have a shortage of physicians. So we would appreciate the support of this bill as written. Thank you so much.
Thank you for your comment. Malik King would like to make a comment. 1 second, please.
Hello?
Yes, go ahead, sir.
Excellent. First and foremost, thank you, board members, for all your continued work towards the greatest well-being for the most amount of people. I'm in support of SB 1450 and 1451. I think that as the culture gets used to the differentiation between nurse practitioners and doctors, just so there's no confusion, and the nurse that took the extra step to get the extra education, I think that the title doctor, nurse practitioner, or nurse practitioner doctor in a clinical or teaching session would help with that confusion. So if the teachers used to being called doctor, blah blah blah, if they're called doctor, nurse practitioner, blah blah blah, when they go to the clinical setting, the students will already be acclimated to calling them doctor, nurse practitioner. So that may help with the confusion, and vice versa. Thank you. Concluded.
Thank you. No problem. Sorry. Thank you for your comment. Carmen Comsty would like to make a comment. 1 second, please.
Good afternoon again. This is Carmen Comsty, Lead Regulatory Policy Specialist with the California Nurses Association. We wanted to thank the board for their discussion about SB 1451 today. CNA supports the sections of SB 1451 that relate to addressing the clarifications to the implementation of AB 890. And we know that it's important to make sure that issues related to legacy certification and the other issues related to implementation of 103 and 104 MPs is addressed. And we also appreciate the discussion about the use of the term doctor. CNA has not taken a position on that section, and we appreciate the board's current motion to address the varying portions of the bill. Thank you.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Do we have any public requests for comments there in BRNHQ?
We have no other requests for comments here in HQ.
Thank you. Would you like me to close this window?
Yes, thank you. They were one member less, but we still have quorum. So we're going to take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Fagan, yes.
Board Member Jovita Dominguez.
Dominguez, yes.
Board Member Patricia Nguyen.
Nguyen, yes.
Board Member David Lawler.
Lawler, yes.
Board Member Neela Patel.
Patel, yes.
And Board Member Allison Cormack.
Cormack, yes.
Thank you. I think this wraps up our.
Yes, so those were the three that impacted the Nurse Practice Act. Given the shortness of time, we wanted to prioritize those, but I did just want to make sure if members are okay with the remainders being moved to the next meeting to discuss, or if there's any you feel strongly that you wanted to bring up. Okay, just wanted to check. Thank you very much.
Thank you, Marissa.
Yep.
Okay. At this time, the board will go into closed session. And we will be coming back at the end of closed session to close out the meeting. There is no further items on the agenda now.
For open session. Additionally, the webcasting services will be terminated and we will no longer be offering those.
as closed session is not something that is recorded or shared out. So thank you very much.
Good evening, everyone. We are back from closed session in order to adjourn this meeting. Meeting is adjourned for Friday, May 24th, 2024. Everyone have a good holiday weekend. Thank you.
Be safe.